problem.
That MC will come.
Good morning and welcome to day 2 of FeFCon 2022. To take you through the scientific feast, I now welcome and invite Dr. Manjula and hand over this to her.
Good morning, everyone. And it's really a pleasure to see lots of people already joining in. And I know it's a very, very most sought after session. We've been doing this session continuously for the past 5 years and very popular session. And we are going to start without wasting much time. I request Dr. Jagdish Channappa sir to take us through this session as a chairperson. Over to you, Dr. Channappa sir.
Thank you, Dr. Manjula, and welcome everybody for this wonderful session today morning, which Dr. Suresh Kumar has been doing for us for the last all FeFCons. It's a very, very important topic about how to use your antibiotics and when to use, what to use, how to use. And you know, Dr. Suresh Kumar needs no introduction to this group, but he is one of the most sought after ID specialists in Chennai and probably throughout the country, because I'm sure many people keep calling him for various doubts. And as he presented yesterday, many people from even Andhra Pradesh and Karnataka and Kerala will be calling him to clarify their doubts on infectious disease. He has got a number of achievements. I'm not going to go through for this thing because we have already gone through this yesterday, but he has got a specialized interest in all the exotic infectious diseases and their management in India. So I hand it over to Dr. Suresh Kumar.
Thank you, sir. Thanks for your kind words of introductions. Good morning. I need a couple of acknowledgements I need to do. First of all, I thank the FeFCon organizing team. Keep on having faith in me in last 3 to 4 years for conducting this morning breakfast sessions. I need to thank the FeFCon organizing team as well as the advisory board members for giving this enormous responsibility. One, and I need to thank Microlabs for providing this opportunity. Third thing I really missed today, my co-participant, Dr. Bhaskar Shanai sir, he made this even more participant, more successful. Unfortunately, I missed him. So he put double the responsibility on me. Usually 50-50 will take the responsibility. Today, he put my 100% responsibility on me. So I need to sincerely acknowledge Dr. Bhaskar Shanai sir for making this even more successful there. With these words of introductions, I'll just start sharing my slides. I hope it will display without any hitch. I think it is displaying. It's in the...
Yes, sir.
Yes, sir, visible, correct.
Okay, thanks. Thank you. So I thank again the chairpersons for the kind words of introductions. Actually, I told Dr. Manjula to name it's no antibiotics. Always in English, KNOW and no antibiotics is always difficult thing. So antibiotics in OP is no to me. That's why I said no, NO, no antibiotics. But somewhat it went into KNOWO. So I made no or no antibiotics in OP. When to start, what to start, why not to start. This is my aim today. So disclosures, nothing. I don't have any disclosures pertaining to this talk. I'm clean on this. And one more disclosures, I am married. Because of married, I don't have money in my pocket. We deal with a lot of resistance and a lot of stuffed situations in our day-to-day practice that give a lot of confidence to manage any situations in our antibiotic selections and antibiotic pressure monitoring. I'll straight away open this poll to the participants. This is a poll question there. In which situations you will start antibiotic? I'll ask my organizing team to run the poll. This is a 10-year-old boy because my co-participant, Dr. Bhaskar Shanai, was not there. So I'll put one of the child case also here. 10-year-old male child, fever, sore throat, running nose, congested throat for the last 3 days. This is during the COVID time. Just now I think about it. 60-year-old female, diabetic, poorly controlled, urine routine showing plenty of pus cells, culture showed 10 to the power of 5 E. coli. 30-year-old male, diarrhea, 5 times watery and nausea of 2 days durations. 50-year-old female, bilateral leg swelling and redness. I'll show pictures subsequently during my presentations. And 20-year-old female planning root canal procedures. So I'll give the choices also. Only diabetic host need antibiotics, or diabetic plus 50 plus leg swelling need antibiotic. Except one, pediatric doesn't need antibiotics, so only adult need antibiotic. What do you think about it? Or all of the above? Always in multiple choice questions, the all of the above, none of the above is always tempting to you. So think about which one you want to go for it. Please go ahead and vote. I think the poll is running. Organizing team, correct?
Yes, sir.
Wait for 10 seconds. Yeah.
They have to use the chat box for poll?
No, they need to answer.
RX events. Yeah, RX events.
Ma'am, there is a poll button.
Okay.
So I'll wait for 10 more seconds or 15 more seconds for first question. Subsequently, once the first question is taken over, we need to check. So this is a first question. So I'm waiting for 10-15 seconds before start.
Somebody, can you give the instruction to the delegates where that poll button is so that they will use it? Yeah, it's clear. Yeah.
Okay. So the poll is running now.
Yes, sir.
Okay, good. But I do not know whether I'm going to see the response or only the audience will see the response. If we are able to see Dr. Manjula, you can update me the response. Okay. So far,
Yeah.
I'm asking my questions only there.
Sir, I can see only 2 is 25%, 2 and 4 is 75%, rest all 0%.
Okay.
Yeah.
So fine. So suppose if you want to start antibiotic, people who answered the poll, I want to start antibiotic for this scenario. For example, this 10-year-old male child, what antibiotic you would start? Amoxicillin or amoxiclav, or you want to start fluoroquinolone, Cipro or Cipro or macrolide in the form of Azithro or Clarithrol, or you want to start clindamycin, or you want to start cefuroxime or cephalexin. What do you want to start for 10-year-old child? And for a diabetic lady with urinary tract infections, which is your preferred choice? Cipro, Norflox, or you want to start cefuroxime, cephalexin, or amoxiclav? For a diarrhea, which one? Norflox plus tridazole or Ciplox plus tridazole, what do you want? And for a patients with bilateral leg swelling, what is your preferred antibiotic? So what is your preferred antibiotic? In other words, amoxicillin or norfloxacin or linezolid or cefuroxime, cephalosporins, which is your preferred antibiotic in OP settings? That is my question. So no antibiotic. What you are preferring it right now?
Poll has to come, please.
Very good. I'm able to see the situations now. Fine, good. Okay, the next questions, which antibiotic will you start? Antibiotics. Okay. I need to share my screen again. Okay, good. That's fine. No problem. I am comfortable with this one. Okay, sure. Okay, so people who answered why no antibiotic? Why no antibiotic? Most of the antibiotic, this is a third poll questions for you. Why you don't want antibiotic? Most of the OP infections will settle on its own. Most of the infections in OP are due to virus. Antibiotics causes a lot of side effects. That's why I don't want antibiotics. This is no antibiotic sessions. So we need not write antibiotic as a choice or I don't know. Which one you're preferring to go for it? Please go ahead and vote. Why no antibiotic? You're saying I don't want to write antibiotic, but usually this will happen in conference. But in real life scenario, this is not happening there. Conference people say I don't want antibiotic. At least you tell what is your reasons you don't want to start antibiotics. Most of the infections are settled on its own, or most of the infections are viral, or antibiotic has low side effects. Because you think it's viral, or because of the side effects, or because of the cost. Can I see the results, or can Dr. Manjula can read out?
No, can you open the poll? I am not seeing the poll. If you can see RX events. Can you open the poll, please?
After this question, a lot of time will be there, so people can take time there because I run 3 questions immediately. Then I want to go for a theory part.
Session. Yeah. RX event, can you put the third question poll? Or it is already done. Please show the results.
Why no antibiotics? That's my question there. Okay. Still, it's getting ready. I can move on the thing, and Dr. Manjula will update me afterwards there. So I move on my next thing. So we need to remember William Hostler quote. Suppose if we start some medications, always keep in mind the patient need to recover from 2 things. One, from the disease, what he suffer. The second thing, what the medications you are giving to the patients, he need to recover from the medications. Medications are all not safe. Whatever medicines you can call, whatever medicines is not safe. So always think 2 things. Whether the patient need to suffer from the disease and recover, or whether the patient recover from the disease and suffer from the medications what you prescribe and suffer from the medications and recover. If you keep this in mind, you don't write unnecessary antibiotics or unnecessary medications in your practice. That is the moral of the story for today's workshop. So my objective today, why no antibiotic sessions for FeFCon 2022. Then when to start, what to start, when not to start, and summarize at the end of the thing. So why we need this workshop? A couple of slides there. So this is good, interesting paper from JAMA 2016. 1 in 2 outpatients are getting antibiotics in OPD. Even though this is an US-based study, in the US it's 1 in 2, means in India, I think 2 in 2 for me. And respiratory tract infections is the leading cause of antibiotics. In India also, the respiratory tract infection is the leading cause of antibiotic. And most of the prescriptions were inappropriate. That is why we are conducting these sessions to make your antibiotic choice correct. And most of the time, we don't want antibiotics. People answer no antibiotics for most of the situations. But if I do OP antibiotic prescription audit, if I come and sit in your OPD and collect the prescriptions what you are giving, I started collecting a lot of antibiotics. For example, even during the time of COVID, people used azithromycin. In fact, healthcare personnel, you suffered COVID and you are taken azithromycin, doxycycline, ivermectin. So you are yourself taking a lot of antibiotics. This is a problem. So people want to take viral infections also, they want to write. They write viral fever, but below the viral fever, some antibiotic prescription is present. So this is called antibiotic audit. During the time of meeting, you say there is no need for antibiotic, but in real practice scenario, it is quite different. So we need to do a lot of audits for you people. And this is inpatient setting, even more worse. People start sending some cultures, reacting to the cultures. Whether the patient is having fever or not fever, this is one of the hospitals. The patient is absolutely not having fever, but keep on sending cultures. When the WBC count is high, when procalcitonin is very high, they keep on sending the cultures, keep on sending the procalcitonin based upon the WBC count, based upon the procalcitonin, based upon the culture result, wound swab, drain fluid, they start reacting the antibiotics. See the cost of the antibiotic, how much suffers. If you read the William Hostler, the patient should recover from the disease. Already the patient recovered. Unfortunately, because of your medication, is suffering now. People say dengue. For example, we did the audit for dengue patients who came to the OPD. Out of 180 hot patients in the dengue, most of the patients getting antibiotic. Most of the patients getting antibiotic. So this is a prescriptions for dengue. Before making a diagnosis, at least you say, I think the patient has got typhoid. I give an antibiotic, that's fine. But once you made the diagnosis of dengue and the serology report is also dengue, what is the point in writing antibiotics? But if you do the audit, people are using antibiotics for dengue patients, even after the diagnosis. So don't say, like, I don't write antibiotics. We are not believing a thing. Then what is a big deal? So what? If I write antibiotic, you'll ask, I write antibiotic. What is a big deal? If you see, this is the first case of antibiotic success shown in the literature. For example, this child presented with severe necrotizing fasciitis. All intervention tried before 1940. None of the interventions worked. Only penicillin came into the market, the child improved well. This gives confidence to the World War soldiers too. In World War I, there is no antibiotics, so people suffered and died. But during World War II, penicillin came into the market, go and fight. Whatever wound you are suffering, you are going to come back. So what gave the confidence? The industry started producing a lot of antibiotic between 1940s and 1970s. To be precise, 1942 to 1970, the life expectancy gone by 7 years. Life expectancy gone by 7 years. No other public interventions, no other public health interventions improved the life expectancy. For example, providing clean water, vaccines, not improved within a short span. Yes, they improved the life expectancy, but not within a 3 decades. That is more important. What happened? It gave a lot of confidence or overconfidence. The Surgeon General Stewart, he told US Assembly, we won the battle. We got vaccines for the diseases. We got infections, antibiotic for the infections. There is no need for further thing. By 2000, all viruses and bacteria have been eradicated. This is a statement he made in CDC in 1968. We need to search for this man, William Stewart, in the heaven and bring him and show the status what we suffered in 2020, 2021, and 2022. So this is a statement he made. So what happened? A lot of antibiotic they introduced in 70s, but after the famous quote from CDC in Central the chief surgeon to the CDC, people suffered. Antibiotic has not come into the market. At the same time, whatever antibiotic introduced, people start abusing the antibiotic or using the antibiotic. As a result, what happened? Bacteria start taking revenge on us. They start producing resistance mechanisms. The resistance mechanisms wash out whatever antibiotic is existing in policy. So almost all the antibiotics started developing resistance. So there is no antibiotic to treat at this point of time now. This is a backstory. So people say, where is the evidence? You are saying about antibiotics are resistant. Yes. So this is an antibiotic resistance scenario. This is a busy slide, but see the column when a patient has got colistin resistance bacteria. Colistin is an old antibiotic reintroduced in 2008 because there is no antibiotic. It is a nephrotoxic antibiotic. We introduced a nephrotoxic antibiotic in 2008. In 2015, what happened? The patients start developing colistin resistance bacteria. Once you got the resistant bacteria, you're not going back home. You're not going back home. All are expired, lost to follow. And a lot of English medias and Facebook journals start saying that Indian physician does not know or Indian pediatrician does not know how to treat infections. Because we are abusing antibiotics, we do not know the resistance mechanisms. And even in Pakistan, typhoid is resistant to ceftriaxone. We need to use carbapenem like imipenem, meropenem to treat typhoid. So this is a status we are also landing in. Don't think Pakistan only the situation is bad. Indian situation is also equally bad. Not only think about the antibiotic resistance and antibiotic death, but adverse events. Antibiotic, I told, that's why William Hoster told, think twice before writing some medications. The patient need to recover from the disease and recover from the medicines. Antibiotics are all causing adverse event. US has got very good data system because they got very good electronic health records. They tracked. Patient comes to the emergency department. Particularly, patient got discharged with antibiotic, came back to the emergency department. This is quite common. I'll show the other case scenario here. 28-year-old female, no comorbids, burning micturations and urgency, hematuria, but no fever. Lower abdominal pain is present, and on examination, tenderness is present over the suprapubic region. Urine routine showed plenty of pus cells. What antibiotic would you start now? Please go ahead and vote. I can run the show this time, hopefully. Organizers, please check. So last question they answered, why no antibiotic? I don't know. So people need to learn. That's why they're attending the workshop. Very good reason. That's a top reason there. Very good. So for these questions, please run the poll again. I need to share the questions and meantime run the poll. What antibiotic you would prefer for this young lady with urinary tract infection suspected because she got burning micturations, urgency, hematuria, and suprapubic tenderness? Can I see the poll results or poll is running?
So there are two answers only, 50% phosphomycin, 50%. Actually, there is a mistake in the poll RX event. The last option should have been no antibiotics till culture, but it is showing both phosphomycin. That's why it's coming 50-50.
Okay. So people given antibiotic choices means it's the best thing there. Fine.
Yeah, right, sir.
So you can stop the sharing. I can start sharing my screen.
Yes.
Yeah. Okay. So it's good. At least I can be able to feel what the audience is feeling. Hereafter, no need to show Dr. Manjula will help me out there so I can finish on time.
Okay. Right.
Okay. So this is the result. This is a urine culture report. Almost all the antibiotic is resistant except amikacin, that too intermediate. So this is not a cooked up situation. This is all real situations people are facing. This is a young female, no antibiotic exposure, no hospitalizations. Previously in 1990s and 2000, when a patient comes with urinary tract infections, start one dose of norfloxacin. They themselves go to the pharmacy, get one dose of norfloxacin, urinary tract infection subsided. But in 2021, 2022, even powerful antibiotic like meropenem, imipenem, colistin is not working. This is the same scenario for pediatricians also. They got a lot of antibiotic using, and even I got a discussions yesterday on pediatric urologist. He says 1.5-month-old child come for hydrohydronephrosis surgery. The child is having no symptoms, basically hydrohydronephrosis. So you want to do a neurological procedures. Before starting a neurological procedures, he did the urine cultures and urine routine. Urine routine showed pus cells and urine routine showing culture is growing E. coli 10 to the power of 5, resistant to everything. 1.5-month-old child, not even exposed to a lot of antibiotics. 1.5-month child, carbapenem resistance E. coli, carbapenem resistance Klebsiella. He's asking me, previously I used to give simple antibiotic like nitrofurantoin to take care of this one, but I'm now suffering. I don't have antibiotic to give prophylaxis. I'm worried whether I need to go ahead and operate or not. You need to plan for pyeloplasty and you need to plan stenting or something. And he says it's very difficult for me. I'm giving antibiotics. What antibiotics? I do not know. This is a status I'm living in. So this is a This is a real scenario. Don't think this is a cooked up scenario. This is a real scenario. People are facing it up. That is why we arrange the sessions of no antibiotics in your OPD setting. So why so much of antibiotic therapy? Why so much? People always think they need to treat infections immediately. If you don't treat infections, the infections will kill you. This is a myth, I can put it. Cultures are difficult to grow. If you ask, cultures will take 48 hours, difficult to grow, not growing all the time. And provider belief. Well, provider belief is a main reason because this was not taught in our undergraduations and post-graduations how to choose antibiotic. We just copied the prescriptions of my chief or my professor, what he used to write. He just copied. Why he chosen this antibiotic, I do not know. He didn't tell me what is a rational. In the examination, they didn't ask how to choose antibiotic in a case scenario. They want to find out mitral stenosis. They want to find out stroke, where is the lesions. But they didn't know where is the site of infections and what antibiotic. They didn't teach us during my undergraduations and post-graduations. Fear, always fear, because my practice is busy. I am missing something, just give antibiotic to cover whatever missing I'm thinking. Myth, anti-inflammatory. Why doxycycline in dengue? Anti-inflammatory. Why azithromycin in COVID? No data. They are getting better. I use these medications for the last patients. He improved like ritual. When a cricketer scores 100 with the whole bat, they want to see the sun and they want to use the same bat till the bat is broken. So they want to use the same bat. So this is a scenario people are using it. So basically the habits are difficult to change. Habits are difficult to change. The second most important thing, lack of knowledge. And third thing, lack of control or aggressive marketing, maybe, but fortunately, the organizers don't do aggressive marketing. They give freedom to talk as well as freedom to discuss anything. So this is another thing. Lack of knowledge and habits is most difficult. Particularly lack of knowledge. Is there evidence people asking? Yes. We put the paper. I told E. coli resistant to carbapenem in 2008. But people still do not know whether carbapenem is working. What is the resistance mechanisms? That's called NDM1. I asked Indian physicians what is NDM1. They're not aware. In 2012, we are repeating the same study in 2022. Whether they still know what is NDM1 or CRE, they are checking for it. So that's why we conducted one of the CME called No Antibiotics, dedicated antibiotic CME. Whatever antibiotics you are using in OPD, with all the experts we conducted in the month of August. Right now, the content is available. We can, if you want to learn more of antibiotics, need to learn this antibiotic sessions individually. It's going to upload it soon. So I'll come back to the workshop now. So I provided a background. Antibiotic abuse is common in OPD setting. Why? Lack of knowledge, or because of the peer pressures, or because of the other reasons. So we need to know antibiotics. For example, this is a case here. I think the organizers can run the show back, and once I finish this slide, Dr. Manjula can answer what is the answer for this one. 25-year-old female, sore throat, cough, fever. Fever is not great, 99.4 to 99.6, 3 days durations. On examination, the throat is congested, not a sick look. Chest is clear, few small cervical node. What antibiotic will start? Erythromycin, ofloxacin, ciprofloxacin, or amoxicillin clavulanic acid, cefuroxime, cefuroxime. What is your preferred antibiotic? Or you think, no, this is choice is missing, I'll write something. Please go ahead and vote so that at the end of my slide, Dr. Manjula will tell me. So what is your choice? I hope the slide is running, the poll is running.
Yeah, yes, sir. It's
okay.
running.
So I'll show them my theory. Yeah. Okay. So to increase appropriate antibiotic, what you need to do? I'm saying no antibiotics, but what you need to know? First thing, we need to define the infections in two ways. One, anatomically, where is the infections? Whether it's infections in the brain, infections in the heart, infections in the lung, infections in the kidney, or infections in the skin and soft tissue. Once you know where is the infections anatomically, we need to define the infections microbiologically, whether it's caused by gram-positive, gram-negative, or anaerobe. Because bacteria only three things: positive, negative, anaerobes. When to think positive? Any infections happening above the diaphragm. Always put your money on gram-positive. This is OPD setting. I'm not talking about inpatient setting. For example, meningitis. What causes meningitis? Streptococci is going to cause meningitis. Similarly, pneumonia. Either streptococci or staphylococci is going to cause the pneumonia. Infective endocarditis. Staph, strep, enterococci is all possible. Below diaphragm, put your money on gram-negative. Urinary tract infections. What is going to cause? E. coli, Klebsiella. What is going to cause intra-abdominal infections? Either E. coli, Klebsiella, gram-negative, plus or minus anaerobic organisms. So we need to think about microbiologically means whether the bacteria is going to be gram-positive, gram-negative, or anaerobe. Where is the lesions? Whether it's brain, heart, lung, skin, soft tissue, pharynx, sinus, ear, think about it. Think the organ, which organ is affecting. Ear is affecting, sinus is affected, pharynx is affected, lung is affected. Think about it. Skin and soft tissue, bone, joint. Think about anatomical locations. Suppose if you got some rapid diagnostics is possible, you can use a rapid diagnostic, but rapid diagnostic is not always the answer. But always make a courage to make a diagnosis. What is your diagnosis? Don't write just treatment alone in your prescriptions. Please, what you think, commit in your prescription paper. Do not solely response to therapy. Somebody is taking medicines, don't think the response happening because of the medications. That is a false myth. Because of the immunity or because the infection is not present, the patient is improving. All is possible. If empirical therapy started because your doubt, you started some therapy, always reassess in 48 to 72 hours. So this will increase your antibiotic choice. If you don't want to remember these things, at least write a diagnosis. What is a diagnosis? I'm thinking. Write anatomical diagnosis, write your microbiological diagnosis. Dr. Manjula, what has happened to the previous
Yes.
pool?
Yeah, pool is running. Erythromycin 11%. I think Hardik's team can show. Ofloxacin 0, amoxiclav 11, and last option 77%.
So people are wondering what to use there. So that's a good thing. So what to make syndrome? We need to make a syndrome. So instead of making a diagnosis, I do not know exact. For example, I'll come back to this case a bit later. So make a syndrome similar to the HTD physicians. They always say genital ulcer syndrome, genital discharge syndrome, genital lymph gland syndrome, or genital swelling syndrome. That's what they made. Similarly, you also think fever, cough, sore throat. What syndrome? Pharyngitis or pharyngolaryngitis is possible, or pharyngolaryngitis plus tonsillitis is present. On the other hand, fever, dysuria, burning sensations. Think of urinary tract infections. Presence of fever, swelling, redness, cellulitis, fever, diarrhea, vomiting. Think of gastroenteritis. So some syndrome we can make. So there's no need to worry about exact diagnosis. I don't want to say it's a group A beta hemolytic streptococci causing pharyngitis for everybody. At least write the syndrome in your diagnosis. Then third thing is we need to know whether the patient is sick or whether the patient is stable. How to assess the stability? Check the vital parameters. When the vital parameters are normal, he's able to give conscious, able to give history, able to come walking to your OPD settings, and patient is able to give history, and patient is sitting, taking bath, taking food, means the patient is stable. Nothing else. Don't use any advanced scoring system. Assess the patient, whether he's brought in the wheelchair or whether the patient is giving own history, what is his vital parameter. Then try to localize. As I told earlier, any anatomy you can able to localize. Brain, heart, lung, pharynx, sinus, ear, think about it. If you are not able to localize, you follow the other tropical infection stuff. So system, we need to require antibiotics. Then we need to certain system. For example, if you identify system, infections you are thinking in the brain, there is an infections, probable brain, I don't want to wait. We need to take appropriate samples and start antibiotic. Similarly, urinary tract infections, viruses causing urinary tract infections, only post-transplant setting is possible. For immunocompetent, the chances of bacteria is more likely causing urinary tract infections. By viruses won't cause the infections. Skin and soft tissue infections, progressive in nature, most probably bacteria. So these are all the syndrome requires some antibiotic. On the other hand, respiratory tract infections, mostly virus. Similarly, gastroenteritis, mostly virus. So what are all the syndrome we can wait, and what are all the syndrome we need to proceed, we need to know. So coming back to this case, the patient has got fever, cough, and sore throat. My syndrome is pharyngitis or pharyngotonsillitis here. I need to go with to decide which bacteria or which virus is causing. One score is called CENTA score. What is a CENTA score? The patient is stable. The patient is not unstable to me, and I try to localize anatomically to the pharynx or pharyngotonsillar region. I'm able to localize this man. So what causes pharyngitis? What causes pharyngotonsillitis? Virus. Common conditions, always think common. Pharyngitis means viruses. Mostly viruses causing pharyngitis and pharyngotonsillitis. One bacteria we worried about is called group A beta hemolytic streptococci. But always think whether the patient is life-threatening infections or not, whether he abscess, any epiglottitis, peritonsillar abscess, think about it. And always think broad, not only infection is going to cause, microbiologically, we need to define whether it's an infections or non-infections. If it is infections only, bacteria, virus, parasite, in the bacteria, positive, negative, and narrow. But other conditions also mimic infections, always think broad. So how to differentiate? Use the CENTA criteria. What is CENTA criteria? 4 criteria. Presence of high-grade fever, bacteria. Presence of cough, virus. Presence of purulent tonsils or purulent exudate from the throat, bacteria. presence of tender node bacteria. So if we use this criteria, we can say whether the patient is bacteria or virus. That's called Centaur criteria. Based upon the Centaur criteria, here the patient has got fever, that too low-grade fever, not high-grade fever, small node that's not tender, throat is congested but not purulent exudate, and there is presence of cough. All indicate the patient has got viral fever. There is no antibiotic is the best answer here. So that's what we need to do. Use the criteria. Suppose if you think the patient has got group A beta hemolytic streptococci, what antibiotic? So this chart we need to remember. For example, in streptococci, what are all the antibiotics will work? Antibiotics in green has got very good effect. Antibiotics in dark blue may work, may not work. Antibiotics in light blue, most of the time will not work. So for example, for a streptococcal infections, what are all the better drug? Penicillin is a better drug. Third generation cephalosporin is a better drug. Ampi and amoxicillin is a better drug. And even first generation second generation cephalosporin is a better drug. Third generation cephalosporin, yes, is okay. So these are all the things we need to think about it. So this is called antibiotic spectrum. What is a bacteria? Streptococci. What antibiotic will work for it? Gram-positive agents. What is a gram-positive agents? Penicillin is a gram-positive. First generation, second generation cephalosporin is a gram-positive. Amoxicillin is a gram-positive. Among the thing narrowest is penicillin. You can use penicillin. That's a better choice. Antibiotic delay. Then you need to know whether, suppose you are not sure about it, whether I can wait without antibiotic. Yes, it is possible. Certain infections like acute bronchitis, otitis media, upper respiratory tract infections, pharyngitis. Yes, these things you can wait. I told earlier, meningitis, meningoencephalitis, proven case of urinary tract infections, along with progressive skin and soft tissue infections, we need to start antibiotics. Other infections, you need to wait. Suppose you start antibiotics, always the mantra is short. For example, community-acquired pneumonia. I'm not talking about upper respiratory. I'm talking about lower respiratory tract infections. The duration nowadays is 3 to 5 days, not more than 5 days. So that's the recommendations for pneumonia syndrome itself. So think about it. If you start antibiotic, short is sweet, long is not required. Short is sweet, short to clear the bacteria, short to prevent the resistance. That's a mantra. If you start putting the antibiotic, the bacteria got irritated. Once it got irritated, it produces resistance mechanism. Simple. So keep it short. So I'll move to the second common syndrome in your practice. You can run the poll simultaneously. Who is suffering from UTI? Doctor, one of the complaint. Of late, my urine is foul smelling. I call it an UTI. 62-year-old male posted for TKR. Urine routine showing bacteria. Ortho, can I proceed? 24-year-old female with complaints of vaginal irritations, pain during sexual activity. Can you call UTI? 34-year-old female, body pain, weakness, fever, urine culture, CRE. Is it UTI? Please go ahead and vote. Which is causing UTI? Which you call is UTI, not which is calling UTI, which you can call UTI. Foul smell urine, or presence of 10 to the power of 5 bacteria in TKR patients, or presence of vaginal irritations and pain during sexual activity, fever, body pain, weakness in urine cultures, but patient is conscious, patient is oriented, but fever, body pain and weakness, and carbapenem resistant enterobacteriaceae. What the culture report I showed a couple of minutes back, the Klebsiella. Please go ahead and vote. I'll see the responses a bit later. Why you need to know the UTI? UTI is one of the common symptoms, particularly for pediatricians, mostly common, because the symptoms like classical dysuria, burning sensations, the child won't tell. Particularly for me, up to the age of 1, because I do pediatric ID also, up to the age of 1 or maximum up to the age of 2, it's very difficult to elicit the history from the child. But if the mother is smart enough, the parents is smart enough, they will recognize when the child goes to the urine, the child definitely, even if the child voids in the diaper, the mother notices the child will start crying. Even though after passing urine, because of the wetness, they will cry. But while passing urine itself, the child will cry, the urine will struggle. And some of the children, they keep the pain, the hand on the lower part of the tummy. So the parents is smart enough to pick it up whether the child has got some symptoms or not. Otherwise, I'll come back and show the shortcut how to sort out the problem there. So urinary tract infection is most commonly abused antibiotic also. So we need to know whether the patient has got urinary tract infections or not. How to do it? We need to know the symptoms: fever, dysuria, urgency, hematuria. If all the 4 parameters is present, the chances of urinary tract infection is very high. But still, you can't say 100%. But what will say when the patient does not have symptoms? No fever, no dysuria, no urgency, no hematuria, the chances of UTI is almost 99% ruled out. So it has got very good negative predictive value. So we need to check whether fever, dysuria, urgency. Most of the time, the call coming from the house officers, the resident doctors call me, sir, urine culture 10 to the power of 5 E. coli. Just now also a call, I just cut the phone now. They're saying urine culture grew 10 to the power of 5 E. coli. But he didn't say what is the symptoms he's having, why he tested the urine cultures, no informations. So always ask symptom. If the symptoms is not there, 99% of the time, you can rule it out UTI. Then people always confuses with asymptomatic bacteria. What is asymptomatic bacteria? Presence of 10 to the power of 5 bacteria in the urine. Presence of even pus cells also in the urine. But what is missing in asymptomatic bacteria? There is no symptoms. Absolutely no symptoms. For example, the case what I shown previously before the knee replacement. The patient came for knee replacement. Who ordered urine cultures? I do not know. So that is the reason for it. The patient has got symptom that becomes symptomatic UTI. Most of the time, what will happen? Presence of bacteria, 2 or 3 bacteria, poor collections of the urine. That is a reason for antibiotic starting. So we need to know whether it's upper UTI or lower UTI. It's very important. Certain antibiotic will work for lower UTI. Most often you see lower UTI in a female patients in your emergency settings or in OPD settings. For example, urgency will be there, hesitancy, hematuria, suprapubic pain. But what differentiates upper UTI and lower UTI? Fever. Fever means upper UTI. Why it is important? I'll come back in a minute now. So in cases of pediatric setting or the presence of confusing history, we are not sure about it. What you need to do, look for pus cells. Look for pus cells in the urine. Look for pus cells in the urine. I'll come back. Look for the pus cells in the urine. If presence of pus cells, the chances of UTI may not be there. But absence of pus cells, what I told, for example, the symptoms, fever, urgency, micturations may not be UTI. But absence of symptoms rules out UTI. Similarly, presence of pus cells, plenty of pus cells may not be UTI, but absence of pus cells rules out UTI. That is the mantra you need to keep. When a patient has got asymptomatic bacteria, more than 10 to the power of 5, like similar situations what I shown previously, what we need to do, 2 situations. I need to treat in the presence of urological intervention. That's why the pediatric urologist is wondering. He got a small child planning for a urological interventions, but culture is growing plenty of pus cells. That is asymptomatic bacteria, but still you want to do the procedure. So he was worried about what antibiotic to start. So any urological procedures, we need to screen and we need to treat before, not treat, at least we need to give prophylaxis for 48 hours before procedures. On the other hand, pregnant woman, even though the asymptomatic bacteria, but we need to demonstrate 2 occasions more than 10 to the power of 5 and pus cells should present, no bacteria. That point of time, yes, we need to treat. Apart from the 2 situations, pregnancy, urological interventions, there is no need to treat asymptomatic. For a patient going for a TKR, patients going for a bypass surgery, don't treat asymptomatic bacteria. Only patients, even renal transplants, we stop treating nowadays. Post-renal transplant bacteria, without symptoms, I'm not treating it. So why we should not treat? If you start giving antibiotic, this is an end result. If you start treating the asymptomatic bacteria, this is the end result to the patients. So send appropriate. First thing, the patient should have symptoms. Second thing, we need to send urine routine. Urine routine, pus cells present, symptom presence, ask for urine culture. This will cut down unnecessary testing. If you test unnecessarily, the patient start using unnecessary antibiotic. Then what antibiotic for UTI? We can't cut copy IDSA because the resistance to the gram-negative in US is very less. Similarly, for Europe, it's very less. They can use ciprofloxacin, ofloxacin, norfloxacin because it is working in Europe and US. But in Indian scenario, it's quite different. We can't use the bacteria because our resistance is very high. So once you made an urinary tract infections, urinary tract is anatomically located below diaphragm. So what causes urinary tract? Gram-negative. What is the commonest cause of urinary tract? Enterobacteriaceae. For Enterobacteriaceae, what are all the drugs will work? Yes, if the ciprofloxacin, ofloxacin sensitive will work. Cotrimoxazole, nitrofurantoin. So nitrofurantoin is a beautiful drug. It will work most of the time. The resistance is not present, but couple of concerns. One, nitrofurantoin is a good drug for lower UTI. The pharmacokinetics of nitrofurantoin will not allow it to enter in the kidney. Whatever nitrofurantoin, it goes to the bladder, excreted in the kidney. So nitrofurantoin is a good drug for lower UTI like cystitis and urethritis, not for pyelonephritis. But in the presence of elevated creatinine, nitrofurantoin should not be used. That causes any issues. Then other drug called cotrimoxazole. Yes, cotrimoxazole is a very good drug. Unfortunately, cotrimoxazole has got a lot of side effects. For example, potassium we need to monitor. Creatinine we need to keep on high, and along with the blood counts also we need to keep on high. And allergic reactions to the sulfa is a concern, so always ask history of allergy to sulfa before start writing cotrimoxazole. What are the drugs? Quinolones is a beautiful drug. You can cut down the durations, but unfortunately, resistance in India is almost 85% to 90% of the time. Ciprofloxacin, norfloxacin is not working in my situations. So what we left out, sometimes we need to use aminoglycosides provided the kidney is fine, provided the patient should have UTI. If the UTI is there, ideally what I need to do, send urine routine, urine cultures, and start antibiotic based upon the local antibiogram, which is the best drug. Nitrofurantoin is a better drug for lower UTI. For upper UTI, either amic acid may be working, provided the kidney functions are good, or we need to use BL-BLI combinations in the form of piptazo or cefoperazone sulbactam. Why? Cefotaxime, ceftriaxone, the resistance is very high. Till the culture is back, we can use it. Once you know the sensitivity, once you know oral drug is working, change over to oral drug. I think year after the urinary tract infection is a child's play for you. So we need to know what antibiotic. If you choose strong antibiotic, the urine will come in other directions rather than what is happening in this picture. So my third case scenario, 30, you can start running the poll. 30-year-old male, Chennai, working in IT, recently married. So he's eating diarrhea, a lot of outside visit event, and he had taken a lot of food. Diarrhea 3 times a day daily. No blood, no mucus, no fever, no vomiting, no abdominal pain. On examinations, hydration is maintaining well, afebrile. What do you call? Gastroenteritis, dysentery, diarrhea, food poisoning. What is the stool frequency? So what I'm going to call now? So we need to make a proper diagnosis. When a patient comes with fever and diarrhea, don't always think the patient has got gastroenteritis, always bacterial. I told 2 situations, respiratory tract infections, gastroenteritis, always you can wait and watch. So make a syndromic diagnosis. Yes, the patient has got no fever, stool frequency 3 times a day. We need to go and ask what is the routine stool frequency, baseline stool frequency. If the baseline stool frequency is 2 to 3 times, it's normal. 3 times a day is normal, 3 times a week is also normal. So think the baseline. Don't immediately jump and start antibiotic. Work on it. The patient is hydrated well, no fever, no nausea, no vomiting. Think about what is his natural history. Got recently married, because of the married, he got tension, and because of the tension, he's passing stools. I'm not sure. So differentiate whether it's a diarrhea versus dysentery. So diarrhea, usually it's probably from the small bowel. How to differentiate whether it's a diarrhea, dysentery, or small bowel from large bowel? Small bowel, less number of frequencies. For example, 5 to 6 times, but the volume is more, large content, because small bowel retain a lot of fluids. So large amount of fluids, 5 to 6 times, no blood and mucus. Fever may not be present, but in large bowel, fever will present, blood and mucus, more frequent time, along with blood is also present. Why this differentiation is needed? Dysentery needs antibiotic. Diarrhea does not need, but patient will come and say, doctor, I got dysentery. What is the stools? Watery stools. How many times pass? 4 to 5 times. So they always say dysentery. Please elicit the history, whether it's a dysentery or diarrhea. Dysentery means presence of fever, presence of the blood, presence of the mucus. More times he is passing, and small quantity of stools. What causes diarrhea? Most of the time viruses. How to differentiate diarrhea versus dysentery, or how to decide antibiotic? Presence of fever needs antibiotic. Presence of blood or presence of mucus in the stool needs the antibiotic. Presence of more than 8 times or more than 10 times needs antibiotic. Rest frequency, hydrated, no fever, watery stools, mostly virus, don't need for antibiotics. If you read the guidelines are changing. Even the Western guidelines, what is the preferred antibiotic? People always want to use Norflox TZ, Ciplox TZ. There is no role of parasitic infections. For example, amoebiasis, giardiasis, most of the time is a subacute, particularly amoebiasis subacute. Giardiasis, the chances of having giardiasis is very, very less common, mostly virus, bacteria. So people always want to use Cipro, Norflox, they want to use it. But Cipro or Norflox resistance is going up, particularly for Campylobacter. Common causes of organisms in loose stools, gram-negative, Salmonella, Shigella, Campylobacter. So fluoroquinolone resistance can go up. Rifaximin only for traveler's diarrhea. So what is a better drug? Azithromycin is a better drug. According to the data, it has action against Salmonella, it has action against Shigella, Campylobacter, Yersinia, and Vibrio cholerae. All 5 is taken care with azithromycin. You can use azithromycin. People say azithromycin can cause diarrhea. Yes, we need to use sometime. The patients causing diarrhea, that will be taken care. So acute gastroenteritis, oral rehydration is a therapy. Ensure the hydration, that is more important. Second thing, people want to know about probiotics. In pediatric, yet it's got role, but for adult setting, probiotic has got very limited role. Second thing, anti-motility. If there is no fever, no blood, no mucus, you can use anti-motility agent. But in the presence of fever, the presence of blood or mucus or more amount of stools, don't use anti-motility agents before giving antibiotic. So shit happens every day. We know the differences and how to deal with it. That's more important thing in acute gastroenteritis. My other last one case. This lady is presented with cellulitis. Basically, it's very difficult to show. I put the wrong slides. Okay, fine. So the patient has got 50-year-old female, bilateral leg swelling of 7 days durations, but no tenderness. If you see, the redness is present for quite some time. It's not going rapidly. It is slowly and steadily it's increasing. It's not rapid increase. So what do you think? Skin and soft tissue mean I don't run this poll. So we need to learn a lot. We need to differentiate. Sometimes what happens, patient always confuses with cellulitis with non-stasis condition, particularly patients has got venous ulcers or patients has got varicose vein. This type of stasis can happen. Usually bilateral, don't put your money on cellulitis. Cellulitis, most of the time, it's in unilateral. That's more important. And second thing, what is the progression? This lesion is existing for quite some time, more than 7 days, more than 10 days, more than a month. That is not cellulitis. Cellulitis won't stand in a long-standing time without treatment. So we need to know whether the patient has got severe infections, how to say severe infections, neutropenic worst. Patients use IV drug abuse, the lesions can progress. When a patient is stable, what criteria I'm using called ALT7. What is ALT? Asymptomatic, not asymptomatic, asymmetry. Only one limb is involved, either right limb or left limb. Patient's age above 70, WBC count elevated, heart rate elevated. If the criteria is present, we can justify to use antibiotic. Asymmetry,
Hello.
more than 70 years.
Good morning.
More than 70 years, more than antibiotics, WBC count elevated, you can use antibiotics. So last case before knee replacements, what antibiotic? The patient has got 10 to the power of E. coli, or what antibiotic will give for this person? Whether you want to postpone the surgery, last poll, please go ahead and run. 60-year-old diabetic posted for knee replacements, no urinary symptoms, but urine protein showing pus cells and culture is going 10 to the power of 5. Only antibiotics IV. So what antibiotic are going to use for this knee replacements? Cefuroxime, cefazolin, piptazo, ticoplanin, none of the above. So what are going to do for this man? So usually don't do test. If you do test, generally the problem stands. For example, the patient came for TKR, total knee replacement. Why there is a need for urine cultures? The patient has got no symptoms, no dysuria, no urgency, no fever. All 4 criteria absent, so it has got very good negative predictive value. The chances of UTI is almost 99% ruled out. So there's no need to think about I'm going to put a prosthesis, this is going to infect it. If you start using antibiotic, the resistance keep coming up. Similarly for dental, people want to give 2 days before dental procedures and continue. If you got infections, gum abscess or something, yes, fine. Treat the abscess, drain the abscess. But when a patient comes for some dental procedures, why you are using antibiotic? Try to avoid antibiotics. Only the patient has got endocarditis or patient has got underlying structural heart diseases, congenital heart diseases, yes. Otherwise, dental prophylaxis is also not required. Keep in mind. So, in summary, Wright syndrome. That's most important. Before write antibiotic and OPD, Wright syndrome. And syndrome, which syndrome does not require antibiotic? Respiratory tract infections, gastroenteritis, you can wait and watch provided the patient is stable. What infections? Urinary tract infections, meningitis, yes. And skin and soft tissue, progressive, yes. But we need to send appropriate sample before starting antibiotic. Third thing, what antibiotic? Spectrum. Anaerobes means what are all the antibiotics? Gram positive, what are all the antibiotics? Gram negative, what are all the antibiotics? Pseudomonas, what are all the antibiotics? So think about it, whether this antibiotic has covered gram positive, gram negative, anaerobe, or it cover pseudomonas, it cover MRSA. If you know the 5 things, it's easy for you. Whether it cover gram positive, whether it's gram negative, whether it's anaerobe, whether it's pseudomonas, whether it's MRSA. Gram positive, penicillins, first generation cephalosporin, up to third generation cephalosporins can use. Gram negative, mostly third generations, or fluoroquinolones, or 4-trimoxazole, or BLBLIs. Anaerobes, metronidazole, clindamycin, amoxiclav. Amoxiclav has got good anaerobic cover. Think about it. So we need to know what organism. Pseudomonas means we need to use fluoroquinolones or aminoglycosides. If you think MRSA means either clindamycin or linezolid. So if you know these simple things, it's easy for you to choose what antibiotic. Then most important thing, nitrofurantoin will work in the lab, but nitrofurantoin for pyelonephritis will not go. Amoxicillin will work for a streptococci, but amoxicillin penetration to the brain won't be great. So we need to know whether the organisms, whether the antibiotic will reach particular site. If you think the patient has got infections in the brain, AMPI is a better choice, not amoxicillin. The patient has got upper UTI, 4-trimoxazole, fluoroquinolone, provided it's sensitive, is a better choice, not the thing. For typhoid, the best choice is any antibiotic except fluoroquinolone, because fluoroquinolone resistance is very high. So we need to know the pharmacokinetics, whether the drug will reach the site, what is the resistance of the drug. For example, the fluoroquinolone to the typhoid, almost 90% to 95% is resistance, keep in mind. Then we need to know the dose. Pediatricians is damn good. They write milligram per kilogram. Cefotaxime means 100 to 150 milligram per kilogram of the body weight. Ciprofloxacin means 10 to 15 milligram per kilogram of the body weight. Always goes with milligram per kilogram of the body weight. It's easy for you to choose. So for example, cefixime, 400 milligram BD is a minimum dose for adult. Don't write 200 milligram BD. Similarly, ciprofloxacin, 750 milligram BD. We want to use cefotaxime 2 grams IV TDS or 2 grams IV Q6 also, you can go for meningitis. Use proper dose based upon milligram per kilogram of the body weight. And short is sweet. Always the thumb rule, any infections, 5 days is fine. OP setting 5 days, IP setting 7 days. That's the rule I can say. Minimum 3 days. If you got guts, use 3 days. If it's an ordinary person, 5 days is fine. For IP setting, not more than 7 days. Keep in mind. So how to go about it? Infectious disease specialist is not available, but you need attending FeFCon 22, 23, 24. You can learn a lot, and we need to learn in short, because you're waiting for 1 year is a bit difficult. Yes, the other option is a tele-ID, and tele-ID teaching is also possible. We can teach you very busy schedule. Yes, we can teach you. If you don't want to learn these things, just call. We give the options for you. Just make a telephonic call. We give the answer to you. So telemedicine-based training is also possible, and telemedicine-based virtual clinic also running. A lot of hospitals joined in tele-network. They just call us the infections. For example, Southern Railway hospitals, one of the hospitals and private medical colleges hospital started. Suppose if you are working in a hospital, your hospital interested in participate, please feel free to call us. We'll provide the number to you. Please feel free to call for your antibiotic support. Suppose if you are not confident, if you want to get a second opinion, yes. If you do antibiotics, your patients walk back vertically. Your patients walk back vertically, and there will be no lawsuits for you, so that you can retain your money, hard-earned money. Otherwise, one lawsuit will take crores and crores of money from the patient's lawsuits. Please be aware the medicines cause side effects. So I think FeFCon would is look at the paracetamol or dolo compared to antibiotics. That's not my aim, but avoid antibiotic. That's my aim there. So try to avoid antibiotic. That's a mantra I'm conveying it. So my last question is, do you interested to joining hands-on training on ID? This is my sake. I need to see the results in person for me. So please run the show. How many want to join hands-on training? Yes, no, only virtual. Later, I'm thinking. I like to see the response.
Please post the poll. Since till they are doing, sir, I can give you the results of the earlier polls. Sure. The earlier one, you had asked for that erythromycin and the options which we finished. There was another option. Yeah, please.
Medicine.
Yeah.
Which is situation?
Yeah, he is showing, sir. He is showing, right.
Very good. Okay.
Can you show? Yeah, next one. There was one more poll.
Which antibiotic? Why no antibiotics? Very good. So all the polls is very good. So 25 no comorbid.
Last one, can you put somebody? Sir has given the last question.
Who is suffering UTI? Very good. So we'll see later. Last questions you can put. How many want to join ID? Okay.
Yeah, he will.
Okay. Last one. Okay, thank you. So what I need to do now, yeah. So those who are interested, please feel free to contact us. Those who want to learn, for example, our startup will start giving training for 2
Not
years.
this. Can you put the last one, please? Last one.
We'll
yes,
do
sir.
the discussion side. Let him see the no issues.
Yes,
so those
yes.
interested to learn 2 years program, fellowship in infectious diseases, yes, possible, but it's all hands-on. And people interested in MBBS, whether I want to go straight away for super specialty is possible. People want to learn antibiotics, stewardship alone is possible. All possible. Thank you. I think I want time for. I started at 9:05, so almost last 7 to 8 minutes. I keep discussions there. I hope I try to simplify the antibiotics to say no antibiotics in OPD. Please go ahead and ask, shoot your questions to me. Thank you for the wonderful opportunity.
Suresh, as usual, you rock, Suresh.
Thank you, sir.
And if somebody is interested in fellowship also, then they can contact Suresh. or contact me. I'll be able
Sure,
to help
sir.
all. Yes. Manjula, then what else, Manjula, now?
Yes, sir. Are there any questions? Sir will be happy to take some very quick
Last 2
questions.
minutes I kept it, sir. Actually, I
Yeah,
started
yeah.
9:05, so
Yes,
10:05
sir.
we can keep it.
Exactly. Right, sir. Please, yeah, next one. Next, please put the next poll. Next poll for the audience.
Anything in the chat box, ma'am, we can answer, or I can put it to the
Yeah,
questions.
all play chat box. I'm seeing only excellent session. Such things, sir. Queries are not there actually. Excellent talk, doctor. Excellent talk. Such only those things I'm seeing. Right. Anybody wants kindly post your question in Q&A or chat box for Dr. Suresh. And any of our panelists over here can ask a direct question to him.
Yeah,
Suresh,
Suresh,
you said five types of antibiotics. You said gram positive, gram negative, like that, and the last one is MSRA. You said.
Yes,
What
sir.
is the preferred antibiotic for the fifth one?
MRSA antibiotic is usually clindamycin will work, linezolid will work. For outpatient setting, this is oral options. Cotrimoxazole sometime will work, sir. So these are all the better options. Either you can use
that's
clindamycin,
why
linezolid,
I asked you.
cotrimoxazole.
Yeah, the cotrimoxazole has come back now. No,
Yes, sir.
many times they're using that also. And what will be the dose and how long you must give?
Cotrimoxazole, nowadays people going to use higher doses there. Usual doses, if you want to go by milligram per kilogram of the body weight, usually we consider trimethoprim dose of 5 to 10 milligram per kilogram. Usually we want to keep higher doses for bone infections like osteomyelitis and septic arthritis.
And what's the duration? How long you should give?
Depends upon indications. If it is you want to use for bone and joint infections, osteomyelitis, we need to treat longer. For skin and soft tissue infections, 5 to 7 days. The rule is 5 to 7 days, some rule.
And for some of the SIBO, that is small intestinal overload, bacterial overgrowth, they give Metrogel very small dose for quite some time, 3 weeks and all that, 200 milligram daily. Is it helpful?
Antibiotic diarrhea, yes, Metrogel will work, particularly metronidazole will work. Antibiotic diarrhea 3 times a day, but not 200 milligram. We use 400 milligram oral, not give IV. If you think the patient has got antibiotic associated diarrhea 3 times a day with metronidazole, sir.
SIBO, that is small intestinal bacterial overgrowth. There they give for 2 to 3 weeks a small dose of
prophylaxis.
No, it is a cyclical antibiotics they give in SIBO. They give first rifaximin, then rifaximin, then change over to Metrogel. All that they give Metrogel, especially very small dose they give for long. I don't know whether it's going to be helpful, but most of the gastroenterologists, the cyclical antibiotic.
I have one question, Suresh.
Yes, sir.
Madam, one question. Suresh, one antibiotic causing pseudomonas colitis to be highlighted is all very important. Second thing, the point not covered was in the clinical practice. When I was using antibiotic in pregnancy, the antibiotic crossing the placenta, having any teratogenicity on the child, and during lactation, is the antibiotic getting secreted in the breast milk. The pharmacodynamics and kinetics of the drug important, especially when I'm using antibiotic during pregnancy and during lactation.
Yes, sir. Very valid question.
Textbooks also don't highlight much on this.
Yes, sir. In the presence of pregnancy, usually we have one sessions on pregnant-related infections or infections in the mother. I don't think so. Last year we had it. This year we don't have it there. So usually in pregnancy, yes, aminoglycosides is a contraindications. And second thing, tetracycline derivatives, doxycycline tetraderivatives, ciprofloxacin, fluoroquinolone, people previously used to say, but off late we are using it there. Even though the cartilage damage in the newborn, it's myth only. Even for newborn, sometimes if it is working, we are using fluoroquinolones. So what is contraindicated, particularly presence of aminoglycosides is contraindicated. I'm talking about OP antibiotics. I'm not talking about IP antibiotics. Even though aminoglycosides is IVIM, aminoglycosides, tetracycline derivatives try to avoid. These are all the antibiotics we avoid in pregnancy situations. What is safe in pregnancy? Penicillin derivative, amoxicillin, cephalexins, these are all safe derivatives. So we can use without any issues. All amoxicillin, penicillin, cephalexin, even azithromycin are went into controversy, but we can use macrolides also. It's not an issue.
What about linezolid?
Linezolid is safe, sir. We can use it. There's no contraindications.
This information because these
Clindamycin
none
is
of
safe.
the drugs you
Linezolid is safe.
mentioned will cross the placenta. That's why they're safe.
Yeah.
None of the drugs will cross placenta. But all anti-aminoglycic, the placenta crossing is almost 80 to nearly 80%. So that causes yet no deafness. So this knowledge, kinetic knowledge of antibiotic, does it cross placenta or not? What would secretion breast milk? I have not seen any drug which doesn't secrete breast milk.
Like usually
So
the people
unnecessarily we are putting the child on antibiotics.
So usually the lactating mother, what happened, they develop breast abscess particularly, and most of the time following post LSCS, they stayed in the hospital. They got lactating abscess, means mostly it is a staph, mostly it is an
No,
MRSA.
not for lactating, not lactating abscess. Any antibiotic for any reason for mother infection, to respiratory tract infection, urinary tract infection, she is breastfeeding, we should avoid an antibiotic which gets secreted in breast milk. To my knowledge, there is no
I
data.
told everybody should
any
avoid,
antibiotic not
but pregnant and
getting
lactating mother even more so. Yes, agreed.
Sir, if I may
But
comment here,
what I do is,
if
Yes,
I may
sir.
comment here,
Chairperson,
the most antibiotics which are given to mothers are secreted in very small quantities in the breast milk. So they generally, though they are secreted, they do not cause much problems in a newborn. However, as Dr. Suresh and others have mentioned, we have to be careful when you are giving to a lactating mother, especially any antibiotic which can in the first month of life can displace the bilirubin and produce hyperbilirubinemia. So to be careful there. And drugs like cotrimoxazole, chloramphenicol are definitely no-no. Even tetracyclines you have to use with caution. However, you can use most of the oral penicillins. You can use even cloxacillin, penicillin. All those are safe. There's no problem. Even cephalosporins, first generation, second generation are safe. There's no problem there. The only thing is that certain antibiotics are secreted by their mother in very small quantities. So we do not know the clinical significance, whether these really cause problems or not.
yes, sir, there are no data, sir. But what I do, I ask the mother to give breast milk and take the antibiotics, so that 3-4 hours the peak blood levels will come down and the milk concentration of antibiotic will come down. The simple precaution: give breast milk, feed the child, then take the antibiotic. The 3-4 hours don't give the breastfeeding. The simple thing you do in the rheumatology for DMRD also.
Yes, Jagdish sir mentioned that there is no contraindication because we are giving high dose of gentamicin for the newborn. Newborn, the main drug is gentamicin aminobutyric acid. There is no problem. So how it will affect the lactating mother? No problem. We
No,
are
sir,
using all
it's
antibiotics.
another question. Child is not suffering with any infection. Why you want to put antibiotic in our body?
Sir?
No, the question of safety is not there.
I think
Antibiotics should not
there are
take.
two.
Misuse of antibiotics should not be
I
there.
think
So child don't have
I
any
think
infection.
Dr.
Mother's infection, treat the mother. Don't put antibiotic in the child's mouth.
Yes, sir,
No,
agreed,
sir. I think the question was not correctly understood. I think Dr. Anand Keshavan was talking about treating newborns, and you are talking about
lactating mother.
treating the mother and the transmission of the antibiotic to the baby. They're two different situations. I
Yeah,
think
yeah.
both of you are right. Both of you are right, and I think that's fine.
Yeah. Sir, there are no questions here, sir, on the chat box. I think before we close, sir, we can show the poll results if everything is
You
ready.
can send it to me, ma'am. No issues.
Yeah, okay. You can send it to sir. So you can mail it to sir. Okay. Yeah. Dr. Jagdish Channappa, sir, closing remarks.
Yeah, I think we should rename Dr. Suresh now into Shatabdi Suresh Kumar. Okay. Because two things are there. One was the super fast way in which he covered the destination, and second thing is one of the trains which always comes on time, so finishing on time. So I think we should rename Dr. Suresh as Shatabdi Suresh Kumar. So I think it was a fabulous session, Dr. Suresh, and also the other important thing about Shatabdi is that it gives you very good comfort. So your slides also was very comfortable to look at, very nice and brilliant. Thank you so much.
Thank you, sir.
I think Dr. Muruganathan wants to say something.
No. See, all those people who are introduced by me cannot be, ordinary people. So I'm very happy that this phrase every year is becoming more and more popular. Is not like Sadati train. It's more like a jet, sometimes goes so fast like a jet, but still very comprehensive, very clear it is, this one. Anyway, thank you, Suresh. Thank you, Manjula. Thank you, Jagdish Chinappa. Thank you.
Thank you very much. I request all the pediatrician panelists, you may have to log out from this and use the pediatric link which I have pasted. And the physician can stay on. This will continue as a physician hall. Madam has posted, we will bring the Shatabdi to Guwahati. Sir, Dr. Rachana ma'am. Okay. So I request pediatrician to move on to the pediatrician hall, Hall B, and this hall will continue as physician hall. Thank you so much to everyone. Wonderful session, Dr. Suresh sir. It was really wonderful. Thank you. So we will move on to our regular conference session. And the first session is Hyperpyrexia by Dr. Chakrapani sir. To chair this session, to introduce the speaker and conduct the session, I request Dr. Narsimallu Gundala sir. Gundala sir, over to you, sir, Narsimallu sir.
Thank you, Dr. Manjula.
Yeah, 1 minute, sir. I just want to say, Professor Dr. G. Narsimallu sir is a senior consultant rheumatologist at GVN Medical Center, past president of Indian Rheumatology Society, former dean ICP and ICI, former professor and HOD of rheumatology from NIMS Hyderabad, former chairman Association of Physicians of India. He's been in many of the association, including Physicians of India, Indian Association of Clinical Medicine, and he's been the governing member of API, faculty member of API, and former assistant editor general of API, as well as a member of syllabus committee of rheumatology, MCI, and former chairman of FeFCon. And he has been a very valuable advisory board member for us, and he's been guiding us in all our scientific events. Dr. Narsimallu sir, welcome, and over to you, sir.
Thank you, Dr. Manjula, for your kind words. Now, next session in hyperpyrexia causes management, very important clinician, one of the cause of mortality and emergency medicine. And whenever we get, it is a alarming situation, the task will be delivered by none other than Dr. Chakrapani, who is a professor, Department of Medicine, Kasturba Medical College, and for his credentials, academic achievement, 88 publications, 15 index, and 3 PhD scholars are guided. The former dean, KMC Mangalore, former chairman of ISCC Mangalore, former president of API, Dakshin Kannada chapter Mangalore, and special interests are 24 temperature monitoring, very important in the clinical practice, and infectious diseases, diabetes. Sir, I'm sure we can't get a person better than you to address this important clinical topic. Dr. Chakrapani, back to you, sir. Kindly address the issue.
Yeah. Sir, before Dr. Chakrapani sir, I just want to make an announcement to all the delegates. If you are interested in, if you are pediatrician or doctor interested in listening to pediatric topic, it is started on Hall B. There will be parallel session going on now. Hall A will be physician topics and Hall B will be pediatric topic. You need to, if you are logged in here, go out to the lobby and select the Hall A. You don't have to re-log in, you just go to Hall B. So pediatric session have started. So thank you so much, sir. Over to you, Dr. Chakrapani, sir.
Good morning. Let me share my screen.
Yeah. It's visible, sir.
Respected Chairperson, Dr. Narsimallu sir, delegates and friends. At the outset, I should thank Fever Foundation for bringing the focus back onto temperature and fever. Fever and body temperature is one of the oldest vital signs, but often neglected. We have so much of interest on respiratory rate, blood pressure, or pulse rate, but we have neglected temperature in our clinical practice. It is one of the least studied or well-developed science as far as vital signs are concerned. There have been a lot of technological improvements in terms of recording, analyzing, and interpreting, but temperature analysis is lagging behind very much. Fever is an adaptive innate immune response. whenever there is a threat by infectious agents or non-infectious agents, the innate immune response is the one which comes into the forefront immediately. It is a non-specific one, but that's one of the first responder. And when the initial phase of the immune response starts, fever is part of that response, and the this innate immune system is activated, but to a certain level. Uncontrolled, it will produce a lot of damage. So body knows how to control it. So after the initial quick response, the innate response comes to a plateau, and then it's well under control. So this coordinated, adapted phase of immune response is very important, both in terms of the fever and also the variety of biochemical changes that happen in the body. The idea is to contain and control the infection or the other non-infectious agents. But once in a while, this adaptive response can go out of control, and that becomes maladaptive response. Especially when there is infectious agent, body has a very good control over the adaptive process, and there is a limit to which the temperature goes up, and that remains within that physiological range for well-controlled, orchestrated changes that can control the temperature. Once in a while, this will go out of control, and this maladaptive response will give rise to significant inflammatory changes, including body temperature, and that's when it becomes deleterious to the host. In biological system, everything is in a delicate balance. We have the balance between coagulation and anticoagulation. We have got balance between osteoblasts and osteoclasts. There's a very delicate balance between inflammation and anti-inflammation. There is also a delicate balance between mitotic and apoptotic changes. Similarly, as far as fever is concerned, there is a delicate balance between adaptive, protective fever response and maladaptive, destructive hyperpyrexia. So what should be a friend within the normal range of temperature becomes a foe once it goes beyond the tipping balance, and that's when it becomes a maladaptive, deleterious response, and that's where we have to be very aggressively intervening and controlling the temperature. Within that physiological range, often we don't have to unnecessarily bring down the temperature, but then beyond certain limit, when that protective reflex itself becomes destructive, we need to be aggressive and bring down the body temperature so that further harm is not done. Hyperthermia versus fever is always a confusing term. Fever is a pyrogen-mediated rise in hypothalamic set point, because of which the body temperature goes up subsequently. So here, the pyrogen is the one mainly from the infections, which sets the hypothalamic set point. And once the hypothalamus has set the point, all the changes happening in the body try to increase the temperature to reach that set point. That is fever. In hyperthermia, it is temperature set point is not altered. The thalamic alteration of set point doesn't occur, but the temperature is generated either by the external mechanisms or because of internal mechanisms. Here, the thalamus is not changing the set point; it is remaining wherever it is. Ultimately, both are dangerous. Whether it is pyrogen-induced set point changes or whether it's because of the external or internal temperature generation, ultimately the high temperature is deleterious, and whatever be the mechanism, it is dangerous. But understand the mechanism is important because treatment is different. Hyperpyrexia is one where the fever response goes beyond the limit, beyond certain limit, which is quite damaging to the body. Hyperpyrexia and hyperthermia are not the same, although most of the literature, there is some overlap between the two, because ultimately when a patient comes with high temperature, it is difficult to see whether the hypothalamic set point is changed or not. But whatever it is, hyperpyrexia is a term which is reserved for uncontrolled febrile response due to pyrogen, which goes beyond a certain level. In infections, as I've told you already, it rarely goes beyond 106. But an arbitrary level of 106 is defined as hyperpyrexia because it is expected that a lot of enzymatic changes will occur beyond 106 degree Fahrenheit. There is no unanimity as to what should be the cutoff level for hyperpyrexia. Many authors would define it as more than 105, or many others would define it as more than 106 degree Fahrenheit, which is about 41 degrees centigrade. And that seems to be the general accepted level of hyperpyrexia. But there is another functional definition also. Many authors feel that the arbitrary number may not be appropriate, and the temperature at which there is damage to the body could vary from person to person from time to time. And that's why one of these old articles mentions that as a state, the hyperpyrexia is a state in which the internal temperature of the body is so high as to interfere with the physiological mechanisms which normally regulate the body temperature. It could happen at 106. It could happen earlier also in certain individuals. So according to this author, it should be functional definition, and in clinical practice, it is a matter of medical judgment. We cannot wait for the magical number of 106 to initiate treatment. Whenever in our clinical judgment we feel that this temperature is deleterious to the host, we have to intervene and using all our available methods. Let's see what happens in when the temperature goes up and why should it go up. Why should it go up? It starts with the thalamic set point. When from the normal level, the thalamus is set at a very high level. Now the body wants to generate temperature to reach that level, whether it's a core temperature or the surface or the shell temperature. Ultimately, the body wants to reach that set point. How does it reach? It reaches mainly by shivering and all other available physiological mechanisms through which the temperature is generated. So when the temperature is generated by mechanisms like shivering, which is very, very bothersome for the patient and also for the metabolic system, the core temperature goes up first, then surface temperature gradually goes up to catch up with that set point. And once the set point is reached, then the shivering has come down. But in between, if you see this graph closely, in the initial phases, the surface temperature or the shell temperature is close near normal, whereas core temperature has already gone up. So if you record the temperature on the skin surface, you will realize that this patient hardly has any fever, but in fact, the core temperature is already reached a very high level. When we go for recording of the temperatures, we should make sure that we check the core temperature, because ultimately what matters for the host is the core temperature, not the surface temperature, not the shell temperature. And the shivering is proportional to the set point and surface temperature gradient. If the surface temperature is kept arbitrarily low and the set point is at a very high level, then there will be a lot of shivering, because ultimately the body will go by its set point, not the surface temperature. That is why artificial cooling of the surface temperature may not give the desired results. In fact, when the surface is cooled by artificial measures and set point is set at the same level, the gap is too much, and this will be whenever the gap is high, the shivering will be more, and that ultimately results in increased core temperature. So this is a paradox which we should keep in mind. Cooling the surface alone without reducing set point does not yield a desired result. In fact, it could be counterproductive, because it leads to a lot of shivering and other mechanisms which generate more heat. Shivering is not tolerated by the host nor the metabolic system. Shivering has both high metabolic cost and discomfort compared to a steady state of the body temperature. If the shivering is not inhibited by external cooling, there can be increased oxygen demand, and there can also be dangerous rise in the core temperature. That's why cooling without reducing the set point will not yield much of a result while handling patients with hyperpyrexia. And when we talk about hyperpyrexia, it's always the core temperature, not the surface temperature. So surface temperature can vary greatly, as I showed in the previous graph. It can lag behind the core temperature for a sufficient enough long period of time, and during that period, if we go only by the surface temperature, we will miss dangerous hyperpyrexia. The ideal sites for measuring the core temperature are tympanic sites or rectal measurements. Oral may be inaccurate at high temperatures. In the usual temperature range of mild to moderate fever, oral sublingual recording is appropriate, but at a very high level of temperature, at the range of hyperpyrexia levels, there could be a significant lag in the oral temperature, and it may not give us the appropriate readings. That's why we have to measure core temperature either by the rectal measurement or the newly developed tympanic recordings. We have published a small study recently where we have compared the sublingual temperature and the tympanic temperature. What we found was that in steady state or even mild moderate temperatures, the difference is hardly about 0.5 degrees centigrade between the tympanic temperature and the oral temperature. But at the temperatures above 39 degrees centigrade, there was a significant lag, and the difference could be as high as 1.5 degrees centigrade, which means that if oral temperature is 39 degrees centigrade, which doesn't fit into the diagnosis of hyperpyrexia, the core already would have reached 41 degrees centigrade, that's 106 degrees Fahrenheit, and we will be missing a lot of cases of hyperpyrexia if we don't measure the core temperature. Another study which was reported earlier compared oral temperature and rectal temperature, and they also came to a similar conclusion. At high temperatures of more than 39 degrees centigrade, there is about 1.5 degrees centigrade difference between the oral temperature and the rectal temperature. So briefly, what it means is that whenever there is a doubt regarding hyperpyrexia, we should go for appropriate core temperature, either the tympanic or the rectal temperature recording. We also did another study to compare the conventional axillary temperature recording and compared with the continuous 24-hour recording. And you can see here that when there is continuous temperature recording of the tympanic site, we can pick up a lot of spikes which are generally missed by the conventional recording shown in solid lines. So axillary recordings done by the nurses in the fixed interval of 4 to 6 hours may miss significant episodes of the spikes of fever, and these spikes may be, matter a lot when there is the when the temperature reaches the threshold level of hyperpyrexia. In the same study, we also compared the difference between the peak temperature in the tympanic and axillary recording. You can see that there is nearly about 1.5 degrees centigrade difference between the peak axillary recording and the peak tympanic recording, confirming the fact that depending upon axillary recording, intermittent recording, or even sublingual recording may not be appropriate while dealing with patients with a very high degree of temperature. Generally, we feel that infection is the major cause of hyperpyrexia. It is not. As I already mentioned to you, the body knows how to handle the infection and the adaptive response, and it controls the adaptive response. A large number of hyperpyrexia is seen in cases like intracerebral hemorrhage, pontine hemorrhage, or thalamic involvement, or intracranial trauma. In terms of infections, malaria, tetanus, and other tropical fevers can produce hyperpyrexia. CNS infections, enteroviral infections, COVID-19 are notorious causes of hyperpyrexia. There are a variety of drugs, starting with anesthetics, and also drugs which act on the extrapyramidal system, which can produce hyperpyrexia. Among endocrine causes, thyrotoxic crisis is one of them, which can produce hyperthermia. COVID-19 can produce hyperpyrexia either because of the cytokine storm, or because of direct brain injury from the SARS-CoV-2, or because of the extensive vascular thrombosis. Whatever it is, there is high mortality due to COVID-19 induced hyperpyrexia, and unless we measure core temperature, we will miss many of these conditions. Hyperpyrexia is because of pyrogen-induced set point alteration. Hyperthermia is generally because of the external temperature or the temperature generated because of muscle spasm. But although definition-wise they look very interesting, clinical differentiation is not that easy. In a steady state of the high degree of temperature, it is very difficult to differentiate hyperpyrexia and hyperthermia. Both will give rise to very high body temperature. Both will have dry skin. Both will have complications because of high temperature. What we need to look at is the circumstances leading to high temperature, and this is what will give us the clue. Antipyretics do not reduce temperature in hyperthermia because antipyretics only act by reducing the set point of the hypothalamus, which is not altered in hyperthermia. So in hyperthermia, antipyretics generally do not produce much of a benefit, whereas physical measures reduce the temperature in both hyperpyrexia and hyperthermia. The symptoms could be fatigue, altered sensorium, hypotension, hemoconcentration, DIC, variety of organ damages. So all the symptoms are non-specific. It could be something like a SARS. So multiple organ damages because of the extensive inflammatory changes, very non-specific. So we should have high index of suspicion to diagnose these cases. When do we suspect hyperpyrexia? Whenever there is a high temperature with the dry skin, and the exposed skin could be quite cold. So if the physician or the nurse just touch the patient with the hand and then talk about fever or febrile state, we'll be missing a lot of patients with hyperpyrexia. You just have to touch the unexposed area, then you realize that the patient is very hot, and this is where you must suspect hyperpyrexia. Very hot skin which is unexposed, cold skin over the forehead or the hands, and the skin is very dry. There's rapid shallow respiration, and this is when you suspect hyperpyrexia, and immediately confirm it by checking the core temperature either by rectal or tympanic temperature. Once you have diagnosed, the treatment is quite easy. In the sense, the principles of treatment are antipyretics and physical cooling. It is not either antipyretics or physical cooling. It is antipyretics and physical cooling. Physical measures will reduce the temperature by about 30 minutes, but antipyretics will have a slightly delayed but sustained effect. Only when it's combined, you see better results. To hasten the temperature loss, there should be enough fluids. So give liberal amount of oral and intravenous fluids. IV paracetamol is quite useful in reducing the as antipyretics. Other NSAIDs can also be used. Rectal is also reducing temperature. Sponging with tepid water, not cold water, lukewarm or temperature is required, because if there's cold water, it will lead to more vasospasm and more chills and more shivering and more temperature. That's why application of ice packs or cooling blanket, which were recommended earlier, are not recommended now, because they will be counterproductive in inducing vasospasm and more shivering and more temperature generation. Along with sponging, there should be exposure to breeze, use a fan or other modalities, because evaporation is a very good method of taking care of loss of temperature, and monitor the core temperature frequently. Cooling is mainly for hyperthermia. There, the thermostat is not reset, so cooling is quite appropriate. But for hyperpyrexia, heat dissipation is important. So hyperpyrexia is treated with antibiotics and heat dissipation measures, mainly tepid sponging and fanning, and that will take care of the temperature by enhancing evaporation. IV paracetamol is to be used at the dose of 15 mg per kg over 15 minutes in 100 ml infusions. There are some cautions. Whenever there's decreased muscle mass, depleted glutathione stores will be there, and there will be sudden toxicity. And same is the case if there is prolonged fasting or malnutrition. Be careful when a patient has got renal, hepatic, or cardiac impairment, and if there's dehydration or chronic alcohol intake, it can produce hypotension. It can produce infusion site reactions. Other close mimics of hyperpyrexia are drug-induced causes like anesthetic agents, and interestingly, many of the drugs which are used in extraabdominal diseases, and more and more case reports are coming towards dyskinesia, hyperpyrexia syndrome, Parkinson hyperkinesis syndrome, serotonergic syndrome, neuromuscular syndrome. All of them are characterized by elevated core temperature beyond the threshold of 106 Fahrenheit, and aggressive treatment is required. Dyskinesia, hyperkinesis syndrome is seen when there is a significant amount of dyskinesia and muscle spasm, and that can give rise to hyperpyrexia, can be treated with the dantrolene. Parkinson hyperpyrexia syndrome is another interesting condition. Here it is because of withdrawal of anti-Parkinson medications or stoppage of reduction in the dosage, and that can give rise to dangerous hyperpyrexia, and here the treatment is resumption of dopaminergic drugs. And most of the central hyperthermia can be treated with baclofen or bromocriptine, because they act at the central level, and the peripheral muscle spasm can be controlled with the dantrolene. In conclusion, hyperpyrexia is a maladaptive innate immune response system, and beyond certain threshold, which is arbitrarily defined as 160 degrees Fahrenheit, it is dangerous. There is direct damage and high metabolic cost to the host, direct damage to the organs and tissues, and high metabolic cost in terms of increased oxygen demand and more load on the cardiovascular system. And non-infectious causes are more important than infectious causes. And whenever we treat hyperpyrexia, in addition to the measures to reduce temperature, we should look into the underlying cause, because without treating underlying cause, you can't have long-lasting control of the temperature. Skin temperature, the shell temperature is not sufficient. We have to go and monitor the core temperature, and we'll be missing a lot of cases of hyperpyrexia if we go by measuring or observing the skin temperature only. Tympanic memory is one emerging option, which is quite non-invasive, and it can measure continuously the core temperature, which is a challenge when there is rectal temperature. It's very difficult to monitor the rectal temperature continuously. Hyperthermia is much more dangerous than hyperpyrexia, and physical methods combined with antibiotics are the mainstay of treatment for hyperpyrexia. Thank you very much, and if there are any questions, I'll be happy to take them. Thank you once again.
Sorry, I was muted. Thank you, Dr. Chakrapani, for excellent talk on hyperpyrexia and causes management. And the message is very clear from your side. And now I request the audience to ask any questions. Manjula ji. Manjula, are you there on the line?
Yes, sir. I'm 1 minute. 1 minute, sir.
Any questions? Any questions?
There are no questions here, sir, on the chat box.
Any comments? Any comments?
Alex, Event, can you tell us, are there any questions? I'm not seeing here any questions. Are there any panelists who would like to ask a question? Please go ahead and ask before we close.
If nobody asks a question, I will ask one doubt to Dr. Chakrapani. Sir, the shivering will do cause rise of temperature. But in epilepsy seizures, status epilepticus, we don't come across seeing rise of the temperature so commonly. Any comments, sir?
I agree with you, sir. It is not so common, but there are cases where there is continuous seizure giving rise to more temperature. And most of these cases where the shivering, it is just adding a small component of temperature. All these cases, there is already an insult to the host, wherein the temperature set point is quite high. In addition to that, there is additional shivering that gives rise to extra heat energy to the system and giving rise to a complication. So shivering is not the starting point. It is just a contributing and smaller partner in the whole process. But by giving cold water or by pouring cold water or ice to the surface, we'll be inducing more shivering, which is not tolerated by the host. Second, it is not beneficial. Third, it may be detrimental.
Yeah. And one more question, sir. Sometime back, NEET exam, a question in the Supreme Court, in malaria, what exactly causing shivering? Is it malaria parasite or debris of the RBC? What exactly? The question was challenged in the Supreme Court. I was asked by one of the expert committee member, but there is no evidence in the literature to support anyone. Is it malaria parasite or debris of RBC or free hemoglobin, which is causing shivering? There was no evidence. So we couldn't answer. The question was deleted ultimately by Supreme Court. Any comments?
I don't have a particular answer for it, but my understanding is that the pyrogen in malaria is multiple. It's not just one pyrogen, and all the pyrogens, including interleukins, they ultimately change the set point of the thalamus. It's not only for malaria, any other infection. So it's not one single point. Once the thalamus is at a higher point, all the next cascading events will start, including chills and shivers and other mechanisms to go to reach that level. So I don't have the answer as to which one produces that, but my understanding is it's a multifactorial, ultimately resulting in the set point going up to a higher level in thalamus, hypothalamus.
Exactly. I agree with you. Exactly when we presented this, Supreme Court deleted that question to, again, re-ranking was done.
So there's one last question we'll take, then close the session. What are the key systems to evaluate during hyperthermia, sir? It's from the audience.
Yeah, in fact, every system in the body will be affected. But what is most striking is in hyperthermia is heat stroke, where patient will have CNS changes. The patient becoming drowsy, altered sensorium is the one fact that we should look for. Subsequently, there will be organ damages which can come later also. But initially, when we have hyperthermia patient, the clue comes, a patient who becomes drowsy, altered sensorium, and skin is hot and dry. And the skin will be cold, but unexposed areas will be hot. That's where it starts. And from then onwards, all other systems will be involved, including DIC. We fail to understand that temperature can alter the metabolic environment. It can. DIC can be set in, coagulation can be affected, renal function failure can be there, cardiac involvement can be there. So every other system will be involved, but it probably starts with altered sensorium and CNS involvement.
Okay, thank you, sir.
One of the cause of multi-organ failure.
Sir.
Pardon, sir?
Yeah.
One of the cause for multi-organ failure.
Yeah.
Yes, sir. Yes, sir. The fever itself can produce multi-organ failure, although it starts as a beneficial system.
Right, sir.
By itself.
Okay, sir. Can we move on to the next session, sir? If it is.
Thank you.
Thank you.
Back to Dr. Manjula for next session.
Thank you, Chakrapani sir. Wonderful having you, and Dr. Narasimhalu sir for conducting the session. We will move on to the next session. I request Dr. Ravi sir to chair this session. Dr. Ravi sir is the Director, cum Dean and Professor and Head of the Department of General Medicine, Bangalore Medical College and Research Center. He's a member of State Authorization Committee of Human Organ Transplant of Government of India, past Secretary of API and convener of CME of Internal Medicine, and also avid orator with numerous publications to his credit, both in the national and the international arena. Over to Dr. Ravi sir to conduct this session, sir.
Good morning, madam. Thank you very much for this opportunity given us to share this session where we have Dr. Aladi Mohan. I think he needs no introduction to this august audience, though anyway, it's customary for me to introduce who is a very close associate of ours, Dr. Aladi Mohan, who is Professor and Head Department of Medicine, Chief of Pulmonary Critical Care and Sleep sleep medicine at Sri Venkateshwara Institute of Medical Sciences, Tirupati. Well, he's got more than 300 publications. The feather in the cap is edited more than 4 books, including the textbook of tuberculosis and non-tubercular mycobacterial disease. He's the member International Advisory Board Hutchinson's Clinical Method. I think we don't have a better person to talk to us on this drugs in the treatment of tuberculosis. So over to you, sir, without wasting much time.
Thank you, Professor Ravi, sir. I would like to thank the organizers, particularly Professor Ravi and Narasimlu, sir, for giving me this opportunity to be with you here today. In the ensuing 20 minutes allotted to me, I would like to take you through the perspective of what is new in the drugs that are used to treat TB. I hope my screen is visible to all and I'm heard loud and clear.
Yes, sir.
Right.
Yes, sir.
Yes, sir. I have not received any funding for this talk and I have no conflict of interest to declare. It's known since time immemorial that TB has been enemy number 1 for the humankind. And if you look at the global TB report that has just come out, I think 3 days ago, India still has about 28% of the world TB burden, and India is one of the regions containing the highest multi-drug resistant and HIV TB co-infection in the world. Sheer numbers are staggering. Therefore, we are worried about the drugs that we use to treat TB. The cupboard is not overflowing. In fact, it's about empty. I'm sure at least Narasimlu sir and people of his generation and the TB fanatics today would have read Corwin Hinshaw's textbook. Hinshaw himself writes that no one, including himself, had believed that control of TB would be attained by medical means, that is, by treatment within the 20th century. However, we have gone from the era of hope to hype to depression. In the mid-40s, we started having the anti-TB drugs. By around 1980, we were jumping up and down with joy and ecstasy, thinking that TB is no more a public health problem. In fact, when I wanted to do my MD thesis in TB, my boss told me, "Are you out of your mind? TB is on the way out. What do you want to do?" So we are today at a point where India has the dubious distinction, sitting here as a high burden country for TB, for HIV TB, and MDR TB. So this is a clarion call for us to realize what we have and what we need to do. So if you look at the progress of the anti-TB drug discovery, from around the mid-40s, paraminosalicylate acid, streptomycin, later on isoniazid, pyrazinamide, goes back in a higher dosage, comes back with a lesser dosage, ethambutol, and the rifamycin. And then we had a silent period close to 50 years. Nothing much happened. There were no new drugs for TB at all. The situation changed only recently by the use of what is called as multi-arm, multi-stage clinical trials. All of you know that you have phase 1, phase 2, phase 3, and phase 4 clinical trials. And if you see the number of drugs that enter the phase 1 clinical trial, of these, only 14% would actually be available for you to purchase in the market and use for your patients. So the attrition rate is close to 85%. In this scenario, planning and conducting clinical trials for TB has been tricky. So thinking out of the box, rather than doing a series of separate phase 2, 3 studies, the multi-arm, multi-stage trial strategy aims to answer multiple questions simultaneously under the same regulatory framework. Different multiple treatment options can be compared against a single control arm. And the other technique which was used was re-engineering of old TB drugs. These are examples of re-engineering of old TB drugs. The well-known example is the rifampicin and rifabutin, or the modified versions of rifampicin, as is the SQ109, which is a modified version of ethambutol. The third method, which was out of the box thinking, included the drug repurposing, where the existing or old drugs are investigated for treating other diseases. These are all the drugs that have been used as a repurposed drugs. With these three technologies, the anti-TB drug discovery progressed from here to the situation where we had bedaquiline in 2012. That's not very far away, 10 years ago. Delamanid 2014 and pretomanid in 2019. So if you look at the current cupboard of the first line anti-TB drugs, this is well known to everybody. There has been a relook at the designation of the groups for the drugs used for drug-resistant TB. The group A drugs include the quinolones like levofloxacin, moxifloxacin, then bedaquiline and linezolid. Group B would include clofazimine, cycloserine, terizidone. Group C contains all these drugs listed here, including the delamanid and the newer kid of the block, the pretomanid. Now, I'm not going to give you a huge table list or a carry home message for how to treat DRTB, whether it is MDR-TB, XDR-TB, or monopoly DRTB. You can have all these details, nitty-gritty details in the TBC India website. But I would like to focus upon, in the 20 minutes given to me, because I have Indian standard time, not the Indian stretchable time, I will focus upon the few key aspects related to the newer drugs. As on date, drugs belonging to these chemical classes are undergoing clinical trials world over, many of them in phase 1, several of them in phase 2, 3. Obviously, it is not possible to run through all these. It would suffice to say that we have chemical classes like oxazolidinones, nitroimidazoles, benzthiazinones, diaryl quinolones, riminophenazines, and so on. So this is the absolutely latest document from the global TB drug pipeline, updated the day before yesterday. Among the various drugs which are listed here, we have drugs in phase 1, phase 2, and phase 3, but the regulatory market approvals are available for these, the bedaquiline, delamanid, and the pretomanid. Now, if we look at what these drugs are, the hands-on drugs, because the quorum in this meeting are not hardcore TB researchers. These are people who would be handling TB. So it is better and more logical to talk to them about the drugs which we are actually using that are available to us to treat TB. The bedaquiline is a diaryl quinolone derivative, and two nitroimidazoles, the delamanid and the pretomanid, are the ones that are currently available to us. 2012, in late 2012, bedaquiline was approved for the treatment of MDR-TB in the United States FDA. Later on, there was a Supreme Court case on humanitarian grounds to permit the use of this drug, but the program took up the challenge and had done fast tracking for use of this drug under emergency indication under controlled conditions so that it is not misused. It's a strong bactericidal drug and has sterilizing activities against Mycobacterium tuberculosis. It has an extended half-life up to almost 5.5 months post-stoppage due to the high volume distribution, and has shown significant benefits in improving the time to culture and conversion in MDR-TB patients. It specifically targets the mycobacterial ATP synthase, an enzyme which supplies energy to Mycobacterium tuberculosis. And delamanid is the first approved drug in the class of nitro-dihydroimidazoxazoles. It is a bactericidal drug with a 36 hours half-life. It acts by two different mechanisms, blocking the synthesis of mycolic acids, and it poisons the bacilli with nitric oxide. As per the World Health Organization recommendations, the risk-benefit considerations for the use of bedaquiline in patients aged 6 to 17 years and delamanid in patients aged 3 to 5 years, the young age group, it is also similar to what you have in adults. Pretomanid is a bicyclic subsidiary of nitroimidazofuran. It has a potent activity. It is a prodrug that is converted to an active form by the nitroreductase enzyme, which hinders the amalgamation of the cell wall lipids and proteins. It inhibits the Mycobacterium tuberculosis in two ways: as an intracellular ATP exhaustion by functioning as a nitric oxide donor, and by preventing the synthesis of mycolic acid, which is an essential component of the bacterial cell wall. So how do we design regimens using the newer drugs, the repurposed drugs, the re-engineered drugs, and the available other second-line drugs? In the olden days, we had regimens based on whether it was a new patient or a previously treated patient, depending upon disease severity and the category of treatment and so on. Today, we have a wider access to technology, newer diagnostics, and newer methods of drug susceptibility testing, as well as drug resistance testing. And so this algorithm, I'm not going to read out and explain to you, but needless to say, this algorithm will give you an idea regarding how well the regimen constitution, regimen designation has been planned in the NTEP under the programmatic management of drug-resistant TB. The guidelines came out in 2021, not too long ago. So you have regimens for drug-sensitive TB, you have regimens for isoniazid monopoly drug-resistant TB, and you have regimens for the MDR or the surrogate of rifampicin resistance TB, and we have longer regimens for XDR and MDR TB. So what is expected to come up? We are having a good insight into the newer drug delivery systems, like your self-nano emulsifying drug delivery systems, lipopolysaccharide polyalkylate complex systems, the haloicite nanotubes, nano cages, nano composites, nanopolymers, nanospheres, myosomes and vesicles, and so on. These are being still studied and are in the process of getting converted from the bench to the bedside. The bench work is promising. The bedside work is expected to happen in near future. So what is the situation for the treatment of TB today? We have standardized regimens for drug-sensitive and drug-resistant TB. We have the drug susceptibility testing based regimens. We have regimens for treating latent TB infection too. And we have newer regimens in the pipeline. There is a 4-month regimen which is expected to be available soon as a part of the program. The studies are going on in certain sites due to constraints of time and the fact that it is not yet program policy. I have not given the exact details of these, and I would like to conclude here that after the hype which was generated by the anti-TB drugs becoming available and the hope it generated, to the depression it created with the emergence of drug-resistant TB, and gradually our realization with smart thinking to inculcate newer drugs to treat TB, and there is a real-time hope for reducing the treatment duration, both for drug-sensitive and drug-resistant TB, and there is a push now for the all-oral treatment for drug-resistant TB. I conclude here on a very fast-changing canvas, and I request you to keep track with the program. It is futile and foolish to treat drug-resistant TB with newer drugs on an individual basis. The Government of India and the National TB Elimination Program have done very well to provide all this at no cost, not low cost, at no cost to the patient, with active involvement of all the medical colleges across the country. I conclude my presentation. I think I have stuck to my the time given to me, which is approximately 20 minutes. And over to Professor Ravi.
Thank you, sir. Thank you for doing that justice in the time given to you for in the 20 minutes. As always, in mastering the treatment of tuberculosis. So I just got you showed us a lot of newer drugs in the pipeline. With the development of these newer drugs for tuberculosis, will we be really able to achieve the TB Mukt Bharat?
That's a good question, sir. Actually, the whole world wanted to eliminate TB by 2035. We want to do it by 2025. And 2025 is just year and a half or so away. So the point here is these newer drugs will not be available in our armamentarium for eliminating TB by 2025, maybe by 2035, because even with the MAMS, the multi-staging strategy and all those things, it takes minimum time. Even for drugs to become available for COVID, it took from more than a year and a half. So new drugs are not going to save us. But what I expect is the widespread availability of newer diagnostics to pick up drug. Like when we were students, we would know whether it is MD or TB at 12 weeks. Today we know in 90 minutes by using gene expert. So there is nothing like we will first treatment fails, then we will start the second line drugs and all. Upfront we can treat it just like you treat a urinary tract infection. So that appears to be the hope, but we are still a long way, sir. There is a long gap between the cup and the lip.
Yes, sir. One more question. With the advent of these newer drugs, will there be decrease in the duration of therapy? Because most often what we face challenges is the drug adherence in these patients with tuberculosis.
Yes, sir.
The duration is 6 months, and we see patients after 1 month,
sir.
he feels all right.
The issue with there is a 4-month regimen which includes rifampicin. It is in trial, sir. It is in trial in the NTP sites, and the initial results, which we heard in a meeting, not yet published, not yet peer reviewed, they appear promising. I hope to see before next year end the introduction of a 4-month regimen. For drug-sensitive TB, from 6 months, 4 months is the reality. There is work going on a 2-month regimen also, sir. This 2-month regimen is a little far away. 4-month regimen appears to be realistic, free to the patient under the program.
Thank you, sir. Any other questions?
I have one comment, Ravi.
Yes, sir. Please, sir. Dr. Narsimlu.
Already, see, in 1980, there are a lot of trials of 2 months, 4 months, 3 months, 6 months, 9 months, 1 year. The relapse rate was high in 2 months, 3 months, and 4 months. Only 6 months and 9 months was successful. At that time, 4 drug trials of INH, rifampicin, ethambutol, rapamycin, like that were using. But again, unless new drugs have come, same drug repeating for 2 months, 4 months may not have a rationality. Second question.
Sir, here I would like to respond to your query, sir. Basically, once rifampicin became available in the 80s, the regimen had become 9 months. Once pyrazinamide came back with a lower dosage, the regimen became 6 months. So 6 months was the bottom line for a long period. And to permit any regimen to be used in real-time practice, in a follow-up period of 2 years, the relapse rate should be less than 5%. That is acceptable for a regimen to be used either in the program or in practice. So the newer 4-month regimen and all, The initial results look promising, like you told, and the follow-up is going on. In some centers where the follow-up data are available, the relapse rates are less than 3%. That is why we feel it is promising, sir.
Are the drugs approved by FDA already?
Yes, sir. All these drugs have been formally approved. The government of India, the DCGI in the Indian context,
No, by
have
FDA.
formalized.
By FDA.
Sir?
By FDA.
Yeah.
US FDA has that, the ones I've talked about, the bedaquiline, the delamanid, retomanid are approved by the US FDA. The newer ones of phase 2, phase 3 trials are not yet approved, sir. Rifampicin, rifabutin are approved, sir.
I'm sorry, one point I want you, I didn't cover the blood-brain barriers crossing how much in new drugs. And TB meningitis, CNS tuberculosis also, we are very keen. How much drug will cross blood-brain barrier?
It's a good question.
Any data?
The data from clinical phase 2, phase 3 are available, sir. But most of the studies are on pulmonary TB because you have a tangible starting point, a smear which is testing positive, and cure defined as smear turning negative. So pharmacokinetic data in the CSF are available sparsely in human studies for these newer drugs. We await their further validation, sir. But the aminoglycoside, streptomycin has very good penetration to the CSF. Pyrazinamide has very good penetration into the CSF, especially when the meninges are inflamed, as in TB meningitis.
Anyway, excellent talk. Very good information already.
There's one question. Can I take?
Madam, 1 minute, madam. Dr. Ghanshyam Pandey has a query, I think.
Okay, right, sir.
Good morning, sir. Dr. Alladi Mohan, sir. Wonderful lecture. In 20 minutes, you have covered everything from history to the present scenario. I have, sir, still have some few queries. Like in Delhi also, I'm working in Lady Hardinge Medical College. These drugs and these bigger hospitals are not, I don't know why they have not taken the TB as a priority. You are a pass out from AIMS, sir. Still, I don't think drug-resistant TB is well treated, or it's a main center for tuberculosis in medicine department. Your guide, Dr. S.K. Sharma, was there. So there's an infectious disease, whole DM is there, but I don't think they take drug-resistant TB. And so most of these tuberculosis management and all, a lot of thing has been taken by chest medicine, not internal medicine. So when it's a systemic disease, you have a TB meningitis, you have patient who develop a lot of different organ system involvement. So some hospitals are there, they are chest hospital like LRS and all. They don't take those patients. They say we are chest medicine, we are not going to take those patients. So we medicine people should take some.
I totally agree, sir. I am also from internal medicine, as is Professor Ravi. It is we who take the burden of the difficult to treat TB. And we have now, even for extrapulmonary TB, we have diagnostics available free of cost to the patients. One should encourage at least CSF, lymph node, and all tissue which we procure, we should subject it to expert, so that in 24 hours, practically we can get whether M tuberculosis is detected and the R resistance is detected. And the regimens are available. Now the government of India is expanding to have a DRTB ward in through the NMC, they are pushing for DRTB ward in every medical college where there are postgraduate courses and so on. I hope it will materialize, sir.
We hope so. Thank you, sir.
So there is one question on the 2, 3. Can I take? Is the time permits?
Yes, madam, please.
So the one question is there any evidence that suggests that intravenous administration of anti-TB drugs, for example, linezolid, meropenem, results in earlier resolution of symptom and bacillary burden as compared to oral administration?
This is a good question. When we do the pharmacokinetic studies for the injectables, the idealized data look promising. But to make a patient take an injectable daily for weeks on end is neither practical nor feasible. So given that context, the paradigm shift today is to go towards an all oral regimen. so that the drug compliance is enhanced, and all oral regimens which are not inferior to the regimens containing the injectables. So non-inferiority trial designs have been used to establish this fact. Yes, parenteral administration has advantages, but sustainability in terms of the patient compliance for the duration of treatment is the catch here.
So there is one more question. What are the causes for not enabling us to eliminate TB in spite of making earlier diagnosis?
Good question, sir. The reasons are too many. The bug is very smart. As we make our own efforts to corner it, it keeps coming back. It is as old as a humankind. Like, for example, if you now COVID is gone, masks are gone, you walk on the streets of any town, city, you find at least 30% of the people spitting on the roadside. What amount of drugs, what amount of diagnostics will change this? So it is not merely drugs or diagnostics, sir. It is the effort from the side of the society and from the side of the medical and engineering personnel to prevent airborne transmission. That would be the key to eliminate TB, not using more drugs or a battery of drugs or diagnostics.
Yes, sir.
Thank you, madam. If there are no more questions on behalf of FeFCon, I would like to thank Dr. Alladi Mohan, who gave a wonderful talk on this in a very brief period of 20 minutes. Thank you, sir. And again, thank you, FeFCon, for giving me an opportunity to share this session. Thank you, madam. Over to you.
Thank you, Dr. Mohan, sir, and Dr. Ravi, sir. Thank you for making it a wonderful session. Now we move on to the next session. That is, are we missing typhus? I think Dr. Shekhar Chakravarti is stuck in another session. They have having a local IMA conference, so he's taking session. So our savior again, Dr. Narsimulu, sir, I request you to kindly chair your session, your friend session. Dr. Chandrasekhar, sir. So over to you, Narsimulu, sir.
Thank you, Dr. Manjula ji. I am very much privileged to address my friend Dr. Chandrasekhar. See, Chandrasekhar, you are most welcome and to see you in person and also in photo and also virtual. And that Chandrasekhar is a very good friend of mine, and he was now past chairman of API Telangana, and last year he was chairman scientific committee. The conference conducted in Hyderabad. Recently, we conducted a conference in Warangal. Mainly, he was organizing secretary and very dynamic. He tell me the administrative angles is one of the excellent. He was made medical superintendent, and we was Professor HOD, Kakatiya Medical Warangal. And practically, if option is there, I want to say write Chandrasekhar Medical College Warangal, but I don't have that power. What Chandu? Am I right? So he's a Warangal and Chandu inseparable. So such a great personality is a publication, academician, administrator, organizer, and many more things I am telling which are not mentioned in this biodata. And scurf typhus, very, very important and not popularized. I think often clinically we miss it diagnosis unless serology data comes. Chandrasekhar kindly educate us in such a way we don't miss scurf typhus. And before lab test, clinically we should make a diagnosis. Over to Dr. Chandrasekhar. Thank you for your good laugh.
Sir, thank you very much, sir, for your kind words. I am not deserving to the description given, sir. It is only your love and affection from the time to time we are receiving from you in organizing conferences and all those things, sir. And coming to my talk, shall I share my screen?
Yeah. Yes.
Yeah, just I'll share my screen. So is it okay?
Yeah. Perfect.
Okay, I'm audible also, no?
Yes.
Yes.
Okay.
I've seen also.
Yeah. So at the outset, I thank organizers, particularly Narsimulu sir, Muruganathan sir, Manjula madam, and all other dignitaries on the dais as a faculty and colleague faculty persons and audiences. So very good morning. And we are talking on the topic that are we missing the typhus? The question has come and I need to answer. The precise answer is we are missing, yes. Because it appears in the many forms: epidemic form, endemic form, classic typhus, scrub typhus, and many a times it is misdiagnosed as typhoid, particularly in tropical countries. It is overlooked in many of the acute febrile illnesses because symptoms and signs, including stupor, rash, hepatosplenomegaly, thrombocytopenia, shock, capillary leak syndrome, multiple organ failures, all are non-specific, and we have a big differentials list. So common among the differential diagnosis is the dengue, malaria, typhoid, brucellosis. But one other important thing is a typhus can be co-infection with the dengue, malaria, typhoid, everything too. And this painless papule, which may be pathognomonic, called as Ishkar, or subconjunctival hemorrhage in the course of acute febrile illness, could be pathognomonic, and Wheel-Phillips test may support the diagnosis. All are again not confirmatory. But this typhus needs a confirmation because treatment is different and treatment is available too. Cheapest treatment, and it is available, and it will be preventing from the fatality from 100%. If untreated, mortality will be somewhere around 13% to 40% maximum. Even in this modern area, because of all the said reasons why we are missing and neglecting, misdiagnosing, overdiagnosing, overlooking, because we are not adopting the oldest principles in this modern era, that is high index of clinical suspicious and empirical treatment as far as possible are the only mantras. So hence the talk summaries don't give any chance to miss the typhus. So with this brief introduction, I'll go into the history. So the typhus means it's a confused state. So any confusional state holds good for the diagnosis of typhus. It is a febrile illness, it is exanthematous illness, and usually associated with the nervous system, which is described by the lipidemion. So it is a classical epidemic typhus versus plague versus measles versus smallpox. So this is the big differential in the 430 BC. So it is a disease of war. It is 6 times more common in the wars. So particularly all the examples are there: 1492 in the Civil War of Grenada, Segrave warfare in the French, and during the 14th century, 5 epidemics are there in the UK. And so in the 1546, it is differentiated plague from typhus. So since there, it is a contagious disease. So during the 1820, there is a 40-fold increase in these typhus incidents because of many that scrub typhus variety, which is spreading from mite to arthropod to human beings. So there is a Charles Nicolet who discovered the Pediculus corporis, which is commonly called as body louse. He is a vector for this epidemic typhus. And rickets, so who described the organism in the blood and body fluids of feces of the body lice. And this Provacek died, Provacek and as well as Rickards died from the same disease during their research efforts. So that is the reason why the Provaceki and Ricketsia are the names retained. So during the Second World War, latest scrub typhus is the most common, and murine or endemic typhus is also very much there. So major impact of the scrub typhus is it is impacted a medical research, causing so much of improvements in the diagnostic, prevention, epidemiology, clinical management, and transmission. So much of history is there. So there is a correlation. So to prevent the outbreaks by burning the cloths, changing the bedding and all. So this holds good for till today. So it is very effective in reducing the mortality. And with this, there is a promotion of the epidemic, the understanding of the epidemics and contagious notion has started. So in the 19th century, this illness is subdivided into typhus, typhus like typhoid, and relapsing fevers. Since then, clinical syndromes have been made very important, like exanthematous fevers and abdominal or enteric fevers and recurrent fevers. So this is the how it is divided, the so-called typhus, typhoid, and relapsing fevers. And rickettsial diseases, scrub typhus epidemics, many things are there. Bilharzia is there. I will touch upon one by one. Rickettsia are small gram-negative obligate intracellular parasites, and the vectors being arthropods like lice, fleas, ticks, and mites, and humans being infected. When infected in the human beings, it grows in the vascular endothelium and reticuloendothelial cells. So it is the epithelium of the vector to the endothelium of the human being. So since that it is endothelium, so it will cause the vasculitis, and the vessels are affected in the multi-organs. So the scrub typhus, the chigger bone typhus, it is called Tsutsugamushi fever, it is called, and caused by the Orientia tsutsugamushi, and spread through the thrombiculoid, that is called larva laying mites, that is chiggers. So rodents are also infected, but humans are the accidental host in this infection. So first described in the Japan, that is the reason why Tsutsugamushi is the Japanese word, meaning that it is a dangerous mite. And scrub typhus is very common in India. So because scrub is a term used for the different types of vegetation, tall growing coarse grass. So it is common in the forest, gardens, beaches, paddy fields also. So this is the Tsutsugamushi triangle from the Middle East to Far East and most of the Southeast Asian region. And India is also one of the affected country for the scrub typhus. So it is underdiagnosed and underreported because the 1 billion people are at risk for the year, and 1 million cases are incidented, reported annually, and the case fatality rate in untreated cases is from 1 to 60%. So it all depends upon the type of area where it is reported, type of strain, and the previous exposure of the this one, and it is also correlated with the age of the person. So from India, specific data is not available, but still it is reported from the Rajasthan and Vellore and sub-Himalayan belt, particularly Jammu and Kashmir up to the Nagaland, it is seen. And scrub typhus in India is the re-emerging infections. So like the COVID, what we have, it is a re-emerging form of influenza in a different form. Like that, you cannot take, because we are living in the modern era, because lot of advanced antibiotics are there. So typhus can't do anything. No, it is highly fatal if you are undiagnosed, started treatment in the time. So there is also resurgence because from the World War II to latest war in 1965 Indo-Pak war. And scrub typhus outbreaks are reported in the Himachal Pradesh, Sikkim and Darjeeling in 2004 and 2007, and sporadic incidences are seen across all across the country. It is associated with the terrain type, and many cases are within, to say the outbreak. So the terrain is important, number of cases in a certain focus is important, and number of people infected simultaneously following the exposure is important, and absence of history of the bites. History of the bites will, for epidemic or endemic typhus, for scrub typhus, there is nothing like a noticeable bite of the mite. So there is a period of epidemic influenced by the activities of infected mite. So usually it is a seasonal, a rainy season, particularly in South India, it may be the winter. So the areas affected are the forests and river banks and grassy regions. So coming to the agent, it is Orientia tsutsugamushi, reservoir is the chigger mites, and vector is a very small which inhabits in soil, particularly where the micro ecosystem is favorable. So either in the forest vegetation or secondary vegetation after clearance of the forest areas and the grasses and herbs. So here, if any mice is there, mites are there. So particularly Leptotrombidium delineans, which is a vector for scrub typhus. So usually this will be by the mite larvae called as chiggers. So mite feeds their bloody meal from during the life cycle, but adult mites do not feed on the man. So when they die, So these infective agents will be present in the feces. So usually by rubbing, because of the scratchy, itchy area, so that fecal particles which contains the these Orientalis, so which will enter into the circulation and cause. So the normally larva feeds on small mammals. So the enlarged larva and adults, even though they will not bite or cause responsible, but humans are the accidental host in this entire life cycle of infection. So risk factors for the human infection, it is sometimes occupational also, particularly rural settings, but in urbans are also there is outbreaks because of the urbanization of the rural areas. So habitats are, I already told you, it's sandy beaches, mountain deserts, equatorial rainy forest. Incubation period is 5 to 20 days, but usually 10 days time after the initial bite. So coming to the signs and symptoms, chigger bite is painless. Sometimes there may be a localized itch because of which they may rub. So it will cause the local infection, so that there may be what is called local lymphadenopathy. So most common sites are the groins, armpits, and genitalia and neck. So usually a papule will develop and will become ulcerate, and it will heal by a block scar. It will mimic like a cigar mark. So there will be a sudden chills and high-grade fever, headache, photophobia, myalgia, apathy, swelling of the lymph nodes. And 1 week after that initial illness of acute febrile illness, so there is a maculopapular rash, so which is on the trunk, and later on will go to the limbs, but always palms and soles are not affected. So complicated include pneumonia and meningoencephalitis, myocarditis. Pneumonia sometimes in the aerosol form also, it may be inhaled. That is the one reason. So coming to the diagnosis, I said because the symptoms and the signs are very, very non-specific, until unless you have a high index of suspicious, you can't diagnose it. Diagnosis basically depends upon culture. So when culture requires the laboratories like biosafety 3 level, so whole blood is the sample, and skin biopsy from the eschar or a rash or papule or macule which is more than 4 millimeters. So that culture is usually sensitive in acute phase before starting of the antibiotics. The second way is to diagnose the molecular, that is by PCR, to detect the rickettsial DNA. So again, whole body is the best than serum, and biopsy is the best than the skin scrapings. So this is also sensitive, more sensitive in acute phase, but it has a window of 0 to 48 hours of starting antibiotics also you can trust. But usually what is available for the diagnosis is serology. Serology is detecting the IgG and IgM antibodies. IgM is in the first week, IgG in the third week. So when IgG comes, it is a total zero conversion. So if you document 4-fold increase in the IgG titers, so within the 2 weeks of span, it is confirmatory. That means no single test, like in the case of Vidal. In this case, wheel Felix is also useless if you have a single test. So in the wheel Felix, there is also a cross reactivity, and false positives are positive, particularly if you are contemplating the infectious mononucleosis in some patients with HIV. So a infection with the scrub typhus will lead to the lifelong immunity. So that is the reason IgG antibiotics may be persistent throughout the life. So that the wheel Felix cannot be useful if in a particular, it is not useful at least for the efficacy of treatment. So whether it is totally gone or not. So other investigations like blood picture will show the leukocytes may be increased or normal. There is a definite thrombocytopenia, again confusion with dengue and all. So liver enzymes may be raised, SGPT and SGOT, and creatinine will be raised because it may induce AKI in the part of multi-organ failure. So if you are going for the imaging, so either chest X-ray or CT scan, you may get the ground glass appearances and also some consolidative patches. So there is a big list of differential diagnosis: malaria, dengue, chikungunya, leptospirosis, relapsing fever, common typhoid fever, and any acute encephalitis syndrome, meningococcal or otherwise viral, also Japanese encephalitis and all. And for the cutaneous things, cutaneous anthrax is also in the differential diagnosis. So these are the commonest antibodies detected by the wheel Felix: OX19, OX2, and OXK. So OXK is highly suggestive of scurf typhus, and OX19 is suggestive of both epidemic and endemic. Indian tick syndrome is OX2. So all these panels can be given, and you need to interpret. So what is the type of this typhus, scurf typhus or epidemic or endemic? So the treatment is only simplified treatment, either oral or IV doxycycline, which is most commonly used, which is the drug of choice, 100 milligrams, repeated 12th hourly from 7 to 15 days. Results will be coming within the 48 hours of initiation of the treatment, but sometimes a combination therapy with the doxycycline and rifampicin, particularly in areas where the poor response to doxycycline is taken, and if the doxycycline is contraindicated or sensitive or anything, so alternatively you can go for azithromycin or chloramphenicol, either oral or parenteral. Also azithromycin 500 milligrams once in a day for 7 to 10 days, chloramphenicol 500 milligrams 6th hourly, again 7 to 10 days. So the vaccine is developed after World War II, but it is not commercially available. So prevention is the only thing at individual level. So full length clothing and walking without barefoot is abandoned, and insect repellents has to be used to avoid the insect bite, mite bite and all, particularly diethyl thalidomide. And community wise, rapid case identification by the public authorities and public education about how to protect themselves, and rodent control, and improving the living conditions, and clearing the vegetation, and a chemical treatment for the vegetation. So these are the important. And typhus as a biological weapon also, because it is in the inhalation form also, it will cause the feces of the mite. So it will be living for few weeks also. So this will cause a biohazard also because of this nature. So the World Health Organization, a 50 kg of aerosolized typhus in a city of 5 million would result in 3 lakh people exposed in 30 minutes, and 1,25,000 people will become affected with the illness, and there could be possible 8,000 deaths. So epidemic typhus is a classic typhus. It is seen in the war and famine. Coming to India, it is rare, but endemic part of epidemic typhus is Kashmir, and it is caused by Provazaki, and vector is the body loss, pediculus humanus corporis, and rickettsia multiply in the gut of the lice, which appears within the feces in 3 to 5 days. Lice may succumb infection within the 2 to 4 weeks, but they can transmit the infection after about 1 week of being infected also. So because of this wide gap, so you cannot expect a infection immediately after the lice have been bitten. So particularly in poorly maintained the beds and beddings, so these are to be taken. Again, here endemic is 5 to 15 days of incubation period. Again, there is a characteristic rash which develops on the 5th day, and on the 2nd week, particularly this patient will develop real typhus, that is stuperousness and deliriousness. So case fatality rate in the epidemic typhus is up to 40%. It increases with the age. So there may be a latent infections which may be reactivated when the immunity is down. So the recurrent typhus, otherwise called as Brill-Jenser disease, so which is maybe also seen in few of the cases. So coming to the endemic, it is a murine typhus. It's a milder than epidemic form. In India, certain packets are there from Pune, Lucknow, Mysore, Kolkata, Hyderabad, and Kashmir and Rewari. So it is caused by R. typhi, and it is transmitted by rat flea. So, and So coming to the clinical features, headache, fever will be there in 12% of cases. Rash develops in 54% of patients, and all other nausea, vomiting, diarrhea, abdominal pain are very non-specific symptoms. So here also, though it is a milder disease, case fatality rate 1%, and here this epidemic typhus is associated with respiratory failure in almost 10% of cases, and renal insufficiency and brain involvement causing coma, seizures, some polyneuropathies, acute transverse myelitis. So many neurological conditions will be seen with these typhus. So there are many spotted fever groups are there. So one is important for Indian point of view, that is tick typhus, Indian tick typhus, which is caused by R. conuri. So here certain pockets, particularly reported pockets, are Allahabad, Narsapatnam, Ratlam, Secunderabad. So many are there. So the tick, which is species of Rhipicephalus sanguinaris, is the most common vector, and it is found in the dogs also. So some species of Haemophilus, Hyaloma, ticks may transmit the infection. So that's all about the various types of rickettsial disease. So any rickettsial disease, the treatment is same with doxycycline, azithromycin, and other things. So as I said, my take-home message, which was told in before slides, because it is question to the answer is that one. So thank you very much for giving this opportunity, and I'm ready for any questions from the audiences. Thank you very much. I think I maybe crossed 2 minutes overshooting in a given time.
No
So sorry
problem,
for
sir.
that, and
It's
thank you.
fine, sir. Okay.
Thank you. Thank you, Dr. Chandrasekhar, for excellent coverage of the scalp typhus. I'm sure we don't miss this scalp typhus year afterwards, and not only make a diagnosis, the treatment very simple, already available drugs and cheap drugs, so nobody should suffer because scalp typhus. And prevention also we have to take care, which you already covered. And just one thing, next session is an internal speaker. We are going behind time. Already come on the line, so we're not able to take questions. You put the questions, we'll answer in the chat only. So back to Dr. Manjula. Once again, thank Chandrasekhar audience. And now session is back under control of Dr. Manjula.
Thank you very much, sir.
Thanks.
Thank you,
Thank you.
Dr. Chandrasekhar, sir.
Thank you,
It was wonderful
Thank you.
having you. We move to the next session. There are no questions on the platform also. That's what. So there's later also, if you delegates, you can post it. I will hand it over to Dr.
Okay.
Chandrasekhar. So he will in turn reply, and we will ensure that it reaches you. So we move
Sure.
to the next. Thank you, sir. To the session on brucellosis. Over to Ghanshyam, sir. Over to you, sir. Dr. Ghanshyam Pangte is a professor of medicine at Lady Hardinge Medical College, New Delhi. He is in charge of rheumatology and medicine ICU in Lady Hardinge Medical College. He is a joint secretary of Indian College of Physicians and API Delhi chapter. He's the executive member of Delhi Rheumatology Association. He's associated editor of API Textbook of Medicine, published more than 100 indexed and non-indexed articles in reputed journal. He's co-edited several books, to name a few: Pearls of Scientific Paper Writing, Research Methodology, Ethics in Clinical Research. And he is also a very renowned teacher and a speaker. He's the speaker for teacher for MD and NB, postgraduate teacher, examiner for Delhi AIMS and Rajasthan AIMS as well. Sir, over to you, Dr. Ghanshyam, sir. It's a pleasure having you. Over to you.
Namaskar, ma'am. Good morning, ma'am. Good morning, Dr. Manjula and the whole FeFCon team for giving us the opportunity to be part of this FeFCon conference. And since morning, wonderful lectures are going on. We had a very good lecture by Dr. Alladi Mohan. Whole of the tuberculosis has been covered. Now we have come to the atypical infections. The last lecture was typhus, and now we'll go to another difficult to diagnose and treat infection, which is brucellosis. And we have a very learned speaker. We have Dr. Sudha Vidyasagar with us. She is a HOD of Medicine in Voluntary Health Services Hospital, Chennai. She has been head of the department of KMC Manipal. She has been passed out from Stanley Medical College and MD from KMC Manipal only. She has been awarded Good Teacher or a Great Teacher Award from KMC almost 7 times during her tenure. She has number of research publication, more than 152. She has been awarded Professor N. Srivastava Award by RSDI. So she's very active in diabetes group also. And she has received multiple grants from ICMR. She has been chair of pre-diabetes team of Manipal. And she has been principal investigator for 15 international trials. So she will be talking on very difficult to diagnose, because if you ask me personally, I have also heard brucellosis and all, but I have never been able to see a real-time patient. And a lot of patients will come with atypical presentation like arthritis and all. They may come with a chronic symptoms also. So it's all over to Dr. Sudha to highlight us when to suspect the brucellosis and how to treat and how to manage these patients. Dr. Sudha, ma'am, over to her, ma'am.
Very much, doctor, for your kind introduction. Am I audible? Are my slides shared, please?
Yes, ma'am. It's come up, ma'am. You just have to put a slide.
Okay. Yeah, I'll just put. Yeah.
Yes.
Actually, I should thank Dr. Muruganathan because I met him in the RSSDA conference in Chennai, and casually he asked me, "Can you talk on brucellosis?" I said, I'm very willing to talk because I've seen a lot of patients with brucellosis. I thought the comfort zone for any clinician comes when you see a patient rather than talk from a textbook. And so I readily agreed to take up this topic. And that's why I'm delivering this talk. As the chairperson mentioned, brucellosis is not a common disease, but where I worked in Manipal, we used to get a lot of patients from North Karnataka who are cattle farmers, and we have made diagnosis of brucellosis in several of them. And in this talk also, I'll be sharing some of the cases that we have seen. In fact, most of the cases I'll be presenting is what we have seen and diagnosed. So the topic was ideally called brucellosis, a disease of mistakes. We will try to ask ourselves, why is it a disease of mistakes? What mistakes are common? Clinical mistakes, lab mistakes, treatment mistakes, and how to avoid these. Now, if you look at brucellosis, one of the 7 most neglected diseases in the world, according to WHO, and the brucellosis prevalence in cattle is 13.5, and it is maximum in the northern states of Punjab. This is from a serological prevalence that I'm talking about. And if you look at the prevalence in humans, the serological preference is anywhere between 0.9 and 18.1. That means it's a huge range. So some areas in India see a lot of brucellosis. Like I said, in North Karnataka, when patients used to come to us in Manipal, I've seen so many cases, but after moving on to Chennai, I've hardly seen any. And Punjab in India is probably the highest prevalence of brucellosis. Now, how does brucellosis come about? Of course, it's transmitted from to humans from cattle, and by the consumption of unpasteurized animal products. My patients who came in Manipal used to actually drink raw milk because they thought there's nothing wrong in that, and the concept of boiling the milk and drinking was not there, and very intimate contact with the animals, like contact with the skin, mucous membrane, infected tissue, and all body fluids of the animals was the reason why brucellosis is common in people who deal with cattle. And like I said, the mistakes about transmission is most of these farmers, if you ask them, how come you're drinking, raw milk like that? They said there's nothing wrong. We are used to it. Our parents did it, our grandparents did it. So there's nothing wrong in it. You don't get a disease by drinking raw milk. And they used to think the only thing they can get from cattle is skin infections, which is what they used to tell me. But they also deal with the animals in a big way, like they put intrauterine medication. They never really clean up their cattle. They don't test the cattle before buying. So there are a lot of misconceptions about transmission in people who deal with these animals, and that's the main reason. So that's the first mistake, not knowing how it is transmitted. Add to this fact is the fact that Brucella can survive for a very long time, like in milk for 2 days, but 3 weeks in frozen meat, 3 months in goat cheese, and in animal excreta, 40 days. So the organism, once it is there, is not going to go away and is waiting to get transmitted to the next human who walks by. This is a study which I found interesting, came out in 2022, which is talking about the risk of exposure between animal handlers, para-veterinarians, and veterinarians. So when they did this, they found that the animal handlers were the people who were really at risk because their knowledge of the disease was poor. They were just people who are farm helps and people who helped in the maintenance of these animals or the running of the farms, and they had very little knowledge. But the veterinarians and para-veterinarians were better educated, wore their gloves, wore their PPE while conducting deliveries, etc. But the animal handler did not have it. So this paper again emphasizes the fact that knowledge is probably your best protection against Brucella. Now, I will go on to mistakes that we practice, and I will go through this. Now, this is what UpToDate calls the clinical manifestation of brucellosis, says fever, malaise, night sweats, arthralgia, hepatitis, splenomegaly, etc. But this is a patient who came to us, a lady who came with low backache, presented to the orthopedics department. She had fever on and off for 2 months, but because she had backache, she went straight to orthopedics. They did a neurological examination, they MRI'd the spine, everything was normal. Then they referred to us because the counts were high, the ESR was high, counts were low, ESR was high, and she had a fever. That's when she was referred to us. And then she was treated with so many antibiotics, suspecting infection of all kinds. And somebody started her on an anti-tuberculous treatment. And there was a partial response. And we will understand why once we know the treatment of brucella. And it was proved by blood culture to be brucellosis. Once we asked for a blood culture, the diagnosis came and the patient completely recovered from the backache. So one of the ways by which brucellosis enters the hospital is not through the medicine department, but through the orthopedics department, because many patients present with low backache and various arthralgia and other manifestations. This is a study which came out quite recently, 2022, which talks about acute brucellosis, knee arthritis complicated by acute osteomyelitis. This came out very recently. Here they proved the organism from the synovial fluid, and they did an RT-PCR for brucella, which was positive. Now, this is a case report that we published from Manipal. This is a brucellosis in a patient with ochronosis. This patient had this inborder metabolism, alkaptonuria earlier, but everybody thought that is the cause of her arthritis. But ultimately, we proved that this patient has a brucellosis, and once we treated, she at least went back to her previous level of functionality. So arthralgia, arthritis, low backache, osteomyelitis, all these are manifestations of brucellosis, and that is why they come as mostly references from various departments to medicine rather than coming to medicine firsthand. There's yet another patient of ours who presented with pancytopenia, hepatosplenomegaly, lymphadenopathy. She was investigated for a hematological malignancy, in fact, extensively. Somebody had done a bone marrow on her, that is some lymphoma, leukemia, something like that. And somebody had done a B12 levels because of the pancytopenia. And a blood culture was done. Okay, blood culture was done negative for all organisms. We did think of Brucella serology, again negative. But when we did a bone marrow culture, that is when we proved that this was brucellosis from a positive culture in the bone marrow. So again, the point is that when you see a patient with pancytopenia, of course, we have the usual suspects. We have the B12, which is the commonest cause. And then we think of, some kind of aplasia, or we think of, other infections, HIV, things like that, other infections. But brucellosis is one thing that we should keep in mind, especially when you have hepatosplenomegaly, lymphadenopathy, long drawn fever, and active contact. If it is there, then we have to do a bone marrow culture and see the investigations there, which are putting us off track, that the blood culture is negative, the serology is negative, and you're ultimately proving with the bone marrow. Now, one more interesting case, this again we published. 35-year-old cattle farmer presented with fever, weight loss, and embolic stroke. He had hemiparesis. Aortic valve showed vegetations, infective endocarditis. So we thought, okay, he's got infective endocarditis, he's got an embolic stroke, he's thrown an emboli into the brain, CT showed infarcts. But one thing was standing out like a sore thumb. What is the cause of fever in him? So, okay, infective endocarditis, no organism. scrub typhus, TB, blood cultures, the 3 blood cultures, half an hour apart, all that we did, all tropical infections were negative. Then we did a Brucella. The Brucella agglutination test came as 1 in 1280, which is a really, really high titer. And then we made a diagnosis of Brucella endocarditis with an embolic stroke. And this is again a publication of ours. This is the CT scan showing the infarction. And this is where we published. It shows that on a native aortic valve, this patient developed an endocarditis, presented with a fever, and then presented with infarction. And when we diagnosed Brucella simply because of the serology, and then we treated him. So this is again a very odd presentation of a brucellosis, a Brucella endocarditis, presenting like a neurobrucellosis. Initially, we thought it was neurobrucellosis. Okay, we treated him with the 3 antibiotics that we had, and we did an aortic valve replacement in him, and we proved the diagnosis of Brucella endocarditis. Though the culture from the valve did not grow Brucella, the titers dropped and the patient became better, and that is how we proved the diagnosis. So Brucella can be tricky at every level, right from the diagnosis to the lab to the treatment. Everywhere it can be a troublesome thing. Neurobrucellosis, on the other hand, can present with meningoencephalitis, myeloradiculitis, cranial nerve palsy, peripheral nervous system, neuropathy being involved. And we have seen a patient with neurobrucellosis, which have not presented here, but we lost the patient because by the time we made the diagnosis and started treatment, he was too sick and did not survive at all. So the brucellosis presentation is across so many organ systems that is very easy to miss it. Now, this is again another patient of ours, a 55-year-old man investigated for PUO, no localizing symptoms, counts were normal TC, low platelets, mild anemia. All blood culture, everything was negative. He was imaged with a PET scan for a malignancy, negative. How to proceed? And that is when we realized that he had a contact with cattle. The one-line history which our postgraduate took was the clue to the diagnosis, because we then suspected that he could be having brucellosis. And then we proved from the serology and he went home all right. So these are the various cases that we have seen and we have published, and that is what I'm sharing with you today. There are several uncommon presentations of brucellosis that we come across. These are all case reports. One of them presenting with acute acalculous cholecystitis, which you actually think of in an ICU if you have a fever. That's what you think of, but this is rare. Acute prostatitis can occur. Brucellosis presenting with GV syndrome. So there are various publications in the literature which talks of so many manifestations of brucellosis. Now, coming to the next part, what are the lab mistakes that we can do when we want to diagnose a patient with brucellosis? Now, if you look at the general investigation that we do, so you can have an elevated alanine aminotransferase, the liver enzymes can be high. You can get an anemia, leukopenia, sometimes leukocytosis, relative lymphocytosis, thrombocytopenia, pancytopenia. That's hematological. And because you can get something like a granulomatous hepatitis, you can get a liver enzyme abnormality. This is from up to date again. But when we want to prove the brucellosis, we have to culture it either from the blood or from the body fluids. And then we can also do a serology. More than 1 in 160 or a 4-fold lysine titer is probably how we prove. And recently, like I showed you that case report, RT-PCR from the relevant fluid can be done for brucellosis. Now, these are the investigations that will help us to pin down the diagnosis. So serologies are various types. You can have the MAT, you can have the SAT, you can have the IgM, and then you can do the titers. So more than 1 in 160 in a non-endemic area and more than 1 in 320 in an endemic area can be taken as positive for brucellosis. So let me put one more case for you. A 45-year-old salesman who used to work on a farm as manager comes with fever and lymphadenopathy. Investigation showed normal counts, high ESR, Brucella positive at 1 in 320. Should we treat as brucellosis? The lymph node biopsy of this patient showed tuberculosis. Now, why is this happening? This is because this is the advantage, the disadvantage or the downside of the serology, that it cannot distinguish between a present and a past infection. This man had worked in a farm. He must have acquired brucellosis there, must have got cured, but your titers remain for a long time. And taking that titer to the current situation will not help you at all. and it can cross-react with other infections and is not positive in the early stage. So serology has its downside. Serology has its fallacies, which must be taken into account while interpreting. Look at the blood culture positivity. Blood culture positivity is 15 to 70. Now that's a huge range. If it is 15, you're going to miss so many, 85% you're going to miss. If it is 70, you're better off. The bone marrow culture is definitely more useful, but one is not going to do a bone marrow culture in everybody. But it is a gold standard, like I showed you in our patient with pancytopenia, we proved with a bone marrow culture, but the blood culture can be negative. So the lab mistakes are, especially in an endocarditis, there's a time in lag between infection and diagnosis. The organism is fastidious, it grows intracellularly, and previous antibiotic, like everywhere, even in our usual endocarditis, most of the time we're not growing anything because previous antibiotic treatment knocks out your organism. And that's what happened in our patient also. So why is it missed in the lab? Because if you have a back-tech alert, then you would probably get your brucella on day 3. If you do not have that, then you will grow in 1 week. But other tissues and cultures will take a long time. So sometimes we have discharged a patient, he has gone home, and then you get a brucella diagnosis and you call him back and then you treat him. So lab has its problems in making a diagnosis simply because we don't have the best tests yet. There are many things that look like brucella to us, right? So when you have a bone involvement, like you have a vertebral involvement, we think of TB, we think of staph, because Staphylococcus aureus has a tendency to cause a bone involvement. And then you think of a malignancy. An older person coming with backache is probably a myeloma, or with that high ESR, or you're thinking of some meds, etc., like that. So there are many lookalikes for a brucella, and only the clinicians' awareness will make him test for brucella after eliminating the others. So serology, like I said, in the negative blood culture, 1 in 80, some people say 1 in 160 and 1 in 320. The cutoffs can be lower in the Western world, but in our this thing, probably we should stick to the other cutoff of 1 in 160 and 1 in 320. Our patient, we had no doubt because his culture was, serology was very positive. So that's about the lab mistakes. Let's go on to the final part, which is treatment mistakes that we do. Principles of treatment were we alleviate symptoms, we prevent complications, prevent recurrence, and prevent chronicity. The 3 and 4 are important because brucellosis can recur. So therapeutic failure itself can be there by 5 to 30% and relapse. So it's not a disease that's going to go away in one go. It's going to come back to you, or you're not going to achieve the cure even in the first instance. So the principles of treatment are at least 2 antimicrobials must be there, and they must have the ability to enter the macrophage and work in an acidic environment. And you should have a long enough treatment to prevent the recurrence. And you must take into consideration what is the stage of the disease and what are the complications. So the drugs that we use are doxycycline, which is the best, which is the hero of the story in a brucella. Everywhere you put the doxy in, it's a good intracellular penetration. Rifampicin is good, aminoglycoside penetration is not so good, but these are the other options that we have. So look at the treatment options that we have. The minimum treatment is 6 weeks. Now that's a very important rule. The minimum treatment for brucella is 6 weeks. Everywhere you see doxy, all the 3 lines you're going to see the doxy. So you give doxy plus strepto, doxy plus genta, or you give doxy plus rifampicin, which is the third alternative. The first 2 are the best alternatives. So a doxycycline plus an aminoglycoside is the standard of care. If you want to use doxy plus rifampicin, alternative regimen, not so good. Why do we say not so good? Because look at the failure rate and look at the relapse rate. The failure rate itself is more with the doxy and rifampicin, and the relapse rate is also more. And you may have to extend your treatment longer if you're using doxy plus rifampicin. Why is there a relapse? Because like we said, intracellular stays in the acidic environment, protected from antibiotics, and recurrence and chronicity is common in brucella. So what to do when we have a relapse? We repeat the original regimen once more. This we have done. I had a patient who came to me 3 times with brucellosis. Once I treated, he came back, then again he came back. So the point is we have to keep on extending our course, use more drugs, etc., etc. And chronicity is also common. So the treatment mistakes are short duration. Everybody gets fed up. Okay, 2 weeks of doxy, 4 weeks of doxy won't work. It is 6 weeks. Short follow-up. You call the patient once he is all right, you're happy. You're not happy. You're going to call him back again. And Cure is a clinical judgment. What can you use as an index of cure? You're not going to grow a culture again. The serology may or may not be positive or may come down. You're not very sure. So this has to be that you have to treat long and follow up longer. When to extend therapy, in some conditions, you extend even up to, a year. That is in endocarditis, spondylitis, neurobrucellosis, deep abscess, prosthetic things, therapeutic failure. You may have to treat longer. So some use triple therapy, like we used in our endocarditis, doxy plus rifampicin plus aminoglycoside. That also can be done, and it has to be extended to prevent a relapse. The role of steroids in brucellosis is controversial, and it can be given in some situations like I've listed here. Most of them are in neurobrucellosis and sometimes in a cytopenia. Coming to the special situations, brucellosis in pregnancy, of course, we can give sulfa, but you have to avoid in the first and last trimester. Rifampicin is okay. Ceftriaxone becomes an alternative in pregnancy, can be given for 2 weeks or sometimes 4 weeks, and doxy we have to avoid during pregnancy. Special situations like renal failure, we go for rifampicin and doxy and avoid the aminoglycoside. For a liver failure, streptomycin can be given with the doxy and a quinolone. So some combinations we have to do. Neurobrucellosis, again, rifampicin, doxy, and ceftriaxone preferred because this crosses the blood-brain barrier. We have to treat longer. We have to treat for 3 months, follow up and see if it's better, not better, go for 6 months, sometimes even 12 months. Now, endocarditis treatment, like what I said in our patient, we gave aminoglycoside, doxycycline, rifampicin. Sometimes you can give a sulfa as a 4th drug, and then you have to extend the course of treatment, like we said. And surgery is definitely recommended for any endocarditis. Spondylosis, 3-drug regimen, 12 weeks. And the role of surgery is in special situations in brucellosis, like we said in endocarditis, sometimes in resistant abscesses in the spleen, spinal instability, and also collapse, etc., and prosthetic joints. Now, the take-home message from this whole talk, I presented to you all the cases that we have seen and all the lab errors that we did. I'm sharing the mistakes with you, not that we made a diagnosis initially, we also learned on the job and we learned over years. So the take-home message is think of brucellosis. In any PUO undiagnosed, not getting the right answers, think of a brucellosis. Pancytopenia, low backache, arthritis, endocarditis, there are no clues elsewhere. Think brucella, because if you don't even think of it, it will be totally missed. It doesn't figure anywhere. So I have seen patients walking around from hospital to hospital before they come and we get a diagnosis. So think of brucellosis when you get these situations. To sum up, recognition is the key. Think of it, you make a diagnosis. Understand the lab fallacies. Understand that cultures can be negative. Serology can be negative. You may have to go all the way to the bone marrow culture. Treat adequately, minimum 6 weeks, extend to 12 weeks, keep on follow-up and look for a relapse. Watch for complications that can occur, and long follow-up is what we need. Thank you very much for a patient hearing.
Thank you very much, ma'am. I think the lecture topic was very appropriate. So we have learned from mistakes, and now we should not repeat those mistakes to be good in treatment of these brucellosis. And I think she has clearly said that we should have a high suspicion of index for making a diagnosis, and treatment and all doxycycline and all should be given a longer term. And few things she has shared her clinical experience, because we, as said, she's working in a metro like Chennai and Delhi. We don't see so much of a patient, but rural setting, cattle exposure is very important. Ma'am, one question I will take, like there's a reported thing that dogs can also have brucellosis, and we have more exposure in city with dogs compared to a cattle. So one thing is dog exposure should be taken, and is there a important thing that cattle or animals who are sick or recently died is more important, or just person has contact with the unpasteurized milk, exposure to cattle or a dog is more important? And second thing is we are very happy with to know that within 3 days we can have a back test which can detect your cultures, gold standard almost, and also PCR test and all. But some people say agglutination test is a must, like CDC says, and non-agglutination test may not be that effective, especially like neurobrucellosis and all. Any comments on those two things?
Yeah. First, regarding the dogs, I have no idea, to be honest with you, because I've never seen somebody getting from a dog. I will read up on that. Regarding cattle, yes, cattle doesn't mean the cow. It means any farm animal, and a lot of things come from the goat, etc. And the animal doesn't have to be sick like that. It is just that the contact with the animal is probably this thing. And I don't think sickness in animals is so, manifest that people come and tell you that my animal was sick and then I got into contact, because I've talked to a lot of farmers who have come to us with brucellosis. And even if you ask them, did the animal have some abortion? Did the animal have some problem? Most of them say no. So obviously, and they are people who know about their animals. They're not, novices there. So we have to respect their knowledge there. So I don't think that the animal has to be sick for you to get. It's unhygienic situations. Like we said, from the body fluids of the animal, it can last up to 40 days. So something lying around somewhere, these people don't wear gloves, they don't wear a PPE, they just go in and they take the, the cow dung, and everything is handled by hand. And that contact is probably enough. Now, regarding the lab, this thing, like I told you, yes, we've got better tests now, but sometimes you have to go all the way up to the marrow for you to prove the culture. And the serology tests also, the MAT is definitely useful, and the serological titers are useful, and the fourfold increase, if you can do that, is useful. But for a neurobrucellosis, very difficult to prove. It's very difficult to prove. We've tried CSF, we've tried whatever, nothing really works. And sometimes it's just a kind of a guesswork that you do. But I have not seen a patient surviving neurobrucellosis. I have, I think, 3 patients, and all of them came to us very sick. And by the time we proved, they were already gone. So I don't think I proved that at all. But the most satisfying people are the people who came with backaches, arthralgia, PUOs, pancytopenia. Those are the things that we have really cured. But the recurrence is quite a lot. So I've seen patients come back. Like I told you, I've seen 2 or 3 patients coming to me for follow-up for 2 years. Even after 2 years, he still has brucella. And I've been really struggling to, give them a cure. So that happens, right? I hope I answered all your questions.
Yes, ma'am. Thank you, ma'am. I think we are short of time. I'll hand over the mic to Dr. Manjula, and Dr. Suresh want to say something, sir. Yes, sir. Go ahead.
So a couple of things, sir. I say excellent talk, and you got a lot of experiences there. One, you said in Delhi you're not seeing, but one history you need to ask from your patients whether they travel to Middle East or not. People go to the Middle East, you're taking camel milk, come back. Yes, we need to get it. A lot of camel milk people getting it. One. And second thing, one more mistakes people do as an infectious disease, we need to see people in the microbiology lab, they find difficult to identify these organisms, even though the bacteria will pick it up, gram-negative bacteria. But the technicians, what they do, they smell the culture plate. If they smell the culture plate, they can able to identify it. But the problem, smelling can cause aerosolizations and increases the intake. Then we need to give post-exposure prophylaxis. In fact, one of the lab outbreaks I published our data, 26 lab persons, couple of pregnant women, they smell the Brucella plate. In fact, we should not take the culture plate from the automatic system where we are handling it. If you take out the culture plate and smell it, it is a very risky one. So that's the point I'm making. Thank you.
So once we go to Dubai, microbiologists should take care that they should not smell. Thank you, sir. It's over to Dr. Manjula, ma'am.
Thank you. Thank you all for the opportunity.
Thank you, ma'am.
Thank you, Sudha ma'am. It was wonderful having you here. And Dr. Ghanshyam sir, thank you. Both of you for doing. So we will move on to the next question. I hand over the session to Dr. Suresh Kumar. Sir, over to you, sir, for the next session.
Yeah, so I don't really need any introductions because a couple of times I was introduced. This is pleasure to introduce Dr. Krishnaswamy Sundararajan. He's working as a Director Intensive Care Unit, Royal Adelaide Hospital now. He's associated as an Associate Professor in Royal Medical School, Faculty of Health and Medical Sciences. He's examiner for CICM and primary fellowship exams. He's not new, he's Indian. Basically, he got his MBBS and MD anesthesia from India, and he got his gold medal from the fellowship in anesthesiology, as well as he got a lot of scholarship also. And he completed his master's in public health during the time of COVID. He got MPhil. So we are going to hear from him what fever is seeing in his Adelaide ICU. We see a lot of fever in Indian ICUs, but I'm going to see what my chairperson, what my speaker going to discuss about what fever is seeing in Adelaide ICUs, how different from Indian ICUs we are going to discuss in next 20-30 minutes. Sir. Please go ahead, sir.
Okay, so thank you for the kind introduction. Can I confirm that you're able to see my presentation?
Not yet. We are
Not
here.
yet,
Not
sir.
yet.
Here.
Okay, so do you want me to share my presentation or is it
Yes.
loaded up already?
Yes.
If you want, they can do it, sir.
Okay, I
RX
was under,
event, can you, or you want to do yourself, sir?
no, I was under the impression that it will be shared.
Yeah, they
Okay.
will share it. RX event?
Okay.
Ma'am, we do not have presentation of sir.
If you go to your presentations, better to share because it's easy for you to operate. Otherwise, it will take time. We'll check and let you know.
Okay. All right. Let me.
Sir, please open the PPT in your laptop. Then make it in full screen mode. Then please press Alt tab and come into Zoom. Then you need to press share screen, and there will be screen will be over there. You can select that to presentation mode.
Okay. Can you see it now?
Not yet.
Okay. So how do I go about it? Because I
Better
go
like
into
event manager plus you go ahead and carry on. Event manager, this is best thing because he's got a little of difficulties there.
Sir, can you open? Is your presentation open, sir?
it is open. Yeah.
Sir, from the Zoom, there is a green button below the share screen in your video down. There is a mute button, stop video. In the same line, you have share button, sir. If you just move your cursor. Is it
Okay.
MacBook or Windows, sir?
Well,
it should be the same, I guess, sir.
okay.
Sir, can you
is,
see the participant chat button, share screen? Can you see in the bottom of your screen?
Yeah.
So just click on the share screen.
The green one, share screen, you start and click it.
Can you see it now?
Right, it started to
it's
share,
rolling
sir.
there.
It started. Yeah. Make
Put
it
it
full
in
screen.
Put
Yeah,
it
make
in
it
a
full
PowerShow
screen.
mode. Put it in a show
Okay.
mode.
Can you see it now?
Perfect.
Yes, yes.
All right. Okay. I'll keep it very brief because we're already short of time. So I will whiz through. So for introduction, I work in this place, which is in Adelaide, which is in the southernmost part of Australia. And just to give you an indication of what the country is like, it is a land of 25 million people. So, and if you compare that with India, which is about 1.4 billion, so the population of India is at the moment about 54 times that of Australia. So there is somebody who is not muted. Can I request that person to mute themselves? I'm getting some distracting noise here. Please mute yourself.
Professor of Pediatrics at GMP Trishore is the IAP National Vice President 2020, past National President IAP Neurology Chapter, past President Secretary IAP Kerala Chapter, is also
Could you
been
please
editor
mute
chief
yourself?
Journal of Trauma and Emergency Pediatrics, also chief editor IAP TV on
Hello,
TV book
could you
on
please
pediatric
mute yourself?
radiology, foundations, pediatric neurology.
RX event, can you mute Dr. Krishna,
He's
please?
also the member of
Mute, yeah. Please go ahead, sir.
Okay, so I'd like to make a few acknowledgements here, as I could see it here, reference articles from various journals. And again, starting off with this particular quote, the humanity has three main great enemies: fever, famine, and war. Of these, by far the greatest, the most terrible is fever. So it was by none other than William Osler. So the scheme of the presentation today for the next 15 minutes is that I don't have any conflicts of interest. I haven't received any funding or any support for this talk. It's entirely my own contribution. And what I'm going to do now from here on is to just talk about why is fever in ICU an important issue? What is fever in critically ill patient? How does this occur? The pathophysiological basis, what causes this? And then we'll travel through evidence-based medicine. I would aim to give a synopsis of observational studies and of randomized controlled trials, and then finally summarize and give you at least a couple of take-home messages. So I was given this topic and I was asked that it is an open problem. And then I wondered as to what is meant by an open problem. So in science and maths, this is called as a problem, which is something that can be accurately stated and which is assumed to have an objective and a verifiable solution, but which has not yet been solved. Okay, so one of the things there is about the 4-color theorem. So what it actually means is that, if you are looking at these maps here, and this is just to give an example, the 4-color theorem is that if you want 2 colors not to be the same next to each other, and what is the maximum number of colors that you could use to try and prevent that from happening, you only need about 4 colors, and then you can achieve to solve the problem. So this is important here from a fever point of view, in particular as to why this is an issue for us. Okay, it is not about what is fever or how it happens, but why is it important? So it is common in ICU. It has potential benefits and potential risk for patients. And among patients who have infections and who are admitted to ICU, increasing fever is independently associated with a decreasing risk of in-hospital mortality. Even in the absence of infection, a low-grade fever appears to be independently associated with reduced mortality risk compared with normothermia. So the what of it, definitions vary. When do you call someone as febrile, if it is 38 or 38.3, but for practical purposes in an ICU in Australasia, we would use 38.3. And the measurement techniques, as you can see over the years, we have diversified from starting with an axillary thermometer to currently using, temporal arteries, and more importantly, using, advanced gadgets. But nonetheless, the principles remain the same. So in terms of the pathophysiology of fever, most are mediated by the production of pro-inflammatory cytokines, interleukins 1, 6, and TNF-alpha. It's also important to understand that it is the reset of the hypothalamic set point, which is increased, and then the prostaglandin E2, which is involved in this. It causes vasoconstriction, it increases metabolism and muscle contraction. And the hypothalamic set points are lower, and then as a consequence, you will feel hot and sweaty when it happens. So as you can see here, the exogenous pyrogen starts off a cycle, the leukocytes are activated, the interleukin 6 is proliferated, and along with the other cytokines, as we spoke about, it affects the circumventricular organs, release of prostaglandins, and then it has a feedback loop. So there are several phases here, as you can see, starting over the chill phase, the plateau phase, and then eventually the effervescence as it happens. So the mechanisms of that, along with what I said earlier on, is also how it, overall affects the functionality of the hypothalamus. At the same time, it causes mitochondrial and DNA damage, especially in those patients who have hyperthermia, and it also causes stimulation of the exotoxic mechanisms and causes protein denaturation and cell death along with it. It's not only what happens at the cellular level, at a local level, there is cytokine stimulation and inflammatory response along with vascular stasis, and subsequently to that you have endotoxemia and gut bacterial translocation, which is some of the consequences of hypothermia. So there is a key difference here. What is the difference between fever and hypothermia? What we mean by that is that fever is 38.3 and above, and hypothermia by definition is usually 41.1 degrees centigrade and above. So again, I've borrowed from UpToDate here about quite an important slide in relation to what are the mechanisms by which we use various agents at several stages. We use corticosteroids, antipyretics, and dantrolene. And again, as you can see, it's self-explanatory about the various sites of action in terms of its effect on interleukins and TNF-alpha, antipyretics having their effect on the prostaglandins, and dantrolene, which thankfully we don't see it very often these days, unless you have had an issue with malignant hypothermia as a consequence of an anesthetic, which tends to happen very rarely. I have only seen it once in the 17 years I've been practicing in Australia. So benefits. So when I say fever can have benefits, people might look at me and think, well, what am I talking here? Because it's always associated with a negative connotation as to someone having fever. But at the end of the day, fever is a symptom and it is not a diagnosis. So that is very, very important for us to understand. So when we have people examining patients and coming to us and saying the patient has got fever, yeah, that's right. But why has he got a fever? You tell me why, not what. Okay, so fever can be a good prognostic sign in acutely unwell patients with infection associated with a very high rates of survival. In a prospective observational studies, which have been done on one occasion, the fever inhibited microbial reduction and viral replication, as well as accelerated the rate of phagocytosis. The heat shock proteins, again present in fever, are thought to prevent thermal damage to cells by inhibiting the pro-inflammatory signaling pathways. And again, if an individual is able to mount a febrile response, you have to assume that the person has got a good immunity and has also actually has got a good prognostic sign in terms of their longevity compared to those patients who are unable to do it. So, and again, that is a good evidence to back that with the evidence suggested there. So coming to the causes of fever, in broader terms, infectious versus non-infectious. So one thing I would like to say is that, the population in Australia and the types of infections we see are slightly different to what would happen in India for that matter. Okay, but nonetheless, the causes of non-infectious fever are probably more. So the diagnostic approach depends on the magnitude of fever elevation, fever pattern, relationship of pulse to fever, and the presence or absence of localizing signs. The thresholds are important, extremely important. So 41.1 degrees centigrade and above, you have to assume that there's something else going on, not just an infection. Could be malignant hyperthermia, could be a centrally mediated process like a hypothalamic dysfunction from a stroke, either a heat stroke or drug fevers. One thing I would say is that heat stroke is quite common in Australia because it is an arid land, it is dry, and it does suffer from bushfires time and again. So it gets really hot. 2/3 of the continent of Australia is desert. So we are prone to developing heat strokes here. But having said that, with climate change, we are facing quite unpredictable weather these days, and it is not always the case. But either way, it is not uncommon to see heat strokes in Australia. And there is no prognostic significance in terms of the temperature difference between 38.9 and 41.1. In terms of the infectious causes, it won't be vastly different to what you would see in an Indian ICU. Bacteremias, catheter-related infection, surgical site infection, ventilator-associated pneumonias, and UTI. The stock standard ICU-related infectious issues, nothing changes. The other infectious causes, again, is a vast variety here. I'm not going to read out everything. I'm sure all of you are able to comprehend what that would mean, but suffice it to say that we do see quite a bit of empyemas here, more than you would think. Endocarditis, again, mainly because we have a significant problem with intravenous drug abuse in this part of the world, and necrotizing soft tissue infection or necrotizing fasciitis. Again, it's quite an important issue for us. In terms of the inflammatory pathology, again, you will be looking at burns, trauma, and surgery. We are a quaternary referral center, so we get a lot of burns patients for the entire Central Australia. So again, that would be one of the major reasons we find non-infectious fever, pneumonitis, ARDS, and again, the other granulomatous diseases, which are tend to be more prevalent in this part of the world. Infarction, either myocardial or cerebral, along with gut and pulmonary, not an uncommon cause of fever. The hem-onc and endocrine group of patients, again, it is important to realize that we do see more of pheochromocytomas and thyrotoxicosis here, along with tumor lysis syndrome and malignancy from a hem-onc point of view. Tumor lysis, again, we have seen quite a few of them, mainly because we have a very large catchment area for oncology patients. And then finally, in terms of the other causes, again, a vast variety of reasons here, and more important to realize that, the drug withdrawal or overdose is not an uncommon problem in this part of the world. Now, coming to non-pharmacological means of reducing the temperature in terms of cooling, cool environment, wet towels, ice packs, blankets, etc. Is there any evidence to support this particular theory? The answer to that is yes. This is a journal from the CCR, which is the Journal of the College of Intensive Care Medicine in Australia and New Zealand, which showed that active temperature management neither increased or decreased mortality in critically ill adults. And then if the approach is to reduce body temperature, physical cooling may be more effective than pharmacological measures. Okay, so this is again a proof of concept, but again, I would say it's reasonably high quality evidence because it was from a systematic review of and meta-analysis of randomized controlled trials. Now, coming back to the areas here, as I would like to focus in terms of what actually happens in terms of the temperature, and again, this is from Hutchison's, in terms of the sweating and vasodilatation as to which areas are involved, it's the involvement of the parasympathetic and the sympathetic nervous system. This parasympathetic gets activated and the sympathetic nervous system get inhibited in response to this, the fever issues, which happens along at the same time. Now, looking at the observational studies for fever and fever management, there's quite a few here which have been done, but I will go through the key studies which will lend some thought to where we go. So a fever of 38.3 developed in about 44% of ICU admissions in this study, which was a retrospective cohort study. And they found that it was neither associated with increased ICU mortality, but high fever beyond that was associated with significant increased risk of death. The study by Young et al., and that's from New Zealand, but it was done in Australia and New Zealand over a 6-week period. They found that 9% of patients admitted to ICU had or developed a fever or known to suspect infection. Paracetamol was admitted at least 2/3 of the fever in that particular group of patients. NSAID use was independently associated with increased 28-day mortality in patients with sepsis, but a trend towards a decreased mortality in patients without sepsis. And this paper found that 25.7% of patients had fever at 38.3 at ICU presentation. Fever was not associated with increased mortality, but hypothermia was an independent predictor of death. So hypo, as in low temperature, is an independent predictor of death, is severe, is associated with worse outcomes than with fever. So fever does not always mean that it is associated with increased mortality. And this is a paper I would like you to remember. And if there's one take-home message, I'll probably focus on this. This was a retrospective cohort study, as you can see, of a significantly high number of patients, almost like 6.3 lakh patients in Australia, New Zealand, and the UK, admitted to ICU over a 5-year period. And they found that elevated body temperature in the first 24 hours of ICU was associated with an increased risk of mortality in patients without infections and a decreased risk of mortality in patients with infection. So if you have an infection and if you have a low-grade temperature, something which is not actually compromising cellular function, it's actually not a bad thing. That's the take-home message. So let's not be too concerned or too overreactive or too paranoid about just treating the numbers. We need to treat the patient in front of us and not just the number. You look at the randomized controlled trials here in the management of fever here. Again, this paper said there was no significant difference between Brufen and placebo. And this is mainly looking at NSAIDs as well. And again, in this paper, again, using NSAIDs, no significant difference between the treatment groups with respect to ventilation requirements. And again, in the final paper, external cooling devices did not alter the proportion of patients who had any reduction in the vasopressor requirements. And there was a meta-analysis which came about on a systematic review for patients with COVID. It would be remiss of me if I don't talk about COVID in ICU, particularly with fever. And there was some bad press for NSAID saying that they increased mortality, particularly in the initial wave, which affected Italy. But this meta-analysis actually said that NSAIDs are not too bad overall. This came out in the eClinical Medicine, and that was a study which said, look, it is something which we have to take it with a dose of caution. In terms of the acetaminophen for fever, again, early administration of paracetamol to treat fever did not affect the number of ICU-free days from the NIJM paper. And again, from this was from the HEAT study from Australia and New Zealand. And finally, in terms of the meta-analysis in this group, we found that, again, looking at individual patient data, quite a lot of papers were controlled in this study. They found that do not support the hypothesis that active fever management increases survival compared with less active fever management overall or in patients with limited physiological reserves. So in summary, what is the take-home message? The cornerstone in the management is to seek and treat the underlying cause. There is a certain degree of clinical practice variation that exists in the management of fever. A subset of patients will need closer attention in the ICU context, and that would include patients with neurological conditions, post-surgical patients, pregnant or immunosuppressed, malignant hyperthermia, or neuroleptic malignant syndrome. However, fever is not a bad omen. Okay, a less is more approach in the management of fever is entirely appropriate. Active fever management does not improve survival overall and in those with limited physiological reserve. It's actually not an open problem anymore, in my opinion, I have to say, and it can be considered as an open and shut case based on current evidence. I will conclude my presentation here and happy to take any questions. Thank you.
Thank you, sir. So excellent talk for fever in ICU. Couple of good messages. It's not open case, it's open and shut case is one thing. And treat the patients, not the numbers. That's other message you conveyed. Couple of interesting things I like to ask you before the audience start opening up. I should have one question there. At what fever will you start reacting in the ICU? Suppose what sort of patients has got fever admitted in the ICU, when the patient started developing fever, in which patients you start react immediately and which patients you want to wait for some time? Can you throw some light on it?
Yeah, sure. Look, I think I wouldn't use the word react. We would respond to the problem. And 36.6 to 37.2 is the normal range. What we say is 37.2 to 38.3. We probably just sit on it. We won't actively treat that. If it is 38.3 and above, is the time we would be sending some cultures off and starting them on some antibiotics. And in terms of managing their fevers at that time, we would again watch it very carefully, because giving them paracetamol treatment without risk. We certainly do notice IV paracetamol being associated with quite precipitous hypotension, actually. We will have to carefully monitor that, because the bag of paracetamol contains mannitol in it, and it is actually, it kind of, it can diurease and it can drop your pressures as well. So, but to answer your question, 38.3 and above, and that would be the time we would start. But otherwise, if it is a low-grade temperature sitting in the high 37s, we would probably just watch it, and we wouldn't be actively treating it.
The other point what we differs is the cost for the fever in ICUs, both Indian and Australian ICUs same, whether it's a CLAPSI versus SCOTI versus FAB versus infections. But what is the differences between Indian and Australian ICU is a bugs. There you have got MRSA is a problem for you as a staff, but for me, gram-negative is a problem. That too, gram-negative resistance, carbapenem resistant bug is a problem. Second thing, tropical infections is a big challenge for us. Confuses with the thing, dengue, malaria, lepto, scrub, all can cause us septic shock presentation. That's a big challenge for us compared to what we see. The dengue is not that rampant in the ICU. I open to my co-panelists today, and possibly Dr. Manjula can help, because I can't see what the audience has posted in the chat message. So can you? Yeah.
Sir, there are no questions on this.
Sir, can I ask something, sir?
Oh,
I'm Dr.
yes.
Sudha. Yeah.
Yes, ma'am.
Thank you, doctor, for a very good lecture. As a person who's managing an ICU here, and I was working in Manipal also, what you said is right. In certain group of patients, you take the fever more seriously. I would put it down as 3 groups. You said acute neurological conditions, because in a stroke, if you increase your temperature and increase your metabolism, the penumbra, which is dependent on the blood supply, will probably be more affected. So stroke guidelines say that you control fever aggressively. The second thing is cardiac problems, because many of our patients with fever go into atrial fibrillation, supraventricular tachycardia, when they have a compromised coronary circulation or any other cardiac problem. When the tachycardia increases, cardiac failure increases because of the shortened diastolic time. And so I would probably control their fever more aggressively and have a lower threshold for treating them. The third thing is about respiratory failure. Again, when you have so much tachypnea, the work of breathing increases, and many patients probably go into the need for a CPAP or a ventilation, and they kind of carbon dioxide rises, and sometimes wash out, sometimes they get tired, and then the carbon dioxide rises. So probably in these 3 groups of patients, our threshold for treatment of fever may be lower. I would like to ask your comment on this.
Yeah, thank you, Dr. Vidyasagar. That's excellent. Look, you summarized it beautifully. The one of the issues we face is that with the post-cardiac thoracic patients, I'll have to say, is that you're right. We have been using that strategy for a while, but then we seem to have a problem in finding some very esoteric pathogens. Like we had an outbreak of Serratia, sometimes Serratia marcescens, when post-cardiac thoracic patients, because we had this policy of starting them early on antibiotics, and then subsequently watching them as to how they're going, and then subsequently it becomes a problem because they develop pneumonia, they develop sternal wound infection, then wound dehiscence and all of that stuff. So we watch that carefully, but unless and until the patient is decompensating, we tend not to start. And again, comes back to what I said earlier, don't treat the numbers, treat the patient. So it is that's something which we always tell our junior doctors. It's very important that you treat the patient with the disease and not the disease which the patient has, because it is 2 different things. Again, comes back to what William Osler said, is you got to treat the patient in front of you. And sometimes the patient will be fine, they'll be having a temperature of 38, but exactly right, they won't be having increased work of breathing, they'll be coping okay. And we just watch that, but then if they're getting to the point wherein they're actually certainly having a very high metabolic demand, there is a demand supply mismatch, you're right. And then that's the time we would say, okay, let's treat it. And so it comes back to the patient.
Thank you.
So since we are running short of time there, thanks for the wonderful talk, as well as a lot of convey messages you conveyed. I just hand it over to Dr. Manjula for further proceedings. Thank you, sir. Thank you and we look forward for future meetings and future collaborations with you. Thank you.
Okay. Thank you, Dr. Suresh Kumar. Thank you.
Thank you, Dr. Krish. It was wonderful having you. I know there was slight delay, and we apologize for the same. And definitely, we would like to associate it with you for more such activities. And thank you, Dr. Suresh Kumar, for pitching in as a chairperson. And we will move on to the next session, which is on asymptomatic bacteriuria. I request Dr. Ramesh Agarwal, whom all of you know, our quiz master for yesterday. So he will be chairing this session. Dr. Ramesh Agarwal is a professor of medicine at Lady Hardinge Medical College, New Delhi. So he will be chairing the session. Over to you, Dr. Ramesh Agarwal, for the session.
Yeah, thank you, Dr. Manjula. Again, a very good morning. And what I can see at the backdrop is that I have got a logo, which is again FeFCon quiz. So I will change it. I think I am synonymous with the quiz master now.
Yeah, exactly.
Yeah. I'm so proceeding to the next session, and a very important message which the previous speaker has given is that we need to treat the patient and not the disease. And so the first question which arises that what is the disease, and is that patient really suffering from the disease? And when it comes to like UTIs and asymptomatic bacteriuria, that becomes a really very, very difficult question for the physicians, whether to really go about it and to treat the patient or remain silent. And I think this is a very, very important topic for the physicians. And we have with us Dr. Kishan, who is a nephrologist and is currently working as associate professor at Institute of Nephrourology and Bengaluru. And I'm sure Dr. Kishan is going to do justice with our audience and really going to enlighten us about the current guidelines, that what actually we need to do when a patient who comes to you with bacteriuria or sometimes with pyuria, and we are really perplexed when whether it's a case of a diabetes or in cases of an indwelling catheter or in ICU setting. Sir, over to you, sir. Dr. Kishan.
Thank you for kind introduction, Dr. Ramesh Agarwal. Let me share my screen now. Is it visible?
Sir.
Can I go
Yes,
ahead?
sir, it is visible. Yeah, sure, sir.
Good afternoon. At the outset, I would like to thank Fever Foundation for providing this opportunity to speak about asymptomatic bacteriuria. Before I start this topic, I would like to declare I have no conflict of interest or I have nothing to disclose. Coming to introduction, asymptomatic bacteriuria defined as the presence of bacteria in non-contaminated urine sample collected from patient without signs or symptoms related to urinary tract infection. Common finding in some healthy female population and in many women or men with abnormalities of genitourinary tract that impair voiding. Criteria for diagnosis of this entity includes isolation of the same organism in 2 consecutive voided urine specimens for women and 1 voided urine specimen for men from a single urine specimen collected via urinary catheter in both sexes. Coming to colony forming units, it should be more than 10 to the power of 5 in a voided urine specimen. And most important point is they should not have any signs or symptoms attributable to urinary tract. That includes urgency, dysuria, frequency, and suprapubic pain or tenderness, renal angle pain or tenderness. Coming to magnitude of this problem. So it varies widely across different population subgroups. Coming to children, prevalence is very low. It is up to 1 to 2%. Coming to healthy women, in premenopausal age group, it is up to 5%. Pregnant women, it is up to 10%. In postmenopausal age group, it is up to 8.6%. And persons with diabetes, prevalence is more in women up to 16%. Men, it is around 11%. Elderly persons living in community, it is up to 16% in women and 19% in men. Elderly persons in long-term care facility, those patients may be having some disabilities, either physical or mental, for which they will be staying in nursing homes. Among this subpopulation, among women, it is up to 50%. Among men, it is up to 50%. Patients with spinal cord injury, those who are on intermittent catheter use, it is up to 69%. Those who underwent sphincterotomy or condom catheter, it is around 57%. Persons who received kidney transplant in their first month of post-transplant, it is up to 25%. 1 month to 1 year, it is around 17%. More than 1 year, in prevalence definitely reduces, it is less than 10%. Persons on indwelling catheters, if they are on short-term catheter, that is less than 30 days duration, prevalence of this entity is around 5%, and long-term catheter prevalence almost touches 100%. Before discussing any topic, we must understand biology behind. So sterile urine and collecting system are normal rather than exception. Question here is what breaches this sterility? And next question is why bacteriuria become asymptomatic in some and symptomatic in others. Bacteriuria, whether asymptomatic or symptomatic UTI, happens as a result of interaction of host, organism, and environmental factors. First, let us discuss bacterial factors that leads to development of this entity. Escherichia coli isolates from symptomatic UTI or asymptomatic UTI are definitely different from that resides in our gut flora. So these E. coli which cause UTI are called as uropathogenic E. coli. Reason for this development of uropathogenic strains are they develop certain mutations that impart the virulence factors, namely type 1 fimbriae, P. fimbriae, hemolysin, and iron uptake system. However, those isolates which causes either symptomatic or asymptomatic infection showed similar genotypes. So at least at genetic level, whatever tests are available, we don't see any differences. However, when advanced genetic tests were done to see the function of these genes, we were able to pick up certain point mutations or minor deletions that can substantially alter the gene function. For example, a point mutation in PAP gene that render P. fimbriae, which is very important virulent factor, incapable of adhering to normal urothelial targets. So current understanding is uropathogenic E. coli is not a commensal organism like similar to E. coli that resides in our gut flora, whereas it picked up certain adaptive genes for survival in the bladder, but was originally a pathogenic strain. We must remember that. And that lost its important virulence factor that results in the development of asymptomatic infections. The take-home message is there is no single gene that lend itself to a point of care testing to determine whether this bacteria that cause asymptomatic bacteriuria or symptomatic UTI. Maybe in future, we may develop certain tests that include functional genomics like transcriptomics. They may provide us biomarkers to differentiate these two entities. And coming to host and environmental factors, certain polymorphisms in TLR4 promoter gene and chemokine ligand 8, which is also called IL-8, causes this asymptomatic bacteriuria. These observations can also explain by, in theory, that neutrophil activation. So unlike adaptive immune system, innate immune system is responsible for development of this entity. A large body of studies going on neutrophil activation. Probably we may get answers to why certain individuals develop this asymptomatic bacteriuria compared to symptomatic UTI in others. So probably it is too early to preclude. Probably in coming days, we may get some answers with respect to neutrophil activation mechanism. And other factor that contribute to asymptomatic UTI is bladder environment. Impaired bladder voiding and indwelling urinary devices such as bladder catheters as well. These are well-established risk factors for this entity. They both interfere with bladder's natural ability to flush out the pathogens. So to conclude, asymptomatic bacteriuria is not a single condition, but is different in patient groups with different underlying conditions. Important question here is whom to screen for this entity and whom to treat. So arguments for screening and treatment includes, it is presumed that asymptomatic bacteriuria may be precursor for future symptomatic UTI, which includes acute pyelonephritis. And it was thought that it may lead to CKD due to repeated infection resulting in renal scarring. Again, there are certain arguments against screening and treatment because screening, as we all aware, it leads to, if not properly chosen, it imparts excessive costs And we all aware that unnecessary antibiotic use results in Clostridium difficile infection. Again, on society perspective, it can lead to development of multi-drug resistant bugs. So who needs screening and who needs treatment of this entity? Yes, several large body of evidence as well as Infectious Disease Society of America proposes that only 2 population subgroups unequivocally demonstrated to show benefits of screening as well as treatment. They include pregnant women and patients who are undergoing endourological procedures like cystoscopy, TURP, double J stent placement, etc. So we quickly run through these 2 subgroups. Like pregnant women, the story of asymptomatic bacteriuria started here. Kaas, in his seminal work in 1962, published that asymptomatic bacteriuria associated with increased risk of acute pyelonephritis and preterm delivery. Since then, there are several randomized control trials and observational studies demonstrated that asymptomatic bacteriuria in pregnant women associated with increased risk of acute pyelonephritis, preterm delivery, and intrauterine growth retardation. And treatment of this entity resulted in decrease in the incidence of these adverse events. And they stated that duration of therapy usually lasts 3 to 5 days. But however, single dose therapies were also tried with success. Again, there is uncertainty over the duration of treatment. And one thing we must understand that none of these trials evaluated long-term effects of asymptomatic bacteria, which were presumed to cause scarring. And none of these trials evaluated this problem. And we must also remember that all these studies which were published dates back to late 1960s and 1970s. We must understand that there is considerable progress happened in antenatal care in last few decades. So again, risk of preterm delivery and IUGR must be studied in current era to understand and to carefully subgroup patients who really benefit with treatment of this entity. Coming to urological procedure, there is robust evidence for treatment of asymptomatic bacteriuria before proceeding to any urological procedures. So theory behind this is any urological procedure, especially cystoscopy, diagnostic or therapeutic, may result in breach in the mucosa. That definitely may result in invasion of these organisms into bloodstream resulting in sepsis and ascent of these organisms resulting in pyelonephritis post-procedure. So available evidence suggests that 3 to 5 days of treatment is needed before proceeding to surgery. And whatever evidence definitely demonstrate treatment of this entity results in the decrease in the incidence of sepsis and acute pyelonephritis. And again, single dose therapy was also studied with considerable success. And we really don't know the duration of therapy at this juncture. Definitely screening and treatment is recommended. And long-term outcomes, again, with like in pregnancy subgroup, long-term outcomes like renal scarring were not studied in any of these trials. Coming to other subpopulation groups where it deemed to be beneficial and what evidence what evidence tell about treating or screening these entities. Coming to most important subgroup, what about pediatric population? We are aware that pediatric population, they may not be able to clearly tell about symptoms and signs of UTI. Again, available evidence did not demonstrate any benefit of screening or treatment in this population. There is high quality of evidence to suggest that use of antibiotics in asymptomatic bacteriuria can result in harm, including increase in the cause and development of antibiotic resistance. However, we need to do future studies, not using all general pediatric population, probably some subgroups like children with certain disabilities of voiding, like neuromuscular disorders like spinal muscular atrophy and neurogenic bladder and certain immune compromised states. Maybe that will give us clear understanding. Coming to non-pregnant women, evidence did not demonstrate any benefit, rather paradoxically increase in the incidence of symptomatic ATI in treatment groups. So higher incidence of antibiotic associated complications like Clostridium difficile infections were also noted in treatment group. Definitely in this subgroup, no screening or treatment recommended. So diabetics, very important subgroup. There is robust evidence against screening or treatment of asymptomatic bacteriuria in this group. And there is increased incidence similar to non-pregnant women, like symptomatic UTI following the treatment. So no screening or treatment required in diabetics. And we must remember that diabetic women have high prevalence of asymptomatic bacteriuria. Despite that, screening is not needed because treatment will not make any change, and rather it leads to development of resistance. And coming to elderly patients with impaired cognition, it is an important clinical dilemma for treating clinician. They will be brought to emergency with non-localizing syndromes like worsening of their prior sensorium or development of FOX. Will you treat if you find asymptomatic bacteriuria in them? Clearly, there is paucity of evidence in this subpopulation. And coming to Infectious Disease Society of America recommends that in the absence of symptoms or signs of sepsis, these subpopulation needs careful evaluation rather than initiation of antimicrobial therapy. So definitely this subgroup needs further studies. Coming to non-urological surgeries that involves prosthetic implants, especially hip transplants or knee transplants or grafts in vascular surgery, etc. Available evidence did not favor screening or treatment of asymptomatic bacteriuria. Trials rather demonstrated more harm in treatment groups. So definitely no screening or treatment needed. Some miscellaneous conditions where there is evidence against screening and treatment of asymptomatic bacteriuria, like patients who are on short-term or long-term urinary catheters. As I told you, long-term urinary catheters, 100% definitely they will have asymptomatic bacteriuria. Definitely again, available evidence suggests there is no use of screening or treating those patients. Again, short-term catheters, prevalence increases as every day passes on them. But however, there is evidence against screening or treating. Coming to post-transplant, kidney transplant after 1 month, again, available evidence against screening or treatment of asymptomatic bacteriuria in this subgroup. And for any other solid organ transplant apart from the kidney, immediately after the post-transplant, if you find asymptomatic bacteriuria, there is definitely no rationale in treating that such patients. And even in post-transplant immediate 1 month, we don't have enough evidence. But again, fear of deleterious consequences on graft make nephrologists and transplant physicians to treat those entities. Again, evidence, there is paucity of evidence in immediate post-transplant period. Coming to patients with spinal cord injury with widening disturbances, in adults, definitely there is no evidence. Patients who are already on urological devices like stents and nephrostomy tubes, they may require treatment before the procedures. However, once procedure is done, stents are in place, there is no evidence to screen or treat asymptomatic bacteriuria in them. So most important part is magnitude of mismanagement of asymptomatic bacteriuria. This prevalence of this is pretty high, more common than asymptomatic bacteriuria itself. Here, there is a situation of clear evidence but muddled practice. Published studies reports about 20 to 50% over treatment of this entity. This, whatever studies I'm quoting are from Western data. We really don't have data from developing world. And it is the one of the significant contributor for antibiotic overuse. Why does overtreatment occur? So most important thing is lack of knowledge and fear of deleterious consequences. Despite the evidence suggests there are no deleterious consequences, still there is fear remains with treating physician. And we know that conventional teaching then and now is that bladder and urine within it are normally sterile. So we are finding non-sterile finding. So definitely it may lead us to treat this entity. And difficult to ignore. Once you do the culture, things will become even more difficult because sometimes in the presence of demanding patient, you may end treating that entity. Okay, when topic was given to me, when I quickly ran one cross-sectional survey among postgraduate students in our institution, almost 90% of them told that they do the cultures because they find pyuria in urine examination. Then when question was asked why they do urine testing, they said this is routine testing in any outpatient or inpatient setting. So the moment they find pyuria and they run the cultures, once cultures comes positive, irrespective of the symptoms, they may end up treating those entities. So we must resist ourselves. In the absence of symptoms, don't do the cultures and no treatment required except in pregnant or patients who are undergoing certain urological procedures. So to way forward in asymptomatic bacteriuria, we need biomarkers to identify asymptomatic bacteriuria versus symptomatic UTI, because relying on symptoms may not be easy in certain patient subgroups like patients who had cognitive impairment and children. And we need further studies focused on subgroup population where evidence is passed, like as I already discussed, elderly with cognitive impairment. And we need further studies to optimize the duration of therapy in benefit group. Even in benefit groups like pregnant women and patients who are going to undergo urological procedure, we really don't know how long to treat them. And available evidence suggests that 3 to 5 days, and certain studies done even with single dose therapies, we really don't know exact duration of therapy. Maybe definitely it is shown that longer the duration of therapy, more the adverse effects. So we must minimize the duration of therapy. And we must also, future studies include renal endpoints like development of scarring that resulting in CKD. To conclude, asymptomatic bacteriuria needs screening and treatment only in pregnancy and prior to urological intervention. Magnitude of overtreatment is a serious concern both at individual level as well as on society. We need good biomarkers to differentiate asymptomatic bacteriuria from symptomatic UTI. So I will end my talk by this statement by Robert Atkins: don't fix what's not broken. Thank you. I will be ready to take any questions on this topic.
Yeah, thank you, Dr. Kishan. I must congratulate you on this clear, crystal clear, and very strong message that the one who actually needs to be screened should be screened. Before the lecture, I had many doubts in my mind, but you had so comprehensively and clearly cleared them. For example, that you have categorically mentioned that only pregnant females and those who are undergoing any urological procedures should be screened for bacteriuria. And even if you try to, like the real study which you have done in your center with the postgraduates, that's actually a real-time data which shows that how this misuse of antibiotic, because of the false perception and the lack of knowledge, is prevalent amongst the postgraduate residents and even amongst us. That's why we switch over to screen every patient. So just a short question from my side, which was not clear, that once we treat any asymptomatic bacteriuria in a pregnant female, like you mentioned about 3 to 5 days, so do we need to repeat the urine examination to see whether there is again bacteriuria, and should this cycle be repeated?
Yeah, we don't have any clear evidence in that regard, doctor.
Okay.
Whatever studies only demonstrated that short duration of therapy is sufficient. Again screening, again treating, we really don't have any evidence at this juncture. So usually all these things happens during the booking case of pregnancy. And again, all these studies were done in late 1960s and 1970s. As I already told, enough advances in the antenatal care. And endpoints studied in those studies were like development of pyelonephritis in later term and preterm delivery and IUGR. Again, in the face of recent advances in antenatal care, IUGR and preterm delivery must be reascertained in coming. I think we need to have a better trials in this regard. Definitely, it is shown to benefit in preventing acute pyelonephritis even with single treatment. And there is no data to suggest repeating the screening or rechecking the cultures to see that this disappear.
And question,
sir, may I ask one question?
Yeah, please, sir. Please, Narasimhala sir, please.
Thank you, sir. Sir, wonderful talk. I have one doubt. in rheumatology and oncology practice, where immunocompromised patients are there, we're using cytotoxic drugs, DMRD biologics. And routine urine exam we do once in 3 months, shows pus cells 15, 20. And then we do culture, organisms of culture. But patient is asymptomatic. And patient is on cytotoxic drugs or biologics. What shall you do, sir?
No evidence, sir. Definitely no evidence to treat such entities. And it is only shown that neutropenic. Anyway, in neutropenics, we will start.
No, neutropenic, the counts are normal. Only
when counts are normal, there is no evidence to screen or treat. So thing is, the moment we see pus cells in the urine, we send for cultures. So we must abandon that practice probably, because there is no evidence that treating this entity will make any difference in these population subgroups.
So the guidelines, sir.
IDSA guidelines clearly again.
No. In rheumatology practice, patients on DMRDs or cytotoxic drugs, biologics, once in 3 months, we have to do urine exam, CBPSR, creatinine, HOT, GPT. So once in 3 months, we will do every full lifetime. So only dilemma is asymptomatic bacteria. Elderly people definitely we don't treat, but young patients, 20s, 30s, sometimes unmarried also. So I have dilemma, no data. I have dilemma, there no data on such category of patients.
Yes, no data. Maybe we need to clearly define the population subgroup, and we must do studies to see if any benefit in that subpopulation. And again, immune compromised state is not uniform. As I told you, post-transplant patients, post 1 month of their transplant, they will be on immune suppressive medications. In that population subgroup, definitely treating and screening the asymptomatic bacteriuria is more harmful than not screening or treating. So if we extrapolate to other immune compromised subgroups, maybe we need to do other trials, but definitely with available evidence, there is no rationale to screen or to treat in other than neutropenic patients.
Dr. Kishan, you are absolutely right in this. Dr. Manjula, do we have any other question, or because of the paucity of time, we can go ahead?
Yes, sir. Yeah.
So we must thank Dr. Kishan for this wonderful presentation. Dr. Manjula, over to you.
Thank you very much, sir. Thank you, Dr. Krishan and Dr. Ramesh Agarwal. It was wonderful. Now we are moving on to one of the most awaited session, CPC. I hand it over to Dr. Nagraj sir to conduct the session. Over to you, sir. And Dr. Nagraj sir, as we know, he is the professor of medicine at Sri Atal Bihari Vajpayee Medical College and Research Institute, Bangalore. He's the dean of faculty at Rajiv Gandhi University, Bangalore, Health University, past chairman and honorary secretary of API Karnataka chapter, and associated editor of Journal of Internal Medicine, Reviews and Reports. He has presented several papers at national and international conferences and numerous publications in various national and international journals, and he has been very helpful to us and the FeFCon Foundation as an advisory member to helping us in conducting all the scientific session, and he even helped us conducting regularly of the poster competition and the quiz. Over to you, sir. Nagraj sir.
Thank you, Dr. Manjula madam. Thank you. And this is one of the most awaited program in this conference, clinico-pathological conference. So from clinical side, we have got Professor B.V. Murali Mohan. He is a senior consultant and academic director, Department of Internal Medicine and Pulmonology at Narayana Hrudayalaya, and also a former professor and HOD medicine at Dr. B.R. Ambedkar Medical College. And he has got innumerable awards and orations, and is at present chairman-elect of API Karnataka. And he has got numerous papers and posters presented at national and international conferences and journals, and is the joint author of WHO Manual of Tobacco Cessation for Doctors and Dentists, author of Manual of Basic Life Support, and founder of Nightingale's Life-Saving Services, and former editor-in-chief of Karnataka Journal of Medical Sciences. And his areas of interest include pulmonary and vascular diseases and ILD. And his special abilities and talents is a very, very avid quizzer. And many of us remember him in participating Mastermind in Mastermind India BBC serial. And this quizzing and that investigative approach will definitely help in analyzing this case, and definitely it is going to be very informative and educative discussion. And I want to introduce Professor Rajalakshmi, Dr. Rajalakshmi Tirumale. She is from the pathological side for this conference. Madam has given this case, and she will be discussing after once Dr. Murali Mohan discusses. Professor Rajalakshmi is a professor and HOD of St. John's Medical College, Pathology Department, and also head of the Dermatopathology Fellowship Program. And she is editor-in-chief of Indian Journal of Dermatopathology and Diagnostic Dermatology. And she has got fellowship in dermatopathology from Germany, and also she has been awarded visiting scholar awarded from Germany, and she has got training in soft tissue pathology at NIH Bethesda, and recipient of A.S. Thambian Award and NAMS and Nalini Bai Thakkar Award by IAC. And her areas of interest are cutaneous lymphomas. I'm very grateful to you, madam, for sharing this case and agreeing to discuss with us. Now I invite Professor B.V. Murali Mohan to discuss this case.
Right. Is the screen visible?
Yeah, yes, sir. Yes, sir. It's visible, sir.
Oh. So this case was entitled CPC, Horses or Zebras. And I bring you greetings from Narayana Health, and of course, a very special thanks to the organizers of the Fever Foundation Meet 2022. In particular, Dr. Nagraj, Professor Nagraj, who would not take no for an answer, because I'm always very frightened when I have to do these CPCs, a challenge. And when Dr. Manjula and others kept sending registrations of 40,000 plus, it becomes even more intimidating. Dr. Rajalakshmi, of course, thank you for this case. And she is the person we refer all cases that our pathologists are confounded by. We get a second opinion from her at St. John's. So I'm looking forward to when she actually reveals the answer, because I must confess, I'm still fairly confounded by this case. Let's go into the discussion of the case itself. This was a gentleman, 32-year-old, with no previous comorbidities, who presented with a low-grade fever for 2 months, a decreased appetite and weight loss for about 6 weeks, and had started vomiting 7 days ago. So low-grade fever and decreased appetite and weight loss clearly points to the presence of a person who has a significant systemic illness. He's 34-year-old, fairly, healthy, apparently previously. We think he is probably immunocompetent, and there's no history of comorbidities. None of those have been stated specifically. So he's had an abdominal pain, predominantly in the right upper quadrant. The cause is uncertain. It's been going on for 2 months. It's not clear whether he's sought medical help in that time. And since we have an abdominal right upper lobe, right upper quadrant source of pain, the differential diagnoses are few. We will, however, also keep in mind the lower likelihood of referred pain from somewhere else. The second issue is his fever going on for the same amount of time. And fever almost always points us towards infection, while we cannot completely rule out non-infectious conditions. But a young man, abdominal pain, fever, right upper quadrant pain, followed by decreased appetite and weight loss and vomiting, it seems to be a progressive, a subacute to chronic condition. So we need more information at this point, but we're thinking of an abdominal-based infection. When we go deeper into the abdominal pain, it's reported as being insidious in onset and progressive. It was localized to the right hypochondrium. It was dull aching and continuous, not associated with any radiation, no association with food intake, and no aggravating or relieving factors. So we pretty much covered the questions we usually ask when we come to any pain in order to determine the origin of the pain. And some important negative features: there's no history of diarrhea or vomiting at the onset, though the vomiting occurred about 1.5 months, 2 to 4 weeks down the line. There's no history of blood in the stools, so that does not seem to be a significant amount of colitis or enteritis. There's no history of jaundice, clay-colored stools, or pruritus. somewhat ruling out an obstructive hepatopathy, biliary tract obstructive lesion. You look at the differential diagnosis of abdominal pain, the right upper quadrant specifically points towards biliary, colonic, hepatic, pulmonary, or even renal causes, because these are the organs located in and around the right upper quadrant and can refer pain to the right upper quadrant. Biliary, we think of cholecystitis, cholelithiasis, and cholangitis. Colonic, of course, could be colitis and diverticulitis, especially if it involves the ascending colon and the transverse colon. But hepatic seems the most likely in this person, staying localized to that region, not associated with jaundice or pruritus, not associated with blood in the stool or any bowel disturbances. And the referred pains from pulmonary and renal seem extremely unlikely, given the absence of any respiratory symptoms, any respiratory findings reported later, or any renal symptoms, including abdominal pain of the typical colicky nature, the loin to groin kind of pain, or any changes in the urine. So we'll stick with hepatic as being the most likely. We can also think of epigastric pain referred to the right upper quadrant, often missed by patients when they point to the whole upper abdomen being unable to localize it well, especially in the case of visceral pain. But I still would put these on the back burner and focus on the hepatic source of the pain being the most likely. When there is abdominal pain associated with fever, the differential diagnosis narrows. And when we localize fever and abdominal pain in the right upper quadrant, we have a very short list of conditions. We have hepatitis, we have hepatic abscesses, and we have liver-related issues such as cholecystitis and cholangitis. Most of the other causes we can relatively rule out in this patient, and I take into account the later findings that emerged on examination as well as the imaging. So this patient had fever, which went on for 2 months. It is undocumented, but he describes it as being more in the evenings, apparently. There was also some loss of appetite, almost 50%, and a weight loss of about 6 kgs over 2 months. And this is an involuntary weight loss associated with a decreased intake. Now, whenever in India we have somebody going on with fever for 2 months, especially if it's low grade, especially if there's an evening rise of temperature, there is a loss of appetite and weight, we think of classic symptoms of tuberculosis. However, they are non-specific symptoms, and they can add little more than make it likely to be some kind of subacute or chronic infection. However, in India, we will have every responsibility to keep tuberculosis in the differential diagnosis. So in the light of the first symptoms, we'll need to consider the possibility of abdominal tuberculosis or some other non-tuberculous abdominal infection. The patient then, a week before he came to medical attention, described pain and redness in the left lower limb, extending from mid-thigh to mid-calf, not associated with swelling of the entire limb. So at this point, I asked myself, am I dealing with a venous thrombosis, typically a DVT, though I'd expect a DVT to involve the whole limb and not just halfway down the thigh up to halfway down the calf? Is it a cellulitis spreading from somewhere in between? Or is it some other lesion? Unclear at this stage because we have not yet gone to the examination. So let's keep venous thrombosis in mind and cellulitis or other lesions. And while I've mentioned deep venous thrombosis, we must keep the possibility of a superficial thrombophlebitis in mind because that could produce localized symptoms. So then we move on to the examination. This person has a heart rate of about 98 per minute, a temperature of 100.2 degrees centigrade, and on examination, he was found to have localized redness and tenderness, noted on the lateral side of the left leg and thigh. The other findings were all relatively normal, including a normal saturation, and importantly, no icterus. So in somebody who's got right upper quadrant pain and no icterus, it seems to rule out the likelihood of an acute hepatitis or even a subacute hepatitis and a biliary issue. The fever and tachycardia that he describes, infection he has, and again on examination, I'd say probably a venous thrombosis superficial versus a cellulitis, which is localized. However, we cannot rule out the cutaneous spread of a malignancy or a paraneoplastic skin manifestation, And I'm bringing these in because of his significant weight loss and rapid weight loss. However, these are unlikely, as such manifestations tend to be multiple and small rather than single and large. I'm sorry, that should have been single rather than simple. Autocorrect has been over helpful in this case. So a venous thrombosis, I thought, was much more likely than the other differential diagnosis of the skin lesion. So we move on to the systemic examination. The abdomen apparently was normal on inspection. The umbilicus was central. There were no visible pulsations or peristalsis and no dilated veins. But the important finding was the liver was palpable 5 centimeters below the right costal margin. It was tender. It had a smooth surface. And the liver span was described as being 12 centimeters. The liver span can be anywhere, according to the literature we have, from 6 to 12 centimeters, though we more often teach between 10 and 12 centimeters. So it's a little surprising that this 5 centimeter palpable liver is only 12 centimeters. However, we'll accept that there is significant hepatomegaly, and this is a tender hepatomegaly. And all the other findings in the abdomen and the other systems were normal. So when you look at causes of hepatomegaly, and we've ruled out concurrent splenomegaly and jaundice, we have 4 groups of conditions: infiltrative, congestive, infectious, and inflammatory. By and large, tenderness does not occur in infiltrative conditions, but when we throw it into the mix, it can also be due to a malignant infiltration by primary carcinoma, because tender hepatomegaly occurs usually when there is a rapid enlargement of the liver with stretching of the liver capsule. Typically, this can occur in congestive failure, infectious conditions, and inflammatory conditions. So in this particular patient, we'll keep the following differentials: a primary carcinoma of the liver, of course, but also a liver abscess. Bacterial cholangitis is possible, though unlikely because of the absence of any liver, any jaundice, and tuberculosis. And of course, inflammatory conditions, top of the list being alcoholic and autoimmune hepatitis, though rarely drug-induced hepatitis and sarcoidosis would also come into the mix. Sarcoidosis rarely is tender, it's usually non-tender. We move on to the investigations, and we find the person is mildly anemic with neutrophilic leukocytosis. Almost 20,000 is the total count, with an 87% neutrophils. His liver functions show mild hypoalbuminemia with a mildly elevated total bilirubin, just borderline, and a mildly elevated conjugated bilirubin. His PT-INR and APTT were significantly abnormal. 1.4 is the INR, and APTT of 30 seconds, while his transaminases again were mildly elevated. So was the alkaline phosphatase and GGT. The alpha fetoprotein, normally about 9 to 10 units per liter, or less than that, I should say, was about 2.4, so in the normal range. He had his serology done and was negative for hepatitis B, C, and HIV. So to summarize the blood investigations: mild anemia, neutrophilic leukocytosis, mild hypoalbuminemia and mild conjugated hyperbilirubinemia, elevated PT and APTT with mildly elevated transaminases, GGT, and alkaline phosphatase, negative serology, a normal AFP. Other tumor markers like the CA19-9, 125, and the CEA are not been mentioned. And normally we would do this whole panel together, but clearly the problem is focused around the liver and appears to be of infective origin with a mild anemia. As I mentioned earlier, the AFB is normal. However, an AFB in a hepatocellular carcinoma has only about an 80, and sometimes described as being 50 to 70% sensitivity. So a normal AFP does not rule out for us the possibility of a hepatocellular carcinoma, which we brought into the differential diagnosis so far. We move on to the imaging that the patient had, and his ultrasound showed hypoechoic lesions in both lobes of the liver and was thought to be a pyogenic liver abscess on first description. He also had an ultrasound venous Doppler of the lower limbs, and this showed a left great saphenous vein thrombus extending from the saphenofemoral junction to the mid-calf, and this had been done in view of his lower limb pain, and I assume because of the red lesion that was seen. So, to summarize his ultrasound and Doppler findings, This is probably a liver abscess. And again, because there were multiple hyperechoic lesions, pyogenic, more likely than an amoebic liver lesion, which tends to be large and single. We cannot rule out a hepatocellular carcinoma because multicentric origins are known, and more often intrahepatic spread of a primary hepatocellular carcinoma. So let's wait for further imaging. And he probably has a superficial venous thrombosis or venous thrombophlebitis. The chest X-ray, not the clearest image. I mean, it's coming on a PDF, so I can accept, that it is most likely to be normal. I don't see any evidence of secondaries. There are a couple of doubtful areas on the image, such as the left lower zone, but I'm unwilling to commit myself to saying that this is an abnormal chest X-ray. The contrast-enhanced CT abdomen was done in the classic 3 phases, the venous phase, the arterial phase, and a portovenous phase. And what we are seeing here, and I'll come back to the official description later, is multiple hypoattenuated lesions in the liver, predominantly involving the left lobe, which appears enlarged. We also see a much larger lower lobe lesion, which was later measured as being over 6 centimeters in 2 dimensions and extending into other areas of the liver. In the venous phase, we saw mild peripheral enhancement and non-enhancing centers, such as that of a cyst or abscess. In the arterial phase, there is enhancement of more of the liver, as you can see here, but still the center does not get enhanced. And when you move into the portovenous phase, there is more of delayed enhancement and some central pseudocapsule formation in the center. The spleen on this does not seem to be enlarged, and I'm unable on the images provided to make out any lymph node enlargement of significance, though it appears that close to the porta hepatis, there may be some lymph node enlargement. But let's go on to the official description. They said in size, there were several well-defined, peripheral thick called cystic. They described it as non-enhancing centers. Lesions noted throughout the liver, predominantly in the left lobe, compressing the left branch of the portal vein, no infiltration, and the largest lesion was 6.6 by 6.2 centimeters. They also described periportal and peripancreatic lymph nodes, with the largest being about 10 millimeters in size, and the rest of it was normal. Very specifically, there was no intrahepatic biliary radical dilatation. So to summarize, hepatomegaly, well-defined cystic lesions, large and small, thick-walled, peripherally enhancing, one of them compressing the left branch of the portal vein, indicating that it's probably an expansile lesion, could be a mass lesion, it could be an abscess, and draining lymph nodes, the larger of which is about 1 centimeter in size. And then they finally tell us that fine needle aspiration and biopsy of the liver lesions were done. And this is interesting because it kind of pushes us towards ruling out an abscess because we wouldn't do a fine needle aspiration and certainly not a biopsy if it happened to be a node. We'd rather be doing an aspiration and putting in a catheter, typically a pigtail catheter. So to summarize, we have a 2-month history in a 34-year-old male with no comorbidities, presenting with fever of low-grade weight loss and a right upper quadrant pain, tender hepatomegaly without icterus, neutrophilic leukocytosis in inflammatory markers being elevated, mildly elevated transaminases, mildly elevated alkaline phosphatase, mildly abnormal clotting tests, and a negative hepatitis serology for the classic hepatitis B, C, and HIV. He had a normal AFP. He had peripherally enhancing large liver lesions with multiple smaller lesions, late central enhancement, and shaggy inner borders with superficial thrombophlebitis. So what I would like to have known, which was not provided, is whether there's any history of ethanol or drug use, for example, the use of anabolic steroids, which increases the risk of conditions like a hepatocellular carcinoma, whether there was any family history, any preceding GI symptoms, diarrhea, which would push you more towards a diagnosis of an abscess, pyogenic or amoebic, what the results were on other tumor markers, and whether there's any possible aflatoxin exposure, which makes a hepatocellular carcinoma more likely. So my differential diagnosis at this point would be a liver abscess, either pyogenic or amoebic, a hepatocellular carcinoma, or an isolated liver tuberculous abscess or liver tubercular lesion. If you look at the symptoms and signs of a pyogenic liver abscess, fever and weight loss are very common symptoms supporting the diagnosis in this person, and later nausea, vomiting, and anorexia. The signs are not very typical. He did not have any of the signs we might expect, or they were not provided. This was an interesting paper from Pakistan, which showed that it was more likely that you will have a pyogenic abscess in a woman, older age, not a 34-year-old. The cutoff given was 60. The presence of diabetes mellitus, which this patient did not have, abdominal pain and tenderness, which he did, and jaundice, which he did not have. So some plus minus features. The white cell count was not really useful to differentiate between an amoebic and a pyogenic abscess, something we were always taught. But in their study, there was no evidence of that. The albumin was low, much lower than in this patient, but there, it was around 2, between 2 and 2.5. Multiple abscesses, of course, favored pyogenic liver abscesses, and larger abscess diameters were not different. When both lobes of the liver were involved, it is much more likely, almost 3.5 times more likely, to be a pyogenic abscess. So between amoebic and pyogenic, I think I would favor a pyogenic abscess. However, there are some odd points. The history was a little too long, 2 months of fever. Pyogenic abscesses tend to be more acute. The low-grade fever rather than high fever, and the late central enhancement is unlikely. Typically, you get some peripheral enhancement late, that is called a pseudocapsule. That we are not seeing in this patient, except in the last portal venous image. And the second thing, as I mentioned earlier, he had an FNAC and biopsy done, not the investigations of choice with a pyogenic abscess. So let's consider the alternative. And these are the differentials offered: hepatocellular carcinoma and hydatid cyst. Again, one would have to be extremely bold to do an FNAC or a biopsy in a hydatid cyst, so we can largely exclude that. Hepatocellular carcinoma, therefore, seems to be the main differential diagnosis we need to consider. Typically, these are multifocal within the liver in 75% of cases, and they can involve the periportal nodes, as in this patient, when they metastasize. The AFP is elevated in about 75% of cases. However, it has only a 40 to 70% sensitivity. On imaging, it can appear as a focal nodule with early enhancement on the arterial phase, with rapid washout of contrast on the portal venous phase, which we didn't really see in this patient. It persisted in that phase when you do the 3-phase contrast scan that was done. And hepatocellular carcinoma typically occurs in older individuals, and they have risk factors such as cirrhosis or chronic hepatitis or alcoholic hepatitis, none of which are described in these patients. And again, if you look at the neutrophilic leukocytosis and the normal AFP, these are points against it, though they don't rule it out, as a hepatocellular carcinoma can get secondary infected and rarely can present as an abscess. The last differential that I offered is hepatic tuberculosis, an isolated lesion. The insidious onset and the age favor it. It's a rare condition, very few case reports in the literature, but it's probably being missed quite often. Neutrophilic leukocytosis is unlikely unless it's secondary infected. The imaging features, however, are fairly typical of this condition, and biopsy, the only way to confirm it, was done in this patient. So my final differential diagnosis, and I'm waiting for Dr. Rajri with bated breath to tell us what the diagnosis is: liver abscess, pyogenic, unlikely to be amoebic, a hepatocellular carcinoma, an isolated liver tuberculous abscess, and secondary infections of multiple cysts of various causes can also present like a pyogenic liver abscess. So I'll put that down as a last diagnosis. And thank you all for your invitation. And I hand it over to the chairperson, Professor Nagaraj, and of course, Professor Rajri.
Thank you, sir. Thank you. It was an excellent discussion on the information what is provided by Professor Rajalakshmi. And as physicians, always we tell more than important, more than the destination, what we travel is more important. Like that, more than the diagnosis, how we discuss the case, how we analyze these findings, that is the most important, which you have done excellently. And I now request, any questions are there, Dr. Manjula Madam? Anybody wants to ask any before Professor Rajalakshmi tells the diagnosis? Anybody, any comments or anybody in the chat box?
Can you tell us any comments on the platform? So far they're saying no questions.
Okay, then I invite Professor Rajalakshmi to give her final verdict.
Thank you, sir. I'll just share my screen.
Professor Rajalakshmi, my apologies for calling you Rajshri. One of my favorite classes was Rajshri. She just tells us the regard I hold you in.
Thank you. Is my screen visible?
Yes, ma'am.
Yes, yes, ma'am.
Okay. First of all, thank you very much for inviting me to this meeting. It's been wonderful to listen to even the couple of talks preceding. Unfortunately, I couldn't attend all of them. And also, I was a bit apprehensive. I mean, I was not sure how I would really fit in, this fever being the focus of this. And, first of all, when Dr. Nagraj called me, I took a lot of time to dig out a case because he said, there has to be fever and there has to be a twist, unusual presentations like pyogenic liver abscesses. So the good thing here was that there was a constant discussion. There was a multidisciplinary discussion which was going on between the surgeon, the radiologist, the pathologist. So as early as 72 hours after starting antibiotic, they took him up for a biopsy. So they felt there is something unusual about this case which needs a biopsy rather than waiting for long. So there was an early FNA biopsy done, which facilitated the diagnosis in this patient. But nevertheless, it is unfortunate. Despite doing all this, using immunohistochemistry, the young patient could not be saved, which is unfortunate. So this case goes to show that, you have horses and you have zebras, and you might have just that one zebra, which is among horses, which you might miss if you don't do timely reviews and multidisciplinary consultations. So cliched as it may sound, it is always teamwork that prevails. So thank you very much for inviting me to this meeting. And I'd like to thank Dr. Sridhar, whose case this was, for kindly sharing all the clinical details with me and enabling me to present this here. Thank you very much.
Thank you, madam. Sir, go ahead, sir.
Yeah, thank you, Professor Lal. Something that's very important. It pushes you towards a diagnosis of malignancy. In a lifetime, I would not have got the, the small middle lobe primary, but that tells us about 2 or 3 things. One is the great importance of the immunohistochemistry, which has transformed our knowledge of how to identify lesions and how dependent we are on the pathologist these days. That diagnosis could never have been achieved, I think, without the help of pathology. The second, and something I want to bring out, because this is one of my passions, is that a patient like this should be, I'm sure he was, knowing St. John's practices, should always be on prophylactic anticoagulation when they're in the ward.
He was on anticoagulation.
Yeah. So despite the fact that he had abnormal clottings, he still went on to develop a pulmonary embolism, which tells you how, prothrombotic these patients are. So 2 important lessons for me there. One is a minor finding like the superficial thrombophlebitis may actually give you a clue. I honestly don't know why I left it out, because that's the first thing that struck me. And the second is the importance of continued anticoagulation. And when you can't anticoagulate, take at least mechanical thromboprophylaxis into mind. Thank you. Back to Professor Nagraj.
So he was on prophylactic anticoagulation, plus it was the dose was hiked up, and he was also on mechanical devices. But despite that, the thrombosis was so extensive, such a prothrombotic tumor that unfortunately he could not be rescued from that.
Thank you, madam. That is very, very interesting. In spite of your perseverance, it was very, very unlucky for the patient. Suddenly, with thromboembolism, he was to die. Okay, thank you very much, Professor.
Thank you.
Dr. Nagraj, I'm Sudha Vidyasagar. Can I say something?
Yeah. Please go ahead.
Dr. Murali and Dr. Rajalakshmi, fantastic presentation, both of you. So well presented. Only one thing I want to tell you, Dr. Murali, I thought you got it right on the chest X-ray. You made out a small nodule on the left lower lobe. I thought it was there. And you backed off saying, I don't know whether there's a secondary there. I thought I should ask Dr. Rajalakshmi when she did the CT. I thought he was right. There was a small nodule in the left lower lobe, very short. And the right middle lobe, if you look at it, Dr. Murali, again, you will see it's a retrospectroscope. But yeah, you would probably see it because there's something round on the right side. And I thought you were going to analyze the chest X-ray a little more, but you said, I don't know. I think we all give up at some point, but fantastic discussion. Thank you so much.
Thank you.
Thank you, ma'am.
I'm spoiled by having CT is an excellent quality X-ray, so that's why I didn't want to, hazard too much of a guess on the X-ray.
Okay, right.
Thank you, everyone. Back to Dr. Manjula.
Thank you very much, sir. Thank you, Nagraj sir, Dr. Murli sir, and Rajalakshmi madam. It was fantastic. We will be moving on to the next session, another most awaited session, pro-con debate. I have a pleasure and privilege of welcoming Dr. Pradeep Rangappa sir to chair this session. Okay, thank you. Dr. Pradeep Rangappa sir is a DNB diplomat in National Board from St. John's and fellow in the Joint Faculty of Intensive Care from Australia, European diplomat in Intensive Care, and fellow of College of Intensive Care from Australia. So currently is a national president for Indian Society of Critical Care Medicine, consultant intensive care physician at Manipal Hospital, Yeshwanthpur, Bangalore. He is in Indian Society of Clinical Care Medicine, Bangalore, past secretary, and also he has been holding various positions at ISCCM and Indian College of Critical Care Medicine. And he's been a very, very organizational man, and he has done a lot of conferences. The recent one being GICS, which happened just a few months ago, 2022. And also he's been in critical care 2015 and GAPIO. So Dr. Pradeep Rangappa sir, it's pleasure and having you. Welcome you, sir. Over to you for this session, sir.
So good afternoon, everyone. So thank you, Dr. Manjula, for giving that exhaustive introduction. So I think it was a fantastic CPC discussion. I was really enjoying the discussion that was happening. So great. So now I think we'll move the momentum towards intensive care. So the debate that we have today is about antifungal. So in someone in ICU who has an ongoing fever, where you do not have a bacterial cause or where the cause is not established, very similar to the last case, where you throw in antibiotics. So would the intensivist throw in an antifungal agent? So this is something which is a contentious issue or a situation, and even our sepsis guidelines do suggest that if you have a fever with shock which is not resolving or fever with sepsis, and if the suspicion of fungemia or candidemia is there, then one should consider antifungal. So that is the backdrop of this whole debate. So we have two excellent academicians. So we have Dr. Vivekananthan from Royal Care Hospital from Coimbatore. So a good friend of mine from an intensivist who's trained in UK and in India. So he's a senior consultant at Royal Care from Coimbatore. So he will be talking in favor of starting an antifungal therapy in someone where fever is not resolving, and maybe he will be adhering to the sepsis guidelines as well, I would think. So the person who will be debating against Vivek would be Dr. Neha Mishra, who is an ID specialist from Manipal Hospital, a good friend of mine as well. So she would be debating that we should not put antifungal therapy without possibly having a sound evidence for initiating this therapy. And all this, for all the listeners, should be the backdrop of emerging resistance to antimicrobial therapies and antifungal agents as well. And India is at the forefront of having increasing resistance even to antifungals, especially with the emergence of Candida auris. So that would be the sort of a backdrop. So I invite Dr. Vivek to start off his presentation. So the way it will go is Vivek will present, followed by Neha Mishra, and there'll be rebuttal of possibly 2 minutes or 3 minutes from Vivek, and then Neha Mishra and the concluding remarks. Over to you, Dr. Vivek.
Thank you, Dr. Pradeep.
And thank you for the foundation to initiate this. And it's an excellent opportunity for me to present over here. Thanks for the opportunity as well. Can you view the screen?
Yeah, we can see the screen and you're very audible.
Okay, thank you. And good afternoon from the Department of Intensive Care Medicine at Royal Care Hospital. The fever in ICU, which is not responding to antibiotics. Will you add antifungal without proof? So do we need the proof? So that is the question. And I would say probably yes. And the overview of the talk would include what the context would be, why and where we are in such a clinical situation, what are the evidences that we have got, and what are the guidelines that we can rely on, and what is the clinical relevance as well. So what exactly is the context? So if you look at globally, I think we have got enough papers to suggest a study among 23 ICUs among 9 European countries, giving us a data that the incidence of candidemia, where I'm choosing candidemia being the number one fungal infection in ICU, that the incidence seems to be around 7 episodes per 1,000 ICU admissions, and the crude mortality rate is huge at around 42%. What about across the world? You've got nearly 1,200 odd intensive care units participating across 76 countries, and the prevalence is pretty much the same, around 7 episodes per 1,000 ICU patients. And again, the crude mortality is huge. And what I wanted to impress upon is the length of ICU stay in patients with candidemia. It is nearly 33 days as against the gram-positive and gram-negative infections of 20 odd days. So quite an intense problem there. And what kind of ICUs do these patients are harbored in? Probably medical ICU is having a higher incidence when compared to surgical ICUs, and the incidence is quite high with mixed ICUs as well. And Candida albicans seems to be the most frequent isolate across the world. What about the Indian context? So there is quite a significant mortality occurring because of the candidemia, and the overall incidence within the Indian context is still the same. And what is interesting to note is you've got the median day of occurrence is much lesser. The median day is roughly 8 days. And even in patients with less severe physiological score, you've got the occurrence of candidemia, and the mortality is still the same. So what we are going to argue or suggest from my perspective is that we are not in a position to look at the risk and give a prophylaxis, which is a totally different group of patients that we're going to deal with. And within this context of ICU, the invasive fungal infection can range anything from 20 to 90% among septic patients having fever while on antibiotics. And if we were to rely on waiting for the diagnosis to come through, then probably we might be at loss. So what we are looking at is patients who have got symptoms, they are septic, and looking for other markers which can suggest probably we should go empirically to deal with them. There is a huge burden of having a negative blood culture among these patients. So what kind of negativity have we got here? So even in invasive candidiasis, I think we have got only less than 50% of them, there is a positivity. And if you're looking at intra-abdominal candidiasis, again, it will be less than 20% of the times that you're going to have a positivity. But most of the patients, we have got a good negative predictive value of the markers, which can suggest that we can withhold antifungal therapy even if you're going to start one. So there is a caveat there which we can rely upon. So majority of the time, there isn't a proof. That is a huge problem. So symptomatically, if the patient is going to have a risk, then we are going to have them on empirical therapy where there is symptoms and signs and the risk factors are there. So we need to individually look at patients whether there is a risk factor or not. Unfortunately, if you're going to delay things, there is going to be a huge mortality. So look at this paper, Gary et al., and subsequently Cortigini as well, highlighting that if there was a delay in starting fluconazole therapy, then by day 3, if it was delayed, then nearly 41% of them die. But if it was started earlier, then only 15% of them die. What they went on to say was there were independent predictors of mortality, which was increased time until fluconazole initiation was done, and of course, the higher Apache score as well. So the suggestion was clinicians should take into account the clinical evaluation, risk factor assessment, the scores, the Candida scores, and other surrogate biomarkers to individualize and start the empirical therapy as soon as you could. And what are the risk factors do these patients harbor? So the odds ratio of all these risk factors have been highlighted here. And although the odds ratio is modest, it still is valuable in identifying these risk factors among the patients. So you've got further risk factors of renal replacement therapy, the mechanical ventilation per se, and I wanted to highlight the 2 factors, which are a patient having sepsis and the patient who are on broad spectrum antibiotics. They do carry the risk factor. And what does the Candida score tell us? So it has been validated previously, but it has been updated now with this particular paper with the new sepsis guideline, what has been come through as the sepsis 3 criteria. And still those parameters holds good, that sepsis is valued at 2 points, and somebody on total parental nutrition has 1 point, surgery has 1 point, and Candida colonization at 2 or more sterile, unsterile sites as 1 point. And that would still have a incidence going up quite significantly when the score is 3 or more. So how could we use the biomarkers to risk stratify patients? So there are quite a lot of suggestions, scoring systems that are in place, and the Candida scoring more than 3 is something reasonably validated. But if you have to look at what I wanted to emphasize is the negative predictive value of these parameters, where you should emphasize and individualize the care as to when you're going to de-escalate the care. So if you're going to start empirical therapy, I would rather rely on these markers for de-escalation rather than on the positive predictive value of them. So biomarker utilization based on beta-D-glucan, if you're going to rely on the numbers, then probably majority of them would say as 80 picograms. But if you're going to increase it further to 200 picograms, then probably the specificity goes up and you can very well use it for your de-escalation purposes very well. So what does the European Society of Intensive Care Medicine and the European Society of Clinical Microbiology and Infectious Diseases Task Force make recommendations on? They very well say that the risk prediction models, because of their simplicity, high negative predictive value, should be used for identifying high-risk patients, which is coming up as a strong recommendation. Let us look at the guidelines from IDSA, specifically tailored towards what is the role of empirical treatment for suspected universal candidiasis in non-neutropenic patients in ICU. So it's pretty much explicit. Empirical antifungal therapy should be considered in critically ill patients with risk factors for invasive candidiasis, and the fever is not because of any other reason. And the clinical assessment of risk factors, the surrogate markers for invasive candidiasis, the culture data from non-sterile sites, all these things should be taken into account for starting empirical antifungal therapy, which enjoys a strong recommendation with a moderate quality of evidence. Again, empirical antifungal therapy should be started as soon as possible in patients if they are in septic shock. So it is pretty much explicit. If the patient deteriorates further for septic shock, you would go on to give empirical therapy. But we have got the context of a patient who is septic in ICU. So I would pretty much value the first point of IDSA that we should go for empirical therapy. And IDSA pretty much explicitly prefers the empirical therapy to be echinocandin, and fluconazole can be an surrogate or alternative. And also it goes on to mention about de-escalation as well when there is no clinical response by day 4 or 5, and do not have a subsequent evidence of invasive candidiasis, or have a negative non-culture based diagnostic assay with a high negative predictive value, then probably you could stop that empirical antifungal therapy that has been started. So there is a definitive endpoint to it as well, which has been very well defined. And how about the European Society task force on practical management of such patients? So what they had to say was, if the patient is in septic shock or multi-organ failure with more than one extradigestive site having colonized, then they do recommend as well. And they go on to explicitly come up with this flow chart in terms of a septic patient who is non-neutropenic, non-transplanted patient, having a specifically abdominal sepsis. Then if there is an absence of the abdominal sepsis, then goes on for a higher incidence of candidemia, where you would rather look at the Candida score and the colonization index and exclude other reasons for the fever, and rely on other markers where you can still go ahead with an empirical antifungal therapy, because the likelihood of having an invasive candidemia or candidial infection is high. So you would empirically start it and then reevaluate by day 4 or 5, and probably have a antifungal stewardship strongly based on that fact. And there is this flow chart on the right, the blue mark, saying that better individualization of the immune status and risk stratification of the patient will prove worthy with the aid of diagnostic tests as well. What is the empirical trial? I'm sure my opponent is going to lever pretty much on this trial, wherein the 19 ICUs in France have taken this, and the study had 518 patients, and the intervention was with micafungin, and the primary outcome was no statistical difference in patients alive and free from fungal infections at 28 days. But I would like to highlight a few other areas, which is that the secondary observation was that the micafungin group had a significantly lower incidence of new proven invasive fungal infections. And the other point I wanted to emphasize upon is the fragility.
Please mute
index,
Mr. Raja.
Come up with is how fragile the trial is. So if you look at the fragility index of this particular trial per se, it enjoys a score of 3, but it may not be adequate. If you compare it with the counterparts of many other intensive care trials, the number is pretty slim, and the validity of the trial per se can be very fragile if you're going to go by that trial. What are the other factors that I wanted to highlight upon? There are some key differences in the baseline characteristics of this trial, which the intervention group had only higher BMI patients, more so chronic renal disease patients and diabetic patients, when compared to the control group, where the chronic respiratory disease was there and immunosuppressed patients and septic shock patients were there. So the homogenization of this group wasn't perfect. And the trial goes on to highlight that the survival was noted among patients with higher SOFA score, and in the particular group was the critically ill subgroup, and they could benefit from empirical therapy. Additionally, there was a low participation of patients where the risk is high, like the necrotizing pancreatitis patients or the postoperative gastrointestinal leakage patients. So many studies previously have shown that surgical patients do benefit from empirical therapy. And what are we afraid of? And my opponent might argue that increasing resistance among Candida species is a risk, higher cost of drugs, potential side effects. But we are not going to put our head into sand like the ostrich, but we have got this rescue that the antifungal stewardship, if it is properly practiced, that we are going to de-escalate. If the risk factors are not there by day 5, what is the harm in starting the empirical therapy? So we have also got the notion of this early empirical antifungal therapy. So where does it come from? There are evidences emerging, like Breuer et al., going on to say the time lapsed from candidemia onset to echinocondrin therapy initiation can very well be shortened. And we have seen this before, that if you're going to shorten this duration, then the mortality benefit will be there. And the next flow diagram of this study highlighting that if antifungal therapy is started empirically, and of which there are around 51 patients where it was done, and the empirical therapy in 39 patients, 9 of them had a proven invasive candidiasis. Do remember the first slide where the culture positivity is very slim in these patients, but of the 30 patients where it was not proven, the response was nearly 18 out of the 30 responded to empirical therapy. That's a huge number. That's a huge number. What do we know about the survival benefit? Well, survival rate can be up to 90%, ranging from 50 to 90. And there are 2 studies of the empirical antifungal therapy that was reviewed over the last decade in this Journal of Fungi in 2022 recently, that 2 studies from Singapore and 1 from China did find that early antifungal therapy is an independent protective factor that reduces hospital mortality. And the survival is also better, especially in this group of critically ill patients who are admitted to ICU. At least 3 out of the 12 studies reported significant association between survival rate and early antifungal therapy they empirically started. So I think the evidence is emerging, and this is from the last decade of data through this article that has come up. And then the study by Koloff et al. Delayed antifungal therapy, which is defined as no antifungal therapy within 24 hours of onset of septic shock, will result in higher hospital mortality. So it's pretty obvious that we need to act soon. And this kind of flow charts, which are available in many of the studies, do suggest that you need to individualize patients, take the help of Candida score, take the help of biological markers, risk stratify them, and then appropriately start the empirical therapy, and then de-escalate at the earliest option, which will be around 4 days and 5 days. So one more evidence to state that from the American Thoracic Society, that invasive candidiasis is common and rather morbid complications from the critically ill patients. The diagnosis is elusive and often delayed, and beta-D-glucone has been proposed as a rapid method for early diagnosis of candidiasis. That is all that we know of, but we cannot take it in isolation. So that is my point, that if you're going to risk stratify patients based on multiple parameters, then you could very well start and stop as needed. So delay in initiating therapy is what we are concerned about. And if you are going to cause undue delay, that will result in poorer outcomes. And what do you think of IDSA and all these guidelines that has come up with? There is an editorial suggesting that when the experts looked at all these evidences, the applicability of the IDSA guideline per se, which is very clear to the extent of 97%, still is not applicable on a clinical note. So that is something to be considered. So if I am an average physician who is at the bedside trying to look at up-to-date, this is what they have to say. The decision has to be individualized based on clinical assessment, surrogate markers, and culture data demonstrating Candida colonization at non-sterile sites. So individualization is the key. And if I were to sum up, we should not generalize the results of any one particular trial, and that particular trial probably has a non-homogeneous group, and individualized care is the way forward. And early empirical therapy will save lives, and de-escalation with appropriate antifungal stewardship principles will hold our practice very well. And I leave with a clinical scenario.
Vivek, can we summarize, Vivek, because we may be running short of time.
Okay.
So if you can just put up a conclusion slide so that we can move to.
This is pretty much my conclusion slide. I leave my opponent with this clinical scenario, which we have got a diabetic patient, non-oliguric CKD patient with a marginally high creatinine, admitted for fever for 3 days, started on antibiotics, spikes in temperature persisting. Day 2, mild oliguria, shifted to ICU, and day 4, mild hypotension with fluid resuscitation, central venous catheter is in place, fever is persisting, there is no foci which has been identified in cultures. And day 5 gives you this data. Would you rather consider risk stratifying this patient or not, is my question. I may not be right always, but I am never wrong. With this, I leave it with a good luck to my opponent. Thank you.
So thank you very much, Vivek. I think it was an excellent presentation covering all the salient aspects, put up a very good defense, especially covering on the sensitive point of antifungal stewardship, which we should all embrace and adopt to. So I'll hand over to Neha Mishra to see how she would counter and what would be her contrarian viewpoint would be on this. Over to you, Dr. Neha.
Yeah. Good afternoon, everybody. First of all, thank you, Fever Foundation, for having me here and giving me this opportunity to be presenting this topic. And as a ID physician, whenever I get, I like talking about stopping antimicrobials. So probably that's the reason I chose the topic. And I am sure Dr. Vivekanathan has given a very nice presentation, but let us hear out my viewpoint as well. So today I'll be talking about fever in ICU. Who is not responding to an antibiotic? Will you antifungal without proof? Yes or no? At an outset, I would say no. And individualization, again, as he said as well, is the key. It should not be a blanket statement that everybody who's not responding to fever should be on antifungals at the get-go. And yeah. So somebody wants to add an antifungal empirically to a patient for the given scenario. Now, what are my major, I will take you in next 10, 12 minutes max through whatever evidence I think is adequate for this. So fever in ICU can mean multiple things. There was a talk in the beginning of the session today about hyperthermia and pyrexia. Pyrexia, again, there are causes like infectious causes and non-infectious causes. And then there is a long list. Most of the time, non-infectious causes do get, they are not, they get sidelined, particularly, especially in ICU setup. If somebody is presenting with fever, we all, even I, may tend to kind of lean on the side of infective etiology rather than looking at a non-infective etiology. So coming to instance, this is a study by Dr. Anatomical Chakravarti, which my opponent also has showed. See, we are talking about 6.51 cases in 100 ICU admissions. And it included a whole number of 215, 112 patients across 27 ICUs, and 1,400 patients had candidemia proven on cultures. So we are talking about a very small subset of patients. Number one, I understand that there is a very high risk of mortality associated with candidemia, but still we are talking about a very small subset of patients. Now, say let's do a simple math. We have 100 patients admitted in ICU. We know that the temperature detection will be positive, or patient will have fever in approximately 50 patients as per the previous data. And out of this 50 patients, only 25 patients probably will have infective etiology. And out of that infective etiologies, probably as 80 to 90% patients are usually a bacterial infection, and rest of the remaining infections like viral, parasitic, and fungal forms the other subgroup. So we are talking about probably less than 5 patients in our ICU setup. And I again say, I understand the mortality is quite high. See, so this is a data from ICMR as per the AMR surveillance network in 2021. It was published. So you see that the total ICU occurrence of Candida infections across all isolates is around 1.1% for Candida tropicalis, 0.7, or less than 1% for all the Candida species. On contrary, for our bacterial subgroup, the occurrence and the percentage at which they occur is quite high. So you can see the 13.1% E. coli. Our sweet Klebsiella keeps always be occurring more than 20% with 20% rate. So there is always a high risk of having a bacterial infection rather than a fungal infection. So now yearly trends of isolates of Candida have not changed much. This is ICMR data from 2021, and it has compared it from 2016 onwards. So you see, for our total Candida, isolation, actually it has dropped down from 2016 if you compare. I understand the culture positivity rates are low, and sometimes it may not grow a positive culture, show a positive culture report as well. But then we rely on colonization index too much that we should even keep this in mind that actually culture positivity rate is not that much for candida isolation. So it is not, again, the numbers are lower when compared to the 5 years ago numbers. Now, this again is an ICMR data across the country, across almost 20 plus centers, and from including north, south, east, west, all zones. So, see, we are looking at the overall picture. You can see here the maximum subgroup of infections are caused by 50% are caused by enterobacterial, 25% probably with your NFGNBs, your Acinetobacter and all. Then the small thin line of 2.5% is the fungal isolates. I understand for blood, it is, you are having a 7.9% of isolates in blood, but then they are being positive in blood and you know that they are okay. So if there is a candida in blood, it flashes positive as early as within 24 hours, you'll know that there is a yeast growing in blood. We know that, okay, having said that, what I wanted to emphasize that bacterial burden is still more than the fungal burden. And the occurrence of bacterial infection is very much more than the fungal infections. Now we are talking about so what we have, you may say or you may argue that we want to add an antifungal because the patient is not improving on antibiotic. So my argument towards that is actually how many antibiotics that we use as a first line of antibiotics actually work. We have good amount of resistance prevailing across the ICUs, across the different centers. See, the meropenem that we use are somewhere around 70% resistance, and this varies from center to center. Even in ICMR, where they again checked it amongst different centers, the carbapenem resistance in Klebsiella pneumoniae, you can see it is around 60% in OPD, and susceptibility is only 27% for ertapenem and 31% for imipenem in ICU setup. So that indicates that actually we may be wrong in our antibiotic selection. We have to rectify that first rather than correcting the addition of antifungals. Anyways, so we similarly you can see that carbapenem resistance for blood isolates of Acinetobacter is low. Susceptibility is quite low. Meropenem is also quite low again. And these are the trends of dropping susceptibility of several antibiotics which we use for anti-Acinetobacter all through this trend shows from 2016 onwards till 2020. So there is a dropping trend and susceptibilities for all the antibiotics which are generally used. But so what I wanted to make a point is, yes, definitely we have a disease with high mortality, but probably the burden of the disease is quite low, and we still have bacterial infection which occur in more abundance, number one, and are more resistant, number two, and they may not be responsive to the normal antibacterial which we are using. So we have good amount of carbapenem resistance. We have colistin resistance prevailing. We also know that now ceftazidime, avibactam, and astrenal synergies are also resistant. So we may want to first optimize our antibacterial profile before the addition of antifungals. But see, I still want to add, somebody still wants to add an antifungal empirically. So yes, my dear friend said that I will be banking on this trial, but this is not the only trial I'll be stating. Empiricus trial definitely had a low fragility value, but it did state that in a non-neutropenic critically ill patient with multiple candida colonization, multiple organ failure, and exposure to broad spectrum antibiotics, there was no significant difference across the different QSOFA groups and across different subgroups with be it surgical category, medical categories, and different colonization index more than 0.5 or less than 0.5, candida score more than 0.3 or less than 3. Even in subset analysis, they failed to show intent to treat population also. They failed to show any significant difference between the two. You can look at the forest plot. Now, but I'm not banking only on this trial. So see, I'll only talk about RCTs. This is an intense trial which was done. It is again exploratory, multicenter, randomized, double-blind placebo trial, which did not show any evidence that preemptive or prophylactic therapy, administration of echinocandin was effective in in preventing invasive candidiasis. Okay, so this again was difficult. Was another RCT which kind of helped us to state it against the utility of preemptive or prophylactic use. Coming to surgical patient, and the previous study was actually conducted in intra-abdominal surgery, so surgical patients. So the subgroup which we consider as probably the highest, at highest risk, and the drug use was echinocandin here. And this study is fairly recent, it is in 2015. So the subgroup that we consider as the highest subgroup also, they didn't fail to show any major benefit here. Empirically, fluconazole, when we were not talking about echinocandins back in before 2010 probably, we were using fluconazole quite often. And empirical use of fluconazole versus placebo, again it was an RCT, did not show any benefit in bringing down the mortality of patients. This is another RCT yet again, in which double-blind placebo trial of fluconazole to prevent candida infections in critically ill surgical patients. It failed to show difference in death rate. That was, either in fluconazole group or in the placebo group. So, okay, infectious disease physicians are crazy. They keep talking nonsense. They always come and say that stop this, stop that, don't do this, don't do that. Let us talk about critical care society. So, see, the surviving sepsis campaign guidelines, they updated their recent guidelines in 2021. Okay, so in this guideline, what they talked about is they have actually changed their recommendation. They recommended empirical broad spectrum therapy with one or more antimicrobials for patients who were, and they wanted to give antifungal coverage early. In the past guideline, which now they have changed, they suggest some use of antifungal therapy, and in the literature they also say it should be individualized. And this is a weak recommendation, and the quality of evidence is again low. And even in this patient 23, the 22nd point, they also changed this particular guideline. Earlier they were saying that we should cover. Now they are saying that there's no need of addition in a low risk population group. So because what they say clearly is most studies fail to show any demonstrate a causal relationship between antifungal therapy and the outcome. Hence, even the surviving sepsis campaign is not in hurry to add an antifungal when we are dealing with a patient who is probably sick in the ICU. IDSA guideline estimate guidelines, which my colleague quoted. Actually, IDSA guidelines were published in 2016 before the trials came, and even the estimate guidelines were published in 2012. They're quite old guidelines have not been updated. Lazy infectious disease people, but probably they will update it, and when they do, I think the guidelines may change, like surviving sepsis campaign guidelines have. So what is the issue? Why am I saying that we should not probably do this very often? I really am a doctor. I want to save my patients. I want him or her to do well. So I have no problem in doing whatever is in benefit to do that. But we need to keep certain salient points in our mind. See, empirical antifungal treatment may obscure the diagnosis of invasive candida infection in itself. So even if there is some amount of candida which we are suspecting that patient may develop later, if you start the patient on antifungal initially, then the culture definitely won't grow, even if the person develops fungal infection later. It may not influence the development of outcome of invasive disease. Colonization, infection, and all these complications that we are talking about due to candida are actually one of the several life-threatening complications that a critically ill patient develops. So probably it may serve as a marker of severity of primary illness, and consequently impact of antifungal treatment may be limited. We may need to concentrate on primary as well, primary problem of the patient as well. So it in itself alone is not the problem, so it has to be looked at as a whole thing. Now, invasive candidiasis is an uncommon event in the general ICU population, and the number needed to treat to prevent ICU is actually very high. So if we need to, suppose we need to treat a lot of patients to prevent one invasive candidiasis patient, that may lead to inadvertent use of antifungals. I still, my colleague persists on adding antifungals, but I said that burden of disease is extremely poor, no evidence to support. But he says, see, we will risk stratify the patient and then we will go ahead and give. So how much risk is actually a risk? Risk factor for MDRO in ICU and risk factor of invasive candidiasis are so more similar. They're almost same, apart from candida colonization, which in itself might have happened because the patient was on broad spectrum antibiotics, and serum surrogate marker beta D glucan. We'll talk about it in the next few slides. See, even if we risk stratify a patient depending upon your candida scores or risk factors that are given in several studies, there are several things that are overlapping. So how will you actually distinguish between MDRO or candidiasis? So we cannot just rely upon something like a patient has neutropenia, he's on immunosuppression, he's on longer. He can even have MDRO. We should probably, and that's more common. We should probably optimize our antibiotics first. Okay, I'll use a candida colonization and surrogate.
So Neha, can we summarize because we may be running short of time?
Slides, yeah. So candida colonization, sepsis occurring in patients with multi-organ dysfunction and multiple sites in patient receiving broad spectrum antibiotic agents. They are really due to invasive fungal infections. These are my references. Your beta D glucan are not significantly effective in distinguishing between candidemia and candida colonization. So you may be wrong when you are choosing that as a surrogate marker. So candida score may be as one of the utility factor, but it should not be relied upon completely. Then if, as he said rightly, if we use too much of antifungals, we may drive the fungal resistance. Now we are very hell-bent on using echinocandins. How effective are they? So the occurrences in ICU are commonly ICU occurring candidas are Parapsilosis, auris, and they are actually not very much susceptible to echinocandins. You can see the auris probably, this is again a ICMR data, auris probably is more common in ICU setup. And when we add echinocandin, we may be wrong in thinking that we actually are preventing that. So again, bigger class of death is always not better. So we may not be right in addition of echinocandins at the get-go, but we, there's no benefit noted of, increase, no benefit noted for the risk stratification and even use of seromarkers. So let's summarize. This is my last slide. I'm sorry I had to rush through last few slides. Let's summarize. So not all fevers are infective and common things are still common. So we should probably concentrate on optimization of our antibiotics before switching directly to antifungals. One size does not fit all. Not everybody can be treated as, okay, 3 days antibiotics not responding and we will right now go ahead and add an antifungal because 3 days over, I can't wait. We probably have to individualize for one patient from one patient to another and evaluate if necessary. I understand in ICU setups, there's no time to wait that much, but we should be quick in that. And as soon as possible, we have to do. We have actually murdered all the antibiotics and we can still save antifungals. Even if we start antibiotic for some reason, depending upon the surrogate markers and depending upon the risk factors, we must know when to de-escalate. And as my friend said, that de-escalation may be helped by the surrogate markers. That is one good point about surrogate markers we should utilize. So thank you so much. With that, I'll end the session.
So thank you very much, Neha, for putting up a good defense against not using antifungals empirically. So your whole argument appeared to be more focusing on curtailing inappropriate usage in gram-negative infections so that we could possibly avoid emergence of antifungals treatment. And possibly, I think from the narrative, I could make out that you were possibly pointing out that we should still look at bacterium as the source and try to dig out the source and try to rationalize treatment of bacteria and then consider fungals. So that's the sort of a gist I could make out. So I think I'll hand over to Vivek to have a rebuttal over 2 minutes for whatever Neha has mentioned. And then Neha will have a rebuttal for maybe 1 or 2 minutes, and then we'll take final conclusions. Over to you, Vivek.
Thank you, Dr. Pradeep. I'm glad Dr. Neha Mishra could agree upon few things, which is individualize the antifungal therapy and also to risk stratify those patients and then take it forward. So, and then de-resuscitating the started therapy as well, as it was rightly said. So thanks for that, Dr. Neha Mishra. And a few things which I wanted to clarify upon. Like, for example, the positivity of patients who have tested positive for invasive candidemia per se. All of them were positive, of course, and the incidence was 6.7. But what we have left out with is the ones where the culture positivity is not going to be there. So what about those rest 50% where it has not grown per se, but the incidence will be higher? So per se, we would be looking at higher incidence rather than what was reported. That is number one. And then number two, looking at the context per se, yes, we do have higher bacterial infections. I'm not arguing against it, but when there is a high-risk patient is what I'm worried about. So risk stratification of a patient who is at a higher risk with all the available markers is what we are focused upon. So I'm not trying to change the context here. So the context is a person with fever who has been evaluated and there is no positivity from the bacterial side or there is no other focus is what the context is. So I totally agree, bacterial infections will be higher, but the context which we are debating about is a little bit different. And what about the intense study? The intense study harbors on preemptive therapy. It is not empirical therapy, it is a preemptive therapy, which is prior to going into all the risk factors that the patient has got, risk stratifying them, and then rather going for an empirical therapy. And I am not talking about a preemptive therapy here. And what do you think of the low in sepsis campaign per se? Surviving sepsis campaign is very explicit in saying the low risk group of patients where there is a low risk of fungal infections is when empirical therapy is to be avoided. It is not for patients who are at a high risk of fungal infections. So it's pretty much explicit. So I would rather take it in my favor that surviving sepsis campaign, as suggested, as previously, that empirical antifungal therapy should be there. And then culture, doing a culture prior to any kind of antimicrobials is our standard practice anyway. So that should not affect the diagnosis of invasive candidemia anyway. So that's one another point I just wanted to highlight upon. And then the risk factors, which was an interesting slide, that patients could be harboring multi-drug resistant bacteria still, and that could be one of the things. And just wanted to point out that particular slide conveniently not highlighting in yellow the Candida score, the candidial colonization. Those things are quite unique to that particular group of patients. So I think that slide is in my favor. Thank you.
So, totally, I agree with you, Dr. Vivekanandan. But the thing is, first of all, thank you for nice presentation, and thank you for being considerate in few things, and we actually agree upon few things. See, the thing is that I'm not against addition of antifungals, no. But problem is we forget to de-escalate, number one. Risk stratification is not a problem, but the problem is a lot of risks are similar. So I understand Candida colonization, but how many times do we have to wait for Candida colonization results as well, right? And to do that also we need 3 days. Might as well wait for the culture. Again, we are left with what? We are left with only other risk factors that I told, and which are very much similar to MDRO risk factors. So it becomes very confusing. I am sure you must be dealing with these kind of cases day in and out. It becomes very, very confusing to, okay, this gentleman has a whether he or she has a bacterial infection or whether he or she has a fungal infection. So I think it's not about addressing these things. Surrogate markers, for example. See, even if the patient is colonized with surrogate markers and we think that the results will come within a 3 hours time, 4 hours time, that can be positive otherwise also in a case where the patient is colonized. Then how will we distinguish? So distinguishing is very difficult. Hence, it should be individualized, case by case basis, should not be generalized, and we should not convey the message that, see, if the patient is not responding, then we should go ahead and add an antifungal. Another thing is regarding IDSA guidelines, regarding which you highlighted quite well, and regarding estimate guidelines, they are quite old. They have not been updated. I agree that Surviving Sepsis campaign has updated it, but then they earlier were emphasizing on addition of antifungals on everybody or where the fever is persisting, but now they also ask us to individualize and find out our patient of interest and then only add an antifungal. So again, the context is not being against it completely, but I think individualization is what we should be focusing upon. Intense trial, which you rightly spoke about, intense trial actually, when it happened, the definitions of preemptive and the definition of prophylactic empirical uses were different. And after that, there was a article they printed and said that this is few patients did fall into the group of prophylactic and lactic empirical use, and there also they did not see a benefit. So yes, it was a preemptive usage, which we are not talking about, but in the subsequent article they did mention the other statement as well. See, again, I would say that we are probably saying the same thing. We are saying that individualize and utilize, not to generalize the statement. Problem is that if we give such statements in very big platforms, the message that goes is that, okay, 3 days of fever, Dr. Vivekanathan said, we'll go ahead and add an antifungal now, 3 din ho gaya. So that should not go ahead and go forward. We should just make sure that we are not overusing or misusing it, and inadvertent use should be made less as far as possible. Yeah, thank you.
Thank you. So thank you, everyone. Vivek and Neha very well argued. I think you respected each other's domain and you acknowledged each other's points, and you had a reasonably good, moderate way of agreeing on certain things. So I think the take-home message, I just want to point out to the benefit of audience, I think there were 3 good trials that had happened. So Vivek very cleverly mentioned about fragility index and compared with NICE and the crash trial, but I'm sure he would agree the fragility index will be low if your number you have taken for the study is 260 in the empiricus. And if you increase this number in crash study, it is more than 10,000 or 15,000. The fragility index number looks higher. So it's all about number game, isn't it? And in fact, there were 3 very good trials in cancer patients or malignant patients. One came by the French group in 2009. One came from the German group in 2009. One came from Australian group in Lancet in 2013, where they really compared empiric versus preemptive in candidemia or in fungal infections, and they use advanced PCR techniques to try to confirm whether empiric usage was good enough or whether they should not have used. And in fact, interestingly, the German study did show that empirically just adding antifungals did increase the mortality in that particular. It was Herbert et al. And Australian study also did show there was no difference in adding empiric antifungal agent as opposed to starting with some evidence with molecular techniques. So the take-home message from me is, there is another good study from Hanjic et al. Where they said, I think in ICU, this is predominantly an ICU population. If patient is hemodynamically unstable, which Vivek, me, who really treat with, and then you have no reason for fever, patient is hypotensive, multi-organ. Obviously, we cannot wait. I'm sure every intensivist sitting here would agree that we cannot wait. We start antifungal and adhering to the sound principles of antifungal stewardship, which is emerging, which is evolving, which we need to embrace. Because antifungal stewardship also takes into cognizance the fungal prevalence in the institute that we guys are working. So taking that, I don't think there will be any arguments on that. But the argument comes in hemodynamically stable patient, where you have time to wait for your adjunctive test or molecular diagnostic test, which would possibly help you. And in the context that you both agreed upon, that possibly we could wait until you get the cultures, until you get the adjunct test, then make a decision. I think that would be reasonably acceptable is what I would think. And there is a study in Lancet in bacterial infections they are very clearly showed in hemodynamic stable, we don't need to jump the guns and start antibiotics. In fact, it showed increase in mortality where you have just started unnecessary antibiotics. Rather wait for the cultures and then rationalize it, outcomes were better. Possibly that was in bacterial infection. So we could take a cue from that and apply it to the fungal infection. And for all the audience here, adopting safe antimicrobial stewardship and antifungal stewardship and de-escalating and stopping when there is no evidence is the way to go. I was looking forward for you guys talking about molecular diagnostic because that is going to revolutionize the way we are looking at the fungal therapy, adopting PCR-based techniques, MALDI-TOF or fish test. So these are the tests that give us answers, and the turnaround time is very less now. And even speciation would be given by T2 Candida panel. It will tell you what species that we are dealing with. Maybe going forward, we should adopt more molecular diagnostics to rationalize antifungal initiation. And hemodynamic stable, we can definitely wait, would be my take-home message. In hemodynamic unstable, obviously we can go ahead and start and then adhere to your sound antifungal principles would be my summary statement. Quick comment from both of you, then we can close the session and hand over to Dr. Manjula.
I did have the last slide about molecular technology, but time was too much, so I kind of put the thank you slide. Yeah. But yes, I think MALDI-TOF is the way to go. And in case we are, but it's a costly test and every institution doesn't have it. So outsourcing it takes equally similar time right now, at least right now, for us to get the results. But eventually, once it becomes available for all the institutions, and so the turnaround time is only 2 to 3 hours. That makes it so much more simpler. We know the species right away on the same day. And we can just, do so many beautiful things with the antibiotics and antifungals once we have them. So I guess, yes, they are way to go. Now, not relying only on the biological, this biomarkers like beta-D-glucans and all alone is not the right thing to do. Probably individualize and then treat. That's the best way forward. And please prevent the inadvertent use of antimicrobials.
Yes, thank you. It was a very nice debate. I'm watching throughout and very nice debate. And Vivek Nathan very wisely taken all Neha's points in his favor. And Neha had to subdue because there's a big age gap. So I suggest Manjula ma'am, the people of at least 5 years difference should be allowed to debate, or else there's a senior junior bias in the debate.
Yeah,
there are so many things in favor of antifungals and against antifungals, but very nicely the speakers have put it forward. That was in a lighter sense.
Thank you, Dr. Jain. Vivek, quick comments. We can close the session. Hand over to Dr. Manjula.
Yeah, thank you, Dr. Pradeep. I think the molecular diagnostics, yes, that's a way forward. But unfortunately, within our context of Indian ICUs or any other critically ill patients across the country, I think we are short of cash and short of economy wise, we are at a lower level. So that makes a huge difference. So probably in the next few years to go, still.
Just to interrupt, Vivek, in fact, all those 3 studies that I quoted, they're shown curtailing the cost by adopting molecular diagnostics and not using unnecessary antifungals. All those 3 studies, which were done in Europe, have shown significant reduction in the cost. So that's the way possibly we should move. Over to you.
I agree. And the availability, I think if it can be across the board, then it will definitely make sense, and that will be the way forward. But in the next few years, maybe few ICUs which are in the periphery, I think probably will have to rely upon the use of empirical therapy. But again, coming to the same, what we agreed upon, that it has to be individualized, risk stratified, and then probably that will be the way forward for empirical therapy. Yeah, agreed.
Thank you, both of you. And over to Dr. Manjula to do the honors.
Thank you very much, sir, Dr. Vivek and Dr. Neha and Dr. Pradeep, sir. It was wonderful. And I'm sure all the delegates over here enjoyed this debate. And always pro-con debate is one of the most sought after and very popular in all our FeFCons. Thank you so much for all of you. Now,
fantastic debate, sir, and Madam Dr. Neha Mishra is really fantastic.
Sir, moving on to the last session of FeFCon, which is a panel discussion. So I have the pleasure of our panelist over here, Dr. Ashutosh Biswas from AIMS, Bhubaneswar. Dr. Anupam Prakash, he might join, or he's actually he's in a governing council meeting of API. So then Dr. Ramesh Agarwal and Dr. Shubha Lakshmi and our Dr. Jayant Panda sir will be having this panel discussion. Dr. Ramesh Agarwal, can you take over and conduct this session? You and Dr. Shubha Lakshmi. Over to you, sir.
Good afternoon, Dr. Manjula, once again, and warm welcome to all the panelists over here. Dr. Shubha Lakshmi, I think you will like to moderate the session, and I can be on behalf of Dr. Anupam if he joins. Nothing like that. Otherwise, I will take the questions.
Yeah.
Yes, sir, sure. And thank you, ma'am, for this invitation and this opportunity for this wonderful panel. So we have been learning about fever, typical and atypical, various type of fever with different causes since 2 days in this FeFCon. And just now also we have heard about just wonderful panel discussion on ICU, fever in ICU. So moving on to our next session, this session, as madam said, non-localizing fever. Do I give an antibiotic? This is the topic for this panel discussion. And we have expert with us, as ma'am already introduced, Dr. Ashutosh Biswas, Dr. Jayant K. Panda, Dr. Ramesh Agarwal, and Dr. Anupam sir, if he joins. So ma'am, we can have the slides.
Yeah, I will share, ma'am.
Yeah. So various fevers we have just seen in 2 days. Non-localizing fever, what we understand, what we have to learn about, or how we have to go about it. This will be discussed in our panel, and our expert will be telling us about this. So first question, can we have the slide? So first question I would like to ask to Dr. Ashutosh Biswas sir. Sir, would you please tell us what does one understand by this non-localizing fever, or how does one define this non-localizing fever? Sir, please unmute yourself, sir. Dr. Ashutosh, sir. Sir, unmute yourself. Yeah. Sir, you are visible, but...
Yeah, I think there is some problem in the connection.
Yes.
So thank you very much,
Yes.
Fever Foundation. I would like to thank the organizers, especially Dr. for giving the opportunity in the very special panel discussions. So to begin with that, it's very important topic, that localization of the fever of antibiotic. This is a very important thing. Most of the time, what we think that fever causes, as we know, causes of fever mostly due to infectious and non-infectious cause. Now, in between the prescription by the doctors and using the antibiotic and then localization, what is the importance of it? Localization, and why you want to look for localizing the fever, and what are the approaches to localize, and how does it help in prescribing the antibiotic? So most of the time, can you really localize the fever when somebody is coming with the fever? Is it possible that we can really localize and to know before prescribing any antibiotic? So how to approach this localization of fever? Basically, we understand the clinical approach, and then if not, we fail to localize it, then we go for the laboratory investigations. There are various ways to know: lab, molecular diagnostic, or maybe histopath, or several other diagnostic procedures we follow to localize, and then finally, also most of the time we go for imaging. So basically, these are the three ways we approach. Now, most of the time, the use of antibiotic, burden of use of antibiotic is by clinical acumen. Most of the time, we try to misuse the antibiotic. Our habit, prescription habit, or the behavior of the physicians mostly at this moment we have discussed over these 2 days is really we are abusing the antibiotic, and we see the now emerging of resistance of the antibiotics. So the rational use has already been discussed in this forum for last 2 days in antibiotic seminar and all. So we have to really how to change our behavior. So not only the physician's behavior, is the behavior of the society, is the behavior of the pharmacy that where you are getting this antibiotic. So how to curtail, how to curb this habit and the use of antibiotic, that's the most important thing. Now, among the doctors, when somebody is coming with the fever, so localization is a very important, that is the hospital setting or maybe as an OPD setting, than sometimes in the clinic. So that we have to understand. So how really, if somebody is coming with a fever, now it is time consuming to localize by laboratory investigation and imaging technique, getting an X-ray done and the ultrasound done and CT scan done and something. So by the time you get this all investigations to confirm, to get the evidence, many 2-3 days or maybe more than that you already pass. So can you stop using antibiotic, and what are the really challenges that we face? So clinical localization is a very important thing. When somebody is coming with a fever, something, so we try to localize with the respiratory tract infection. So whether along with the respiratory tract infection, if it is a respiratory tract infection, so what are the other symptoms and signs? So those are the very important to localize really. So there are other organs that we know so we try to localize that by the symptoms and signs. So we have to particularly have a patience to understand the organ involvement and the tissue, because the various organisms, they have their different nature of damaging involving the tissues. So fever is what is really the immune response, the immunological response through the metabolic cellular activity, and this is that we get the fever maybe through the inflammatory process of infectious cause or non-infectious cause. So it's not that fever is the antibiotic they are going to use, and there are all we know that fungus there and viral there, and antibiotic particularly is for against the bacterial infection. So that is the most important thing. So if we want to localize somewhere the bacterial infection to use for getting a scope or a window for using the antibiotic. So what percentage of that patient with coming fever that we could really localize it? If we fail, so can you use as a empirical therapy? So basically, point is we should try, definitely there is a route of entry of all the organisms to cause to enter in your body. So through the route, naturally there is a route of entry, and this organism try to cause the nuisance at the root, and then probably if it is spreading throughout the body, then can cause a systemic, and you may not really catch it that there is a local infection, local cellulitis or local inflammatory process going on. So that is what the sign of localization of the fever.
Okay, sir.
And
sir, we will be coming back with sir, we will be coming back with other questions, because I think we have, yeah, sir. Thank you very much, sir. Okay. So what sir has told, that if we have no signs of localization, if we in a patient, if we are not getting any sign or clinical symptom or even after investigation, then we call it as a non-localizing fever. So now moving on to the next question, we have with us Dr. Jayant Panda, sir. He is professor and head Department of Medicine of SCB Medical College, Cuttack. Welcome you, sir. And for you, we have question. Can we have the next slide, please? So, sir, what are the different or common causes of non-localizing fever, and do they have or do they vary from region to region, different region to region?
Yeah, very pertinent question, Shivalakshmi. The commonest cause that we get fever in our locality, which are tropical areas, depends on the environmental situation. As we already know, in the hot summer, anybody coming with fever, we think of heat stroke. We don't think of an infection. And in a lady with a different polyarthralgia, if it comes, we think of a immunological cause like rheumatoid arthritis, like lupus, like progressive systemic sclerosis. In an elderly patient who comes with a continued fever, we think of a malignancy sitting somewhere. In a young person with a very high leukocyte and without any localization, can be a patient of adult onset Still's disease. So there are so many varied regions, starting from malignancies to immunological causes. I have seen hundreds of patients with a metabolic cause like hyperthyroid state presenting with POO, and we have worked out with a thyroid function test and knew the cause of fever. And they have received tons of antibiotic in the peripheral hospital with a different consultant who have never cared to diagnose the patient. So depending on the locality, depending on the age of the patient, depending on the environmental condition, these cause of fever are different. And when we approach a patient, we have to remember that this patient can have a cause which may not be infection altogether. So in this context, my argument will be in a patient who is not having a localizing cause, we should not jump to an antibiotic immediately. That's what is contributing towards the antibiotic resistance. And then even a quack, even a medicine shopkeeper is daring to start antibiotic. And you know, during COVID time, how many people started with azithromycin and the symptomatic medicines around. So we can diagnose non-localizing fevers depending on their presentation, age group, environmental locality, and the investigation should should include the panel, including the immunological panel, including the metabolic panel, including the panel to rule out the other causes like a malignancy or like a environmental condition. So it's not all about infection. As Dr. Ashutosh Biswas has told, we have to think of an immunological response which is causing fever. So jumping to antibiotic doesn't help. That's a practitioner approach. Anybody comes giving an antibiotic, giving a PPI, giving an antibiotic, I'm not in favor of that. Rather, you should take a careful history, investigate the different related panels, and once you get some clue, maybe you have a leukocytosis, maybe you have a respiratory shines in the form of bronchial breath sound, crepitations, maybe if you have a skin and soft tissue lesion with pus coming out, there you can send a culture sensitivity and plan antibiotic.
Yes, sir. Thank you. Thank you very much, sir. For investigation, we will be moving on to the next question. But yes, as you said, antibiotic should not be the choice without thinking about the cause or without getting the cause. And very rightly said that region, the cause may or it varies from region to region. Like you said, in heat stroke, where it is very hot and humid, we should think of this cause first. And if any fungal infection, if in urban or rural areas where the patient is coming from, we have to think about that also. So now moving on to the next question, we have with us Dr. Yeah. So moving on to next question, we have with us Dr. Ramesh Agarwal, sir. He is Professor of Medicine from Lady Hardinge Medical College. Welcome you, sir. And question for you, or I would like to know, how can we diagnose these non-localizing fevers? And what investigation one should do, and when we should be doing these investigations?
Thank you, Dr. Shubhalakshmi. Dr. Shubhalakshmi, already Dr. Ashutosh and Dr. Panda sir has told that fever is not entirely about infections. It is both infectious and non-infectious etiology what we have to look at. Particularly for the non-infectious as the autoimmune diseases, the malignancies, and of course the drugs which can cause fever, which do not respond to your usual treatment. So one thing I would like to say is that already we are in a soup, like we are not able to clinically diagnose a patient. And we should not take an approach which again will which will land us in some more trouble. Like the approach should be somewhat a step ladder type of a approach, that we should go from below upwards rather than jumping from the roof and again landing nowhere. So for this, like basic investigations, a hemogram and LFT, KFT should be ordered first. And that's the key message which we would like to give from this platform to our residents and to the august audience which are here. Like a simple hemogram can give you a vital clue. For example, if a patient comes to us with a TLC of 13,000, so maybe an immature physician may ignore it or say that it might be somewhat a little infection and start antibiotics at one go, as Dr. Panda was saying. But looking at more say carefully or the DLC, it may show you a majority of the lymphocytes which are there and not neutrophils. So where does the role of antibiotics come there, which has got a 60% of lymphocytosis in a, say, a TLC of 13,000 to 15,000? That should make you more suspicious of some other causes, maybe some malignancy which is going on or some autoimmune disorder which is going on. Of course, there can be variation between lymphocytosis and lymphopenia. Similarly, investigation in hemogram of an eosinophil, so that may give you vital clue whether there is some parasitic infection or some sort of say a vasculitis or a lymphoma which is there, or presence of abnormal cells. So the message here is a careful hemogram with a peripheral smear should be the first approach when we are hunting for something which we do not know. Then, of course, ESR and CRP are there. They are non-specific, but if we really see that very high levels of ESR, they still are relevant for diagnosing tuberculosis. So they give you more information that probably this patient is having some chronic systemic disease, maybe in the form of a tuberculosis or some underlying brucellosis or like that. Then LFT, KFT, of course, are non-specific. They may only help you in verifying a patient of icteric hepatitis or hepatitis that this patient has jaundice. As Dr. Panda has said, that you may miss hyperthyroidism, which is a common cause of fever. So getting into, of course, clinically, if you're suspecting hyperthyroidism and investigating with the TSH, that may help you free T3 or free T4 along with that. Thyroiditis may again present to you with fever. Coming to the serum ferritin, again, serum ferritin has a great hype in COVID days, and it's an inflammatory marker for undiagnosed fevers where we are not able to localize. Say a patient is having a fever of more than 7 to 10 days and where you have used your usual antibiotics. So that may give you a vital clue that this patient may be having a hemophagocytic syndrome. Special investigations, then you may order. And so keeping in mind these things, that you should plan your investigation. But again, serum ferritin, I'll give you an example. A patient who was having fever and NS1 positive on day 2 or 3 had also a low hemoglobin, say of 11. His physician ordered a serum ferritin just to know whether this patient is having iron deficiency anemia or not. And the ferritin came to be about more than 3,000. Now, this is a very tricky situation, and we as physicians should be very responsible when we are ordering for investigations. They may actually land us in trouble because we do not have an answer. It's an inflammatory marker, but then the relatives will be after you that this investigation has come positive. So this is one message which we would like to share. Of course, chronic infections like Shubhalakshmi, tuberculosis, HIV, scab, lepto, brucellola, chlamydia, syphilis, they all have got their specific investigations, and if we are not able to find in routine investigations, then they should be screened for. A basic urine examination should not be missed. Somewhat in a say a microhematuria or in the form of a pus cell that may give you a vital clue, or sometimes an asymptomatic bacteriuria or say pyuria. So that also gives you a clue that probably we are suffering, the patient may be suffering from some atypical infection. Similarly, autoimmune profile and screening for malignancy is one thing. Stopping the antibiotics, looking for the other causes may give you a clue that drugs may be responsible for your localizing or your undiagnosed fevers. Then very important investigations, X-ray, CT scans, and MRIs and PET-CT. They have got their own role when you finish off with your routine investigations, but do not switch over to the radiological investigation first and doing the hematological investigations first. Otherwise, it will again lead you into a trouble. Echocardiography sometimes helps when infective endocarditis is suspected. Again, good clinical experience, good level of suspicion is necessary for diagnosing these patients. Then bone marrow and bone marrow biopsy are two investigations which, at least in a tertiary care hospital, we should be coming forward to investigate the patients of fever where we are not able to localize these patients. Again, having said all this, then it is very important to remember, Dr. Shubha, that we should think of common diseases first when we are actually looking for diagnosing a case, rather than looking for the rare diseases. Rare diseases are rarely correct. So that's all from my side.
Thank you very much, sir. So very rightly said and very crisp message that we should go from basics towards the specific investigations, and common diseases should be thought of first, should be investigated first, and then should be going towards the rare diseases, which we can think of in that clinical scenario. Moving on to our next question to Dr. Ashutosh, sir. Sir, once we are knowing, or once we have read that what this definition is and what can be different causes, so what are the treatment options available, and do antibiotic have any role in this? We have been talking about this topic.
As we discussed that, for localization of the fever, now, even though we localize in the terms of inflammatory, response, sometimes as that if we localize to, suppose, arthritis, as we know, the rheumatoid arthritis or different other to joint inflammation. Now, whether infective, the swelling and the response, all the inflammation like your infection and non-infectious causes. We need to still go further for getting the etiology of infection, like the bacterial infection. So there are several ways we need to really go. We should not jump on. Just if we fail to localize, we should not go for using the antibiotics. Still, we should use our different ways to know clinical and laboratory investigations and imaging techniques. We have that. So to establish the evidence, so the evidence-based practice. So we need to have some clue for using the antibiotic. We cannot use just antibiotic based on the fever. Thank you.
Thank you, sir. So very clear message that antibiotic is to be used, but not in the first instance. It can be used, but not in the first, that we are not getting the cause of the fever and we jump upon using the antibiotic. That is not at all correct. We should first investigate. We should try to find out the cause as far as possible. Then we should move upon according to the individual scenario. So thank you, sir. Now moving on to our next question with what antibiotic cover atypical infection, and what are the causes of non-localizing fever? This is for Dr. Jayant Panda, sir. Would you like to answer this, sir?
Yes. We know there are many atypical infections, as Dr. Agrawal has already noted down. At times, we can get brucellosis. We here in eastern part, we get a lot of cases of scrub typhus. So many people come with a continued fever and even multi-organ failure. And on testing, we get scrub typhus, which responds very well to doxycycline. And when we think of a mycoplasma, maybe a respiratory infection, the macrolides are amazing. And when you think of an anaerobic infection, again, the drugs covering anaerobic infections, they do wonders. And then just we are discussing about the fungal infections. We're thinking of which are not classical, the atypical tuberculosis, the non-mycobacterial infections, and then also the infections which we don't see usually, but if we can locate, it will respond. So here many come under the classification of pyrexia for no reason. And in a non-localizing fever, we have to target them. Once the fever is 2-3 weeks and not worked out, we have to target that, like doing a blood culture to locate the bacterial endocarditis in a patient with the cardiac lesion and echocardiographic finding of the evidence of subacute bacterial endocarditis. Similarly, in a patient who has multiple skin lesions, maybe bone lesions with a deep sinuses and osteomyelitis, not responding for a long time, and then especially in a immunocompromised host like diabetic, we see a lot of foot ulcers, the diabetic foot who don't respond, and many times we have got pseudomonas there. And even recurrent urinary tract infection is troublesome in elderly who have retention of the urine, obstructive uropathy, and especially if they are on drugs like SGLT2 inhibitor, it becomes very chronic, and we don't control the infections. So there who don't respond in the first week and come with the complications, we have to target the typical infections, and depending on the probable clinical site, we have to locate the organism and the agents accordingly. Then only we can get a clinical success. Of course, the biopsy and the laboratory evaluation of the organism is a must.
Yes, sir. So the cause should be looked after. It should be looked, it should be tried enough. We should get the cause of the infection or cause of the fever, maybe infective or non-infective. And as sir said, atypical infections like brucellosis, scrub, they are very, nowadays it is become very common because we are aware, we are getting it more frequently. So it should be taken care of. So thank you, sir. Now moving to our last question of this panel. It is to Dr. Ramesh Agarwal, sir. So what governs the choice of antibiotic in such situation and in case of non-localizing fever?
Okay, Dr. Shubha, again, now see, this is a double-edged sword. Like as what we have been discussing, like using an antibiotic at first go, should we use or shouldn't we use? And then whether to stop the antibiotic or to further escalate the antibiotic. So this is the whole basically scenario where we have to decide. Now, again, I would like to emphasize that before we start the treatment, we know that we are treating the patient and not looking after. And the second point is that the diagnosis or the actually looking after the disease is the second thing. So the treatment of the patient is a primary responsibility. And especially we have to triage that whether this patient is severely or an acutely ill patient and require and probably is he or that patient is immunocompromised or not? Is that patient having a history of some splenectomy, or is the patient on a hemodialysis? Is that patient on extreme age groups like a pediatric or a geriatric patient? So considering these scenarios, then we should take a decision, and it cannot be a hard fast rule that we are not going to start the treatment for this patient. Of course, we all are sensitive physicians, and this 4 or 5 things that should come as a preliminary thing before we take a decision. Now, having considered these extremes of red flags that the patient may or may not have, then the second thing in a patient where we are not able to localize any signs and symptoms and where we wish to initiate is the presence of hypotension, septicemia, or compromise of the vital functions. A patient comes to us with a compromised vitals with a very low blood pressure and a tachycardia, and you can see that there is a marked leukocytosis with neutrophilia and toxic granules and all that scenarios. So instead of just waiting and to localize, there is always an option to go for an antibiotics. Similarly, if a patient comes to say again with confusion and altered sensorium, and you have got very little time to investigate the patient, so an empirical antibiotics can be started. So now coming to the question that once we have decided that yes, this patient needs an antibiotic at first hand. So the question is what actually to cover. So the coverage should include both the gram-positive and the gram-negative bacteria. And from gram-negative bacteria, we can always use fluoroquinones like ciprofloxacin, ceftazidime as for Pseudomonas, the third generation cephalosporins, carbapenems. These are for gram-negative. For gram-positive, we can use vancomycin, daptomycin, linezolid, or quinipristin. So this all we know. So a cocktail of say an initial antibiotics that will probably help the patient to recover, and then of course we can escalate or get down to our initial empirical therapy. The one thing which Dr. Panda has already said, that some antibiotics which are for atypical infections like doxy and azithro, say they may be used keeping in your initial suspicion on your clinical examination. Say, for example, in his part of the country, scrub is very common. So there is no harm in adding that to the empirical regimen when you see that the patient is really toxic, or you may find some clinical evidence that this patient may be having from the geographical presence, or say a recent animal bite or recent history to the forest. So these all scenarios may decide in your empirical therapy. So initial judgment will be based on the clinical signs and symptoms, on the extremes of the red flags which I have mentioned, and a broad spectrum of antibiotics, including both the gram-negative, gram-positive, and coverage of atypical organism will suffice the initial treatment. Yes, ma'am.
Yeah, thank you, sir. So what we are doing, we have to start the antibiotic once we have found out the cause, or we are closer to the DD. If not, and patient is sick, we have to go for a broader spectrum antibiotic to cover all. So if we are not having the cause of fever, if we are not able to localize the localize any finding of the fever, we have to try to find out the cause, try to localize the cause of fever. If at all it is not possible, we have to go about with the investigation, that too from the basic to the specific investigations. And then if we are not able to still we are not able to find any cause, we can individualize the treatment. We have to start or not to start the antibiotic. This is very it depends upon the individual condition of the patient, the clinical presentation, the vital signs, or the red flag sign. If they are all present, then we have to start the antibiotic in favor of the patient, so that we are not losing the time in between. So we can go with the antibiotics, that too a broad spectrum antibiotic covering gram positive as well as gram negative. And as sir also told, that atypical coverage with doxycycline can be started if we are suspecting any atypical organism. So thank you all the panelists for covering the topic very nicely. And I think Dr. Anupam Prakash sir is with us. So final remark from him would be great. Sir, if you are there, please give your remarks, sir.
Thank you, Dr. Shubhlakshmi. Although there is no need, everybody has done his and her job very nicely, and you have also moderated very well. And I'm extremely sorry for not being able to join, but I was passing through the security check at the airport, and Dr. Panda is soon to join here. But thank you so much. And I think fever managing is not an easy thing, and 2 days of conference, and this panel has alluded to the thing that we have to keep our horizon wide and try to understand what are the problems that we have, and not only think of infectious diseases, but also think of less common infectious diseases, atypical infections, and also diseases which are not infective that can also lead to fever presentations. Well, I think that is a wonderful discussion. Dr. Ashutosh, Dr. Panda, Dr. Ramesh, and yourself, thank you so much, and thank you Microlab and FeFCon.
Thank you very much, sir. And thank you all the panelists, Dr. Jain sir, Dr. Ramesh sir, and Dr. Ashutosh sir. Thank you very much. And thank you, Anupam sir, for your final remarks. Over to you, Manjula ma'am.
Thank you. Thank you very much for an excellent discussion to Dr. Jain sir and Dr. Ramesh Agarwal and our Dr. Ashutosh Biswas sir, and you, ma'am, moderating it so well. Thank you so much. And summarizing by Dr. Anupam Prakash. And that was the last question session, and that was actually most awaited question session as well. So before we will be starting this is the last session. With the permission of our advisory board members, I'm going to close the FeFCon. Sir Anupam, sir, you are there on the platform. Can you just give the closing remark for a minute so that we can close the session, sir, from the organizing committee? Is it possible to speak, sir?
Yes, I am there. Actually, the network goes in between, but yes, I am here. I am still waiting. Although boarding had started, but I will still give 2 minutes. Okay. Fever Foundation has been through its commitment to organize this fever awareness, which is very, very important. And in India, among tropical diseases, fever and its manifestation, diseases with manifesting as
Very dynamic presentation, like Dr. Anupam Prakash is on the move.
It had a wide panorama of presentations, not only lectures, but panels, debates, and also we on fever. And these are important things. And I must say that every faculty, every organizing committee member, every onboard person who has participated, and the Fever Foundation Advisory Board members, as well as the micro lab people who have been committed to this cause, they have done excellently well. Well, thank you so much on behalf of the advisory board. And I think, thank you, Mr. Jairaj, Mr. Praveen, Mr.
Thank you, sir. Thank you very much.
Thank you so much.
Thank you, sir.
Thank you. Thank you very much, sir, really. And
Madam Dr. Ravi.
Dr. Ravi, sir, please speak, sir.
Madam, thank you. Thank you. Wonderful sessions throughout the day. From morning, I've just been sitting and listening throughout the day. We had a very good CPC. We had very good interactive sessions now in the last session also. And we had speakers. Thank you all for your wonderful sessions, which we had throughout the day. And yesterday, the quiz program also. I think thanks Microlab and FeFCon, all the excellent members, the resource persons. On behalf of the committee, I thank wholeheartedly the entire resource persons and microlabs for this wonderful conference. Thank you.
Thank you very much, sir. Thank you very much, sir. Thank you, everyone. So I ask Mr. N.K. Raja to give the valedictory note, please. Over to Mr. Raja.
Good evening, august audience. It's been a very fascinating and engaging 2 days of academic feast. It's my privilege to take few minutes to thank each and every individual who has been part of this grand journey of 5th Annual National Conference of Fever Foundation of India, FeFCon 2022, a virtual conference on the theme Fever, Look, Analyze, Manage. Let me take this opportunity to thank the Chief Patron, Dr. M. Maya, Fever Foundation of India, Bangalore, and a former professor of medicine, Karnataka Medical Service. I also thank the organizing chairpersons, Dr. T.S. Ravindra, Dr. A. Muruganathan, Dr. Jagdish Chinnappa, and Dr. Manjula, who had played a pivotal role in arranging the faculties for the FeFCon 2022. It's equally important to thank the Fever Foundation Advisory Board members who had been the backbone in ensuring the success of this mega event. It has been a great honor to have Sri G.C. Surana oration delivered by Dr. Jagdish Chinnappa, Consultant Child Specialist, Manipal Hospital, as well as the Chairman Scientific Committee, Fever Foundation. We wholeheartedly thank you, sir. I would also like to thank Dr. Manjula S., Convener, Fever Foundation of India, and Mr. Jairaj G., Organizing Secretary, and as our entire team Micro Labs, who has put all the efforts in conceptualizing, organizing, and coordinating the wonderful event to bring the best for medical fraternity in fever management. I would also like to thank Team RX Events for seamless arrangement and making the audience engaged with their innovative activities and add flavor to the overall virtual conference. Any event can't be grand without the contribution of the audience. I would like to express our big thanks to all the doctors for their wholehearted participation in making FeFCon 2022 a truly incredible and memorable virtual event with an estimated 35,000 delegates. A special thanks to all PGs in medicine and pediatrics for their participation in national level quiz competition. As the saying goes, knowledge is not just power, but the implementation of knowledge is power. We hope Fever Foundation, initiated by Microlabs Limited, has fulfilled the expectations of all the delegates in this scientific deliberations and help implementation of knowledge gained. Needless to mention, we would continue to raise our bars in future. Thank you once again for sparing your valuable time. Namaskar.
Thank you very much, Mr. Raja. And so with the permission of Organizing Secretary, Mr. Jairaj, sir, you would like to say anything? Shall we close the session?
Absolutely. It's been an overwhelming contribution from everyone involved in FeFCon. Of course, starting from the ad board member and the convener, yourself and your team, and our marketing team and the sales team, everybody, and the RX events. They have been working as though they have been possessed by the phenomenon called FeFCon 22. the speakers who all contributed. I mean, they added a high value addition to this conference. I mean, I don't know whom to mention and whom to leave. Everyone involved in this have done a great job. A big congratulations and a big thank you for all. Thank you very much.
Yeah, thank you very much to all our faculty and the delegates, our colleagues, friends, and my teammates, and all our Mr. Jairaj, Mr. Raja, Praveen, Abira, Yash, and RX team, everyone from my side and the faculty. And special thank to Madam is still there, Dr. Subbalakshmi Mahesh, Sir Ramesh Agarwal. We really troubled them a lot, actually. Thank you so much, sir, for what.
Yeah, it's our pleasure, ma'am.
Yeah. So thank you. RX Yvette, can you play the video, please?
With this, we've come to the end of FeFCon 2022. I'm sure that you enjoyed the 2 days as much as I enjoyed hosting it. Thank you so much, everyone, for joining us in this journey of learning and growing and interacting. We will see you in FeFCon 2023. Please stay healthy, stay safe, take care.